A pleasant good morning to all the ladies and gentlemen gathered here. On behalf of Tapicon 2022, it gives me immense pleasure in welcoming you all for the second day of this great Knowledge Fest. I would like to start the session of this day by invoking the Almighty's blessings for the smooth conduct and grand success of this event.
As a great poet Thiruvalluvar said, இலர் பலராகிய காரணம் நோட்பார் சிலர் பலர் நோலாதவர். The deeper meaning of this kural is only few people spend their time and energy to learn and improve themselves in their respective fields. Only they will sustain the test of time and their fame will remain forever. In this note, let's utilize this Tapicon to get updated and not outdated.
So the first topic of today's session is related to nephrology. I invited Dr. M. Shivashankaran sir and Dr. Arati Kannan sir to chair this session to kindly come onto the dais.
I am so sorry for the mistake. Dr. Arti is not here. Dr. Balamurugan has kindly consented to be the co-chair. He will start, sir. He will join us.
The first topic of the day is refusing dialysis. What next? I request Dr. P. Giri sir to come over to the dais to deliver a speech.
Giri. Good morning to everyone, and I welcome all speakers who is going to speak about nephrology. First topic, refusing dialysis, what next? Is going to talk Dr. Giri, who is my close friend. My association with him is very long. He is a chief consultant and is a first nephrologist in Trichy. And qualification is the best oral paper presentation in gold medal and best oral presentation in Indian Society of Nuclear Medicine and Secretary Nephrology Association Tamil Nadu and Puducherry. And books and articles he had microRNA gene expression omnibus number GAC896999 and gene sequence submission and 16S RNA sequence accession number applied 58 and also contributed review articles in many national journals. Now the topic is refusing dialysis. What next? Over to Dr. Giri.
Good morning, one and all. And I thank the organizers, the APA Trichy, for giving me this opportunity and for the chairperson for giving the nice words and introduction. Refusing dialysis, what next? This particular topic, we pertain it to a person who is having a chronic kidney disease and he is coming into a stage that he requires dialysis. At that given juncture, he says, I'm not willing for dialysis. What else can we do? That will be the area in which this particular topic will be going on. Well known as chronic kidney disease is a major killer disease with increasing incidence of diabetes and the elderly population. We have more and more elderly population. More patients end up in chronic kidney disease. One word to remember is, after the age of 35, there is a fall of 1 ml per minute per 1.73 meter square of GFR for every normal person. Suppose a person comes to the age of 65, 30 GFR is lost and the baseline GFR for that individual is only 70. However, when you have a GFR of less than 50, you come into the qualification of that you are having a lower GFR and you are forming into one of the stages of chronic kidney disease. Any elderly population also per se will have a natural history of falling GFR resulting in a chronic kidney disease. Conservative management postpones the onset of dialysis for a short period of time, and however, this may not extend on for a long period. Ultimately, there is a cardiac event generally. The chronic kidney disease patients are more prone for cardiac events, and their incidence of cardiac events go up to about 30 to 40 times. So, not all patients who are on follow up with chronic kidney disease end up requiring dialysis. So, some of them who do not have some cardiac event are those that require dialysis. So, what percentage of these eligible patients are dialyzed in India? The Indian study recently published, out of the 100 CKD population, suppose you take them, 20 to 30% come for medical or conservative management. They come on to it. Only 1/3 come to it. Of these, dialysis patient population is about 2 to 5% of all CKD population, which end up in dialysis, as reported by the Global Perspective Kidney in October 2020. Now, coming to what are the indications for dialysis? Now that we have seen a patient, he is coming having chronic kidney disease, when should you offer him this dialysis support? One, whenever they have a severe uremia, that is a blood urea of more than 200 or a serum creatinine of more than 10, when we say they are uremic. But there are other classifications for uremia, we'll come back. Whenever you have features of volume overload, whenever you have a difficulty in breathing, severe hypertension, not able to lie down, continuous cough, are some of the features of volume overload. Whenever you have a uremic pruritus and the pruritus is not recovering well, whenever you have a severe anemia and the anemia with the normal appropriate medications for that person, we are not able to correct it. Whenever we have severe hypertension, the hypertension we mean a blood pressure of around 200 by 120 on more than 3 drugs, and they are not able to control their blood pressure well adequately, are this group which we classify as severe hypertension. Severe anasarca, this is another group where we have severe anasarca. In the presence of adequate diuretics also, they are not able to clear this anasarca and end up in severe hypertension or in features of volume overload. Hyperkalemia is another important indication, especially when the potassium is more than 5.5. With adequate nutritional diet counseling, they are not able to recover. And last but not the least, the classification is a eGFR less than 10. That is, we always calculate the GFR according to the creatinine, according to the age and body weight. We get the eGFR calculation, and anybody less than 10 as a eGFR, we tell them you have gone into the stage requiring dialysis support. This will be some of our indications for dialysis. So what next? Now that you have a patient, our approach will be only clinical. It will not be theoretical, so it will be only clinical. So what next? First, we'll come to the history taking. Why should you have this history? Is you classify this population of patients who has come for dialysis into, you can wait for some time, give some therapy, you can't wait, offer dialysis. That is why we need this. The history taking is duration of diabetes and hypertension. How long is it? Suppose a person says, I am a diabetic for 15 or 20 years. I am a hypertensive for more than 10 years. These are the group that are already gone in for a chronic kidney disease. Conservative management may not be helpful. However, if a patient says, I'm a diabetic for 6 months, hypertension I have noticed only for the past 3 months or 4 months, your chances of coming out with some reversibility are very high. Next, the important history taking is continuation of medication history. Are you taking your medications properly? Are you continuing it regularly? Or has there been a recent stoppage of drugs due to various causes? It can be due to financial reasons. It can be due to that the medicines have stopped. It can be due to rain or something. Any reason for that. If you have a stoppage of drugs, you have a reversible element. So you can have this amount of conservative management. Recent intake of non-vegetarian diet, this is very, very important. Whenever they give a history of non-vegetarian diet intake, the urea and the creatinine numerical numbers rise. Suppose a previous person's numbers are 80 blood urea, stable, and he goes for a non-vegetarian diet and he comes back, the next result would be 180. when the urea, creatine, the previous value is about 5. After a non-vegetarian diet, the creatine would be 9. So we will shift a person who is stable into a person requiring dialysis with this one episode in a matter of 2 to 3 days. This is always accompanied by an alcohol intake. Alcohol intake with non-vegetarian diet tend to push you into a severe uremic phase. A recent history of fever, which is very, very vital. Common is this viral fever, and majority of these viral patients, they end up requiring a very high levels of urea. The patient would have been very stable with a creatine of around 5 and a urea of around 80 or 90. One episode of viral fever for 3 days, the next result will be 190 or 200 of blood urea and a creatine of 9, and they'll be very symptomatic. So episodes of fever is very important. Last but not the least, in this presence of fever, they tend to get a OTC product. They tend to get a fever or a set matare. That is what they always say. They go to the pharmacy and then collect the tablets, they take it, and this results in an NSAID. The NSAIDs produce 3 things. 1, it shoots up your blood pressure. So the next blood pressure would be 220, 140, even on drugs. 2, there will be severe volume overload in a matter of 24 hours, and the rise of urea creatine will be so high, requiring towards dialysis. Last history is whenever you come them, last time you would have told them, see your EGFR is around 22. You may need dialysis after about a year or 2. The man says, okay, this man is not giving me relief. Let me go to somebody else. They always tend to have a native drug intake. And the native drugs currently has been proved by the Department of Nephrology, MMC, that when you take certain native drugs, they contain mercury, and the mercury produces membranous nephropathy, and this can result in chronic kidney disease, renal failure, the recent publication in 2022. So this is one important step which it can produce worsening of a stable patient with CKD. So clinically, what should you do? Suppose a patient has come, now that you have asked for certain history, what can you do clinically? The clinical examination, look for evidence of pedal edema and a sacral edema, which is very vital. Let me tell you why. Next, we have a raised JVP. Look for that. In addition, look for a hepatojugular reflex. Whenever you don't have a raised JVP, this points towards a volume overload. Look for any basal crepitation. And last but not the least, check the blood pressure yourself. You check the blood pressure, don't believe in your OP patient, or you select these patients, those patients who are in volume overload, those patients who say that I'm not able to lie down, those patients who says I have a breathing difficulty, you check the blood pressure, one or both the hands, you will be wiser whether to treat or not to treat. This is what I wanted to point out. This is what classically is called a pitting edema. That is classical what is called as no edema. The differentiation is whenever you don't have an edema, this commonly classifies into a person who has minimal hypertension, 1 plus proteinuria, good amount of urine output. They will be uremic. Uremic means they have a raised urea and a creatine. They'll be asymptomatic. However, if you have this amount of pedal edema, they classify into the common thing of diabetic nephropathy or a chronic glomerular nephritis, where they will have 3 plus or 4 plus proteinuria. They'll have a severe hypertension. They have a urinary albumin of 4 plus. They are symptomatic of uremia. Even with a urea of 100, creatinine of 5, sir, I'm taking only 1 idli. This will be the symptoms that they start very early. However, if it is a tubular interstitial, the symptomatic therapy helpful. They don't become of uremic symptoms very early. So this classification is important. So what to do as an investigation now that the patient you have gone for a history examination, all the investigations try to repeat. Majority of the time there can be some fallacies. So repeat these investigations, you'll be wiser. Ask for a CBC for anemia, urea creatine, repeat whether they are all right, worse or better. Electrolytes, very important, including sodium and potassium. ABG is important for bicarb because our normal serum bicarbonate estimated is not accurate. So always believe your ABG bicarb, blood sugars. These are completion of calcium phosphorus alkaline phosphatase, LFT urine routine, chest X-ray for pulmonary edema, pleural effusion, and an ultrasound to reconfirm whether the kidneys are contracted or a normal size kidney or a stones or any other reversible factor. So what next? So you have seen this patient, you ask for an history, you ask for an examination, you decide on certain therapy. The first therapy is if the blood pressure is more than 160/100, what we can do is start an antihypertensive drugs if they are not already on. We prefer a calcium channel blockers like amlodipine, cilindapine, or nifedipine according to the blood pressure control. We have to use a beta blocker like cardioselective, like nebivolol, bisoprolol. We have, if they are still not getting under control, we use alpha blockers. Centrally acting drugs can be used like minoxidil, and vasodilators are there. These are the armamentarium. We do not add here AC or ARB in an established where they have a creatine more than 5. We are worried on using it. So AC and ARB won't be in our list, will be the other list here. One small thing is correction of acidosis. That is what I just want to highlight. The deficit of bicarb is volume of distribution over a targeted bicarb. The volume of distribution is 0.4 into 2.4 by bicarbonate. And body weight, suppose you take it 60 and a bicarb is 10, the volume of distribution is 38.4, and the deficit 38.4 into 15 is 576 millimoles. So what you do is 25% of the deficit is replaced in 1 hour, 25% in 24 hours, 50% of the deficit in 24 hours. That is, we normally have 8.4% bicarbonate solution. And this 8.4 bicarbonate solution contains 1 millimole of sodium and 1 millimole of bicarbonate. So we need to replace, suppose how much ml? 150 ml means we have to replace 150 ml of bicarbonate. That is the thing. You replace, suppose it is 600, we replace it at 150 in 1 hour, 150 in 24 hours, and 300 in 24 hours. That will be the calculation. What if we have hyperkalemia? Yes, hyperkalemia needs to be managed, especially if it is more than 5.5. Well known, our oral polystyrene sulfonate that we always use. IV soda bicarb, very helpful. 25% dextrose with insulin, that is 25% dextrose 100 ml with 10 units of human actrapid is the dose. IV calcium gluconate, rarely we give it at 10 ml over 20 minutes, more slower in elderly. Repeat your potassium results as and when need, minimum with every 6 hours. What else can you do? If you have IV fluids, if there is a volume deficit, IV antibiotics if there is a need, and reassess the patient's condition as and when is necessary. That is, relook at the patient if he is not on dialysis every 1 to 2 hours, whether you are improving, whether you are getting any result or not. Now that you have seen the conservative management, are there any other methods refusing dialysis? So is there any methods? So looking up the literature, there were these two things. One, there was this article which was published in the Electronic Journal of Biomedicine. This is in 2008. It says what is called as intestinal dialysis in a very old patient. This study, they have done it on 3 patients. They have used activated charcoal. Activated charcoal has very many uses, especially in poisoning. And one of the uses is here. They have used 1.15 grams of activated charcoal in 100 to 150 ml of water, given after food twice daily. That is, minimum dose is 30 grams, maximum dose is 60 grams per day. And then they have found out that this absorbs the uremic toxins and this reduces the urea creatinine levels. So they have found of the urea 178 has come down to 125 and a creatinine of 4 to 3.5. Probably the results are here are they have done it on a patient who is symptomatic of uremia but doesn't qualify really from our thing as a urea around 200 or a creatinine around 10. So the numbers are very less. So what happens subsequently is this activated charcoal is commercially available in Japan, Korea, Taiwan, Philippines, etc. Can be used for symptomatic uremia. It is probably thought to be to postpone dialysis. That was what is thought. So a major study was done from USA, reported in 2015 from the Journal of American Society of Nephrology. This is a randomized placebo-controlled EPIC trial, and AST 120 is the word for activated charcoal. This study has reported that there is no great use of using activated charcoal in patients with symptomatic uremia. So there is a group, there is a process, but it has not been confirmed. So there is the next new thing that is coming up for the refusing dialysis. What else? Is your gut microbiome and kidney disease, reported from CJSAN, November 2022, by one person called Dominic S. Raj, who is a nephrologist who has been here in 2018 in Trichy for a conference. So he says that uremic toxins are produced primarily from the gut due to the microbias. So the microbias can be normal, the microbias can be a different microbias, the microbias can be re-altered, and hence they produce more amount of toxins, and reduction of this uremic toxin using this gut microbia is helpful. That is what he says. So his approach, it is called as microbiome therapeutics, where he says that we supplement the host microbiota with a fecal transplantation. This is coming up very much, the word fecal transplantation, they'll ask you again and again. It's coming up very much in the specific strains, whatever strain you want, you just put it in, and that your strains get colonized and your uremic toxin production is reduced. 2, elimination of this deleterious member. Identify these organisms which are deleterious to your urea breakdown and remove this. 3, this can be removed by bacteriophages or bacteriocin. 3 is modulation of the host microbiota by giving agents called prebiotic. You select your organism and give it in large quantities, say 35,000 millions, 50,000, 60,000 millions. You flood in, change your flora, you get a benefit. And last but not the least, they call postbiotics. We target your downstream signaling pathway. This is all currently in investigation level, but they have not come to proof. But this gut microbia in diseases is a very large spectrum. So the result of this conservative management, this patient with chronic tubular interstitial, they make some useful recovery with the above measures for some time. Sometime is difficult to clarify. This can be for a few days, can be for a week. However, diabetic chronic glomerulonephritis patients tend to fare poorly. They may end up in a cardiac arrest, a respiratory arrest, or followed by death when you try to do this conservative management. The life expectancy on dialysis has increased from 2 to 3 years in 1990 when I started this nephrology to 10 to 13 years in 2022. So dialysis initiation is not risky. It has got a good quality of life, so you can use it. Hence, dialysis is necessary. Thank you.
Thank you, Giri. It's a very nice lecture. And newer method of conservative management like microbiome techniques, everything is very nicely explained.
So sorry to interrupt, sir. We'll be having the discussion after the
Yeah.
whole session.
Okay.
Thank you, sir.
Comment.
Thank you, sir. Next, we invite Professor N. Gopalakrishnan, sir, to kindly come onto the stage.
So, sir needs no introduction.
I am Dr. Gopal Krishnan, Director, Institute of Nephrology, Madras Medical College.
Yes, everybody.
Ever willing to share knowledge and help any patient anytime, even in the middle of the night. Many a time from the government hospital, we have literally asked, begged sir, and he was only too ready to come and help our patients. Salute your readiness.
Pleasure is
sir.
mine, ma'am.
Thank you, sir.
First of all, I profusely thank you, madam, for inviting me to be part of this great event. I've been seeing a kind of a sea of humanity here.
Yes, sir.
So many attendees and big list of topics. A great event.
பிள்ளைங்கெல்லாம் இதை மிஸ் பண்றாங்களேன்னு இருக்கு எல்லாம் simultaneously we
No
had
problem.
to
madam. It's
pack
okay.
many programs.
No problem.
Thanks.
Thank you. Yeah, the topic for today's discussion is
AKE in tropical disease. Please.
Yes. Actually, the time allotted is 20 minutes. The topic is quite big. It's very difficult to give a comprehensive kind of discussion on this topic. What I'm trying to do is that just to give an overview of certain important things that we have been coming across. Uh, I bring along with me the best wishes from all the faculty and students and staff of the historic Madras Medical College. And what do we mean by tropic? The tropic, the expression, involves a huge chunk of the globe, including South Asia, Southeast Asia, major part of Africa, and Latin America, which is including about 40% of the population. And why this particular topic is that acute kidney injury profile, if you compare that in the Western Hemisphere and compared with the tropic, there are a lot of differences. There are some common causes in both these, but there are peculiar and unique causes for acute kidney injury in the tropic. That is what is going to be the discussion. Fine. Before going into the topic proper, I know you all, I hope you all know the current, the diagnostic criteria for acute kidney injury. This is KDIGO criteria. This is what is widely followed among nephrology circles. Please remember, stage 1 akin is if the urine output drops to less than 0.5 ml per kilogram per hour, even for 6 to 12 hours. That time the creatinine may not show a great elevation. At that point of time itself, your acute kidney injury starts. This is stage 1. Here itself, you have to be careful. So this is the stage 2 and then stage 3. Stage 3 is very advanced, requiring even renal replacement therapy and the absolute creatinine value going beyond 4. There are quite a good number of causes, plethora of causes for acute kidney injury in tropics. These are the broad categories, 4 categories: the infections, the toxins, systemic diseases, and obstetric causes, right? So this is a brief summary of the infectious causes for acute kidney injury. The bacterial sepsis is the most common cause of acute kidney injury across the globe. So even though there are so many important points to discuss on that, I am not going to do that because it is not peculiar to the tropical region. Particularly the multi-drug resistant gram-negative bacterial sepsis is a real killer. And particularly those who are hospitalized for more than a week or so on, this is a major problem we are all coming across. I'm not going to discuss about that. The diarrheal disease, classically, conventionally, for decades, it is an important contributor for acute kidney injury. Recently, World Congress of Nephrology, we have presented a paper on Chennai floods associated acute diarrheal disease associated AKI. And then scrub typhus is very important now. I'll discuss little elaborately on that. Malaria, particularly falciparum malaria, the dengue, the leptospirosis, and rarely hantavirus and so on. So these are the common infections. Of course, there are other infections as well. This is the paper which from our institution, Madras Medical College, which has highlighted the trend changes in the etiology of acute kidney injury over different timelines. As you can see here, there are different timelines, the data available. I'll discuss about that. This is very important. In a teaching institution, we are at an advantage of collating and compiling data over timeline and then assess the trend changes happening in various aspects of every disease, in terms of the severity, in terms of outcome, in terms of disease profile, and so on. So these are the important trend changes that we have seen. So, gram-negative bacterial sepsis was not a very important cause in the past. Now it has become the number 1 cause. Acute diarrheal disease, the incidence of AKI due to acute diarrheal disease has come down very significantly. And similarly, leptospirosis. When I was a trainee in nephrology, leptospirosis was an important cause. In fact, my beloved teacher, Professor Muthi Sethupathi and Shivakumar sir, they did a lot of work in leptospirosis. They were instrumental in establishing a lepto lab in Madras Medical College and so on. But the now incidence of acute kidney injury due to leptospirosis significantly come down. Similarly, falciparum malaria. More than 2 years, I have not seen a single case of falciparum malaria associated AKI, which used to be very common in those days. Whereas scrub typhus associated acute kidney injury, first case I saw only in 2012. Now it is a very important cause now. And another important thing, acute pyelonephritis. In the past, we used to have acute pyelonephritis, but the patients will have only toxic phenomena, septicemia and all that. Without obstruction in the urinary tract, without a nephrotoxic drug, without a shock, they never used to go in for acute kidney injury. But now, without all these 3, the presentation itself as acute kidney injury is very common. This is a point to ponder. It is an area of intense research that has to happen. Fine. Quickly, I'll highlight on certain important diseases. Scrub typhus, it is a warning from WHO. Warning from WHO that scrub typhus is a re-emerging disease of Southeast Asia and Southwestern Pacific region with a case fatality rate of up to 30%. Look at that, the graph there. This is called a world scenario, the triangle, scrub typhus triangle, which encompasses important parts of, most parts of Asia. So we have to get alerted about scrub typhus. It is caused by Orientia acid Tsugamushi, transmitted by the mite, the trombiculate mite. This is the clinical picture. The important point of clinical point in scrub typhus is that if there is disproportionate early onset of encephalopathy, altered sensorium, always think in terms of scrub typhus. In fact, the meaning of the word typhus is cloudy consciousness, clouding. In fact, this is a very old disease. Later on, another disease with fever and altered sensorium came in. So people thought it mimics like typhus, so it is called typhoid. So typhoid came later. So scrub typhus, once upon a time, it was a major killer. Then for quite some time, it was not there and it is re-emerging. So it can affect almost every organ system, presentation, acute febrile illness, jaundice, myalgia. The problem is it can cause meningoencephalitis, ARDS-like syndrome, multi-organ failure, acute kidney injury. So this is the classical SR. SR need not be, it is not mandatory for making a diagnosis. It is present only in 20 to 60% of the patients. If you do a biopsy at that point, you can see a beautiful lymphohistiocytic vasculitis. So that if it is there, the specificity is very, very high, almost 100%, but its sensitivity is only maximum 60%. How it causes acute kidney injury? Multiple mechanisms. It can cause intravascular volume depletion and the prerenal azotemia and the direct renal invasion by the organism. It can cause acute tubular injury. And rhabdomyolysis can happen. It can cause rhabdomyolysis and myoglobinuria and then acute kidney injury, acute interstitial nephritis, and we have reported a patient rarely thrombotic microangiopathy associated with scrub typhus also because it causes endothelial dysfunction. Fine. Wheel Felix test, it's totally outdated. Never ever think of that because it's got a lot of fallacies. How do you make a diagnosis? IgM ELISA. But the gold standard is nucleic acid testing, DNA PCR. It is not available in most of the places. Please do IgM ELISA. It has got a very high sensitivity and specificity that is making a diagnosis. So this is the experience of MMC. My point is that I would like to highlight there is a 20% mortality of scrub typhus. 20% mortality. And the predictors of mortality were not just the kidney injury alone. If there is only kidney injury, they survive. Along with that, if there is a hepatic dysfunction, if there is associated encephalitis and all that, mortality is very, very high. A very important point to remember clinically is that there are most of these acute febrile illness, thrombocytopenia, little bit of jaundice, liver enzyme elevation, acute kidney injury happens. It can happen in dengue, it can be happening in lepto, it can be there in gram-negative sepsis, it can be there in scrub typhus. Clinically, scrub typhus does not respond to most of the antibiotics. It responds only to doxycycline and azithromycin. If you keep on giving meropenem and then third generation cephalosporin, you miss the best. That is the only point of concern here. Fine. In fact, we have identified scrub typhus even in a kidney transplant recipient. In fact, there is increasing resistance to doxycycline. So the conventional, the advice is that don't waste your time in a patient who has got multiple organ failures with doxy alone. About 50% in certain studies, 50% resistance. In such a severe situation, you can straight away go for azithromycin. Yeah, moving on to lepto. It's a classical leptospirosis with a patient in one of our patients, a conjunctival suffusion, subconjunctival hemorrhage, and icterus. So these are the classical features. Lepto, there will be incapacitating myalgia because of the myositis. That is a clue. And it can cause acute kidney injury in the later phase. Initial phase, leptospiremic phase, there is a systemic manifestation. Later on, it can cause even lung hemorrhage and aseptic meningitis, uveitis, and so on. Acute kidney injury can happen in the later phase. This is Dr. Shivakumar sir's paper. Even 2005 itself, he has noted a significant decline in the incidence of acute kidney injury. That's what I've been talking about. In the month of October and December, myself, Edwin, we were trainees in nephrology. The entire ward will be full of penicillin drips. All that scene has just gone. The present trainees, they are not too enthused to learn about lepto because so many AKIs we don't come across. This is a classical epidemiological change that has been observing. For laboratory investigation, in the presence of acute kidney injury, if you come across a normal, low normal potassium or low potassium, always think in terms of lepto. Because there is a inhibition of sodium potassium ATPase pump, and then you can have hypokalemia. That can be a clue, and lepto is an important cause for hypomagnesemia. Always look for it in a patient who is vulnerable for ventricular arrhythmias. Already somebody has got a ischemic heart, lepto, please think of magnesium. Fine. There are multifactorial pathogens of AKI, the hemodynamic alterations and hypovolemia, ATN can happen, and the lepto can directly traverse across from the glomerulus, peritubular capillary, from the interstitium, it can cause acute interstitial nephritis. From the interstitium, it can enter into the tubule, causing acute tubular necrosis as well. And then there are certain immune-mediated mechanisms of kidney injury also. Fine. In the past, microscopic agglutination test was considered as the gold standard. It's a very difficult test to do. In fact, my mentor, Professor Muthusetupati, helped Microbiology Institute of MMC in establishing it. It is very difficult. You need to have a live 0 watts of leptospira to run this test. But now currently it is not been made mandatory. I'll talk about that. This is the Fain's criteria. And again, we can take the credit. There is a modification of Fain's criteria. That modification is in the name of Professor Shivakumar. He added a rainfall. 5 points has been included. And it is classified as Part A, Part B, and Part C. Part A is clinical data with scores. Part B is epidemiological phenomena. And Part 3 is your laboratory tests and so on. See, this is a scoring system. This is how you have to arrive at a diagnosis. This system works very, very well. You can make a diagnosis with certainty. This is the current Indian guideline. First week, you have only clinical and epidemiological criteria. Your serological test may not be positive. Second week only, there is a serological test. It is enough if you are able to do ELISA, IgM ELISA, or MSAT. MAT is not mandatory. Fine. This is a treatment doxycycline, penicillin, ceftriaxone, and so on. The point of interest from nephrology point. We all have been thinking that leptospirosis is one-time affair. Once the patient recovers, everything is fine. But it is not so. That's what is the current problem. There is a hypothesis saying that you all might have heard about an emerging entity called chronic kidney disease of undetermined etiology. Lots and lots of CKDs without any known cause. There is a paper from Thailand that they have tested in such persons, very high prevalence of lepto antibodies. Probably lepto persistent asymptomatic chronic state might contribute for a CKDU. That is the current view. Falciparum malaria, for completion's sake, we are not coming across. 2 years ago, we came across one Orissa migrant laborer, not indigenous population. Falciparum malaria, multiple mechanisms can cause AKI, particularly intravascular hemolysis, hemoglobinuria, the altered hemorrheology, resulting in cytoadherence and clogging of the microcirculation of the kidney and increased vascular permeability. Okay, and these are the risk factors for malaria-associated AKI, pregnancy, children, and severe parasitemia, and so on. The pathology is acute tubular necrosis, and as I already said, because of hemolysis, you get hemoglobin pigment nephropathy. The artesunate, intravenous artesunate, is the pick of choice. Dengue, for the past few years, every year we are getting an epidemic of dengue. Dengue is potential, it has got a potential to cause AKI. You all know about dengue shock syndrome, the capillary leak, intravascular volume depletion that results in that. Also remember, dengue can cause rhabdomyolysis. And there are reports of even hemolytic uremic syndrome that is happening. So one thing you might notice, all these phenomena, one more virus, I'll finish that one. Hantavirus, whenever you come across an acute febrile illness, thrombocytopenia, AKI, all these tests are negative. Remember hantavirus. I have a feeling we are underdiagnosing hantavirus. Now there are facilities, particularly Child Trust Hospital. There is one virologist exclusively working on hantavirus and serological methods of diagnosis there. Even nucleic acid test is being done. All these infections share a lot of commonalities. They present as acute febrile illness, thrombocytopenia, mild liver injury, acute kidney injury, and so on, hemodynamic perturbation. Quickly, you should be able to completely examine the patient and run through the test, and appropriate treatment is important. The point to remember is that the most important component of the medical management is ensuring adequacy of intravascular volume. Number one, avoiding unnecessary drugs. Don't add insult with nephrotoxic drugs. Then run appropriate tests and then go in for appropriate therapy. So this is a pictorial representation of what happens in all these fevers. Ultimately, what is resulting is endothelial dysfunction and platelet activation, complement activation, activation of intravascular coagulation. And there is a cytokine storm. If a person enters into that severe cytokine storm, it's very difficult, the prognosis is poor. Moving on to another important entity, there is snake bite. It is an under-recognized cause. So this is the protocol followed in RGGH. And I think the same protocol is followed everywhere. It requires revision and introspection. And this is the big four: the crate, the cobra, the vipers, Russell viper and saw-scaled viper. Now one more entity, that is hump-nosed pit viper, that is being recognized. The point of interest is that the current ASV does not cover this hump-nosed pit viper. This is one fallacy in that. See, it's a deadly cocktail of so many invasive, tissue injurious components are in the snake venom. And this is one of my editorial commentary in Kidney International. How kidney is involved. It can cause acute tubular necrosis. It can cause acute cortical necrosis because of the vascular thrombosis. And it can cause acute interstitial nephritis and thrombotic microangiopathy. So these two pathologies are dangerous. Acute cortical necrosis and thrombotic microangiopathy, recovery rate is very, very poor. So this ATN is the commonest pathology. This is the cortical necrosis I was talking about because of the occlusive pathology in the kidney. And these are thrombotic microangiopathy, as you can see here, the fibrin thrombi because of the endothelial injury. These are publication on thrombotic microangiopathy due to viper bite. And this is rhabdomyolysis due to snake bite. It's a myoglobin, the pigment nephropathy. And so this we have published. And acute interstitial nephritis recently we are coming across more and more. Probably it is a immunological mechanism, either due to the venom per se or anti-snake venom. We don't know whether the steroid is indicated here. So actually it is an area of research. We have to do an RCT. So this is a publication on snake venom induced acute interstitial nephritis, right? So also we have done another study. Those who have survived of acute kidney injury due to snake bite, what happens to them? As you can see, it was published in Postgraduate Journal of Medicine. As you can see here, as high as 48% of them, there is adverse renal outcome even if they survive an acute kidney injury due to snake bite. This is a point of interest. The story does not go over simply with treatment of the acute kidney injury episode due to snake bite. That is the importance of this particular study. There are so much to be done for this thing because last year 46,000 deaths happened in India alone due to snake bite. There are so many things we have to do. First thing is that sensitization of the rural community and improving their health-seeking behavior without wasting time, and ensuring availability of ASP across all levels of healthcare delivery system, appropriate treatment protocol with emphasis on adequacy of ASP dosing, and minimizing the bite to needle interval, the most important step, and early identification and optimal management of AKI. And after AKI, regular follow-up is mandatory. And we have to develop diagnostic kits for measurement of individual venom components and serum of the patients. And we have to get ASP which can cover the other snake species beyond this big four. And also we have to introspect our treatment protocols. Another important point in the tropics is wasp sting. In Tamil, we call it as kadandu. That also can cause acute kidney injury, increasing incidence. It can cause rhabdomyolysis and hemolysis and disseminated intravascular coagulation and so on. It can cause ATN and AIN. Whenever you come across this wasp sting associated AKI, look for evidence of either hemolysis or rhabdomyolysis. If it is so, it's only conservative management. If it is not there, please go for an early biopsy because acute interstitial nephritis due to wasp sting responds to steroids. That's what we have learned. These are publications in Kidney International on myoglobinuric renal failure due to WASP. This is yet another publication, a case series of WASP sting associated AKI in Clinical Kidney Journal. That's what we have done. And then we'll move on to other toxins. We have a big toxicology unit in Internal Medicine Institute. Mercury chloride poisoning, not infrequently we do come across. And then diethylene glycol poisoning, this our publication. There's a huge number of patients with paraquat poisoning. I think yesterday we had a wonderful lecture. And then the rodenticide poisoning with yellow phosphorus. All these you can have acute kidney injury. And a case report. A 33-year-old gentleman, he consumed some plant product with suicidal intent. First day, he was treated with native medications. Second day, he comes to hospital after developed a brownish urine. After admission, goes in for cardiorespiratory arrest, but fortunately, he got resuscitated. Serum creatinine 4.1 acute kidney injury. CPK grossly elevated, LDH elevated. There is evidence for rhabdomyolysis. This is it. What is this? Sengandal. This is the official flower, state flower of Tamil Nadu, as well as Zimbabwe. Recently also, you might have come across in the news reports, somebody consumed that one. How does it cause kidney injury? It is actually grown. The plantation is done in Erodu and Namakkal districts and all. It is exported for production of colchicine. A high content of colchicine that causes rhabdomyolysis and acute kidney injury. Case fatality rate is pretty high. And a word about obstetric acute kidney injury. How does it differ from the Western world? Still, we have abruptio placenta. This is our publication. Abruptio placenta 10%. And thrombotic microangiopathy, the incidence is increasing. It was not there a couple of decades ago. It was not there. Thrombotic microangiopathy as a cause of pregnancy associated acute kidney injury. Mortality still remains 8% in spite of so many developments. Fortunately, septic abortions as a cause of AKI, it is almost gone. The point of interest here is that, like snakebite associated AKI, this AKI also has got a very high potential for progression to CKD. Be aware of this particular point. Okay. This is another problem. Now, Tamil Nadu is the wettest state of India. Almost everybody is consuming alcohol, and so many. It's a pathetic scene to develop, to come across a very severe acute pancreatitis. Acute pancreatitis as a cause of AKI. It is very, very unfortunate. This is our publication of 68 patients of acute kidney injury due to acute pancreatitis. Alcohol, the commonest cause, more than 90%. Mortality, 33.8%. And another important thing is that, very interesting thing is that the most common cause is acute tubular necrosis. In severe hypotension shock, you can come across acute cortical necrosis. But now, a person with acute pancreatitis, AKI, after admission, after hospitalization, new onset hypertension happens, get alerted, immediately go for LDH, go for peripheral smear to look for fragmented RBCs. It's a new onset thrombotic microangiopathy. That's what is happening. We are coming across so many such cases of acute pancreatitis associated thrombotic microangiopathy. And I was talking about acute pyelonephritis as a cause of AKI. These are our data. Non-obstructive, without any obstructional system also, it causes acute kidney injury. 83% of them. And E. coli is the commonest cause of this. And AKI is so severe that more than 50% of them require dialysis support. And HIV as a cause of AKI is also increasing, multiple causes. One treatable cause is that antiretroviral associated. Look at our data. About 9 patients of this 51 AKI due to HIV were on tenofovir. It is mandatory to monitor for the nephrotoxicity. This is, I just finished. This is one of my papers in Western Nephrology Journal, a clarion call for follow-up of acute kidney injury survivors. As Giri sir mentioned, there is an increasing burden of CKD. Those who survive an episode of AKI, they are highly vulnerable as a subset to go in for progression of CKD. It is our duty to follow them up. It's very difficult to sensitize them on this because they'll be relatively asymptomatic. Please make it mandatory that they have to get back to the system, periodically have to look for this. We have devised a protocol also, very inexpensive protocol applicable to Asia. It was published. And this is a project we have been thinking of. We are about to start. This is called RAKI. Dialysis requiring acute kidney injury follow-up project to determine the etiology and what happens to them periodically. It is going to be a multicentric trial. I'm glad to announce that we have got ICMR grant for this. MMC is going to be the initiating and coordinating center, and 25 centers across the state of Tamil Nadu are going to participate on that. With this note, I finish my thing. Thank you so much.
Thank you, sir. Thank you for a very lucid and wonderful presentation with a lot of experience. The discussion will be at the end, sir. We'll go on to the next session.
For the next session, I call upon Dr. Edwin Fernando, sir. The topic will be incidental albumin in urine, what to do. I request the chairpersons to introduce the speaker.
So, for this topic of incidental albumin in urine, we have Professor Edwin Fernando from Chennai. Sir is the professor and head of nephrology, Government Stanley Medical College. Sir has a lot of fellowship in nephrology from Royal Colleges. Sir is the member of International Society of Nephrology, and he is the member Renal Transplantation Advisory Committee of Government of Tamil Nadu. He is also member of Board of Higher Specialities, Dr. Tamil Nadu MGR Medical University. He is member of Scientific Committee, Indian Society of Nephrology. Sir is the principal investigation of Credence and DAPA CKD trials, and he has 98 publications in index journals to his credit. So over to you, sir.
Thank you, respected chairpersons, members of the organizing committee of Tapicon. Good morning, and I thank the members of Tapicon and Trichy API for calling me to talk on this topic. I shall be talking to you about what do you do when you have somebody who has got incidental protein detected in the urine. I bring to you warm greetings from the Government Stanley Medical College, ancient institution, one of the oldest in the country. The early nephrologists diagnosed diseases only by looking at the urine. It's not nephrology, the physician looked at the urine to diagnose diseases, which this tradition we have been continuing for long. So the topic today is proteinuria. Now, I shall tell you what is proteinuria, what is albuminuria a little later.
What it means is there's a cardinal sign of kidney disease. It's a risk factor for progression of kidney disease, and it's a risk factor for cardiovascular complications and death. Now, is it present? Is it present on the dipstick, which is a common method of detecting, or you do what is known as a sulfosalicylic acid, because both have got different connotations? And how huge is it? Either you measure a 24-hour urine protein, or you look at a urinary albumin creatinine or a urine protein creatinine ratios, which are simple clinical bedside methods. So, proteinuria is a common clinical finding. The causes could be diverse. It could be something very benign like an orthostatic proteinuria. Others could have sinister implications, some of which could be transient, some of which could be persistent. And the urine microscopy, this we called as the window to the kidney, examination of the urinary sediment is important. These are the various syndromic approach to nephrology which we teach MD postgraduates, and we try to fit in with the investigations into one of these syndromes. And the last one is asymptomatic urinary abnormalities. So, what does this really mean? Somebody goes for a health checkup, somebody goes for a pre employment checkup, and incidentally, there is some protein found in the urine. So, how do you go about this? Normally, there is about 150 milligrams of protein in the urine. In pregnancy, it can go up to 300 milligrams per day, most of which is 30% of which is albumin. There are other immunoproteins and about 40% of TAM protein from the renal tubular epithelial cell. These proteins are normally not detected by the routine urine examinations that we do. The pathophysiology could range from increased glomerular hydrostatic pressure, as in diabetes, or an altered perm selectivity, like a glomerular disease, like a nephrotic syndrome. It could be decreased tubular reabsorption and catabolism of protein, as happens in sepsis. Increased plasma concentration of proteins, normally filtered by the glomerulus. For example, you have the tubular overflow proteinuria, like dysproteinemias, somebody with leukemia, toxicities, myoglobin, etc. Now, how do you assess the proteinuria? Which test to order and which is the best? Assessment of proteinuria would include a complete medical history, review of the systems, physical examination is essential, the medical history to suggest a systemic disease, family history of kidney disease may be present, very important to go into drug history, particularly drug abuse and also native medication intake. Look at the past lab records and always compare. When you compare the lab records, it should be from the same lab. If you have different lab reports, then again it could be quite confusing. And please review whether the proteinuria is of recent onset or it's been there earlier, which is increased. And look at the renal function to see whether it is abnormal and whether there's a recent increase or worsening of kidney function, or it's been there long and how long it's been there. The assessment is not complete without the microscopic examination of the urinary sediment, which is called poor man's kidney biopsy. So, how do you interpret the proteinuria? Do you do an immunological workup and wait and repeat the urine or blood? What kind of proteinuria is this? How do you repeat? When do you repeat? How frequently would you repeat? Is there something to worry about? These are the questions that loom large in the minds of the treating physician. We look at transient proteinuria. This is after strenuous exercise, extremes of cold, a fever, urinary tract infection. Whenever there is some UTI, there could be a transient proteinuria. Now, this is something that could be repeated in about 1 to 2 weeks on 3 separate occasions. And a resolving proteinuria would say this is transient, secondary to some intercurrent illness. So, a urine examination done during a febrile episode or some other acute illness may not be the right one always, unless it is persistent. Then coming to orthostatic proteinuria, this simply means that the urinary protein excretion is normal at night, while in the daytime the protein excretion is more than normal. So if you collect the urine, the daytime urine separately and the nighttime urine separately, and estimate the protein, then this is something that could be found out, and this is something very benign. Now, when there's a persistent proteinuria, you keep repeating the urine samples at least 3 occasions. Even in our unit, we always insist that 3 examinations should be done, and we insist that our students should also do the tests themselves at least once a week or twice in a week, just to familiarize themselves how to do the test and also look at the urine microscopy, because this gives you a lot of information. So, is this proteinuria associated with a progressive increase in creatinine? Abnormalities in the urinary sediment. You find RBCs or RBC casts in the urine. It pins your diagnosis to the glomerulus. Is there some leukocytes or leukocyte cause? It pins down to the urinary tract. Leukocytes without infection could be interstitial nephritis. Fatty cast, oval bodies are in nephrotic range proteinuria. Associated symptoms like hypertension or systemic illnesses, systemic manifestations like palpable, non-palpable purpura, asthenia, red eye, arthritis, prolonged fever, symptoms of lupus, etc. Now, what test do you order? First, you do a dipstick because it's rapid, easily available at the bedside, and can be done as an outpatient. We call the urine examination as an extension of the clinical examination. The sensitivity is low, but the specificity is quite high. It is useful as long as the urine protein is about 300 to 500 milligrams or the albumin of 10 to 20. It has got limited sensitivity to detect immunoglobulins and light chains, and there are false positives and false negatives. A concentrated or diluted urine could change the result. The pH can change the result. Presence of gross hematuria again can change the results this way or that way. Urease producing bacteria raises the pH and that could produce false results. So, iodinated contrast and contamination with the disinfections can give a false positive or negative report. A negative dipstick with quantification positive is called a tubular or overflow proteinuria. So, when you interpret a urine examination, please check whether the lab is doing an albumin or protein. Albumin is done by a dipstick, while the protein I shall come to a little later. So these are the acceptable normal ranges of physiological albumin and protein. So look at the difference, nearly about 20 milligrams per day, while the proteinuria can be up to 150 milligrams per day. And microalbuminuria is now called moderately severe proteinuria, 30 to 300 milligram per day. Macroalbuminuria is more than 300 milligram per day. And we call nephrotic range when it is more than 3.5 grams of protein per day. In a 24-hour urine collection, we look at what is known as the albumin excretion rate. A mild is less than 30 or ACR of less than 30 to 30 milligram per gram. So it is important that you measure the creatinine in the urine also to calculate the albumin creatinine ratio because it has to be corrected for that. So a moderate is 30 to 300 and a severe is more than 300 milligrams. So whenever you look at albumin creatinine ratio, it is milligram of albumin to gram of creatinine. So these are again the normal acceptable ranges, but make sure that your patient has not smoked or exercised or had some febrile episode before checking for protein. That is the reason why we always repeat the urine examination, not be satisfied with just one sample. Now, there are three components of a complete urine examination. One is gross assessment of the urine, which is again very, very important. The clue, you can get a lot of clues. Then you do the urinary dipstick and then the examination of the urinary sediment. All these three things should be done. The urine sampling again, freshly voided in a clean, dry container. The external genitals have to be washed with water and a midstream urine collected. So this is to be particularly instructed to the patient, especially when they are taking a culture. Of course, in children, we do a catheter suprapubic aspirate, and in patients who are unconscious, we take a catheter sample that will disconnect the catheter and the bag and take it from the catheter directly. And the specimen should be analyzed at room temperature, ideally immediately or within 2 hours of retrieval. The colors of the urine can give you a lot of clues. Normal is an amber colored, very dilute urine is colorless. Phosphates in the urine or leukocytes, bacteria could give a cloudy color to the urine. A milky urine could be chyluria. Remember, chyluria can give a false positive protein in the urine. And sometimes the patient would come and say, my urine is milky white. So best thing is, and chyluria can be intermittent. So when you do the test for chyluria, it could be negative. So if the patient is passing cloudy urine, ask the patient to bring the sample and show it to you. Pyuria again could be a milky urine. Then drugs. Rifampin particularly produces orangish urine. Excess of bilirubin in the urine, yellow color, and red color with hemoglobinuria, myoglobinuria, brown urine. RBCs, etc. This is the dipstick. The principle of the dipstick is that there is a color change. Why does the color change? Because of the change in pH. So there is a buffer called tetrabromophenol blue, which is coated with this dipstick. So the principle of the dipstick is it's a protein error in pH. There are some limitations for this dipstick. Now, whenever there's a moderately increased albuminuria, 30 to 300 milligrams, this may be the limit below the limit for detection of this dipstick, particularly if the urine is very dilute. The semi-quantitative categories that are reported as 1 plus, 2 plus, 3 plus could be misleading in these situations. Dilute urine will underestimate the degree of albuminuria. A concentrated urine will overestimate the degree of albuminuria. So then you do a semi-quantitative measurement. So you're convinced that 2 or 3 specimens of sample of urine is showing protein. Then you do the standard urine dipstick, as called a sulfosalicylic acid test. And then you have the quantitative measurement. Either you do a 24-hour urine collection or do a spot urine protein creatinine ratio. Now, this is a sulfosalicylic acid test, and I insist that all my trainees do this test at least once in a week by themselves to check whether the lab is also right and also be familiarized themselves. As a nephrologist, the urine examination is the most important part of our investigations. I call it an extension of our clinical examination. An ultrasound and urine routine are extension of our clinical examination. So this is done by turbidometry method, where we use the sulfosalicylic acid, and the change in the color. This is flocculation here. This test is most sensitive. The dipstick is most sensitive to albumin, while the sulfosalicylic acid test is performed to detect other proteins. Suppose you have an albumin that is negative and a sulfosalicylic acid test that is positive, that is suggestive of some paraproteinemia like myeloma. So this is a very important clue that you could get the diagnosis. And this is how the SSA test is quantified. It is trace 1 plus to 4 plus. So suppose there is a 4 plus flocculent precipitate, it should be at least 1000 milligrams of urine per day. So this is a very important test in the armamentarium in the laboratory. So whatever test you are doing, you must be sure what is this test the lab is performing and giving you a report. You should, as nephrologists, we visit the lab often to check a random check or quality controls to see whether the lab is performing the test right. We can't assume that they always do it right. There may be change in the personnel and results may vary. That is why we insist that 3 urine examinations should be done before we decide on anything. Because if you're going to do a biopsy or an invasive procedure, then we need to be doubly sure that what we are doing, our results are right. Now, coming to a quantitative assay. How many of us would like to have a 24-hour urine collection? I have to apply leave for today. Probably the Sunday is the only day we sit at home, then bring a big can and then start collecting urine from morning till next day morning, then carry these 2 cans of urine to the laboratory. So it's a laborious method, and no patient is also going to like it. Of course, for treatment purposes, for documentation, we do. So this test has to be equated to something more easy, and that is what is known as the urine protein creatinine ratio, otherwise called a urine albumin creatinine ratio. Both are different. So this PCR tells you it is equivalent to a 24-hour urine protein. The PCR is 5. There's a sample of urine, you estimate the protein, you estimate the creatinine, and then you calculate a ratio. Suppose the PCR is 3, it means it's 3 grams per 24 hours. If the PCR is 10, it means 10 grams per 24 hours. So this is a very quick OP evaluation. Somebody comes from outstation, you follow up a nephrotic syndrome, you want to find out the proteinuria has decreased, whether the patient is responding to your treatment, or you have to scale down your immunosuppression. This is very helpful test. So instead of doing a laborious 24-hour urine protein, this urine protein creatinine ratio is a simple outpatient clinical test. So these are the different varieties of proteinuria I spoke about: transient proteinuria, orthostatic proteinuria, overflow proteinuria, that is when you have an albumin that is negative but a SSA that is positive. Then you have the glomerular proteinuria, then interstitial proteinuria, especially with drugs and other toxins, and some post-renal proteinuria like urinary tract infection, nephrolithiasis, etc. So, which test do you order? Either you can do a protein creatinine ratio, or very sensitive, you have to do the albumin creatinine ratio. Of course, the gold standard is to do a 24-hour urine protein. So, the measurement of the urine ACR or the PCR is as good as a 24-hour urine. You must be aware of the accuracy, standardizing the protein measurement to the quantity of creatinine. So, this has to be done accurately. If your lab is doing the ACR, then the lab should undergo good quality controls, because ACR is now implicated and is being recommended as a screening tool for diabetes, for early detection of diabetic kidney disease. Complete collection has to be ensured, especially if it's a 24-hour urine protein. The men and women excrete different levels of creatinine. Creatinine is a muscle protein. So somebody who's very lean, frail, can have very less creatinine excretion. That is why the albumin has to be adjusted for the creatinine. Diluted or concentrated urine samples could provide false positive negative reports, and the influence of age and muscle mass I mentioned. The urine PCR or the ACR can be done on a spot urine sample, and it is more sensitive. The ACR is more sensitive, but make sure that all criteria are fulfilled. And if you're looking at an abnormal ACR, you should be doing these tests at least 3 times in 6 months, and twice it should be abnormal to really brand somebody as having disease. In pregnant women, there could be diurnal variation, and the microalbuminuria in a spot sample, the sensitivity is quite high while the specificity is low. The negative predictive value, of course, is very high. For a PCR, the sensitivity is high, the specificity is also high, and the negative predictive value is 96. So that's quite high. In that way, these tests are extremely useful. When you make a 24-hour urine protein, you have to instruct the patient clearly that the first sample of urine has to be passed in the restroom, and the remaining from the next time the patient voids urine, that time to 24 hours from that time, urine should be collected, and the entire urine should be brought to the laboratory for analysis. When you're doing a spot sample, you could do a first morning sample, and or sometimes an overnight urine sample, but the first morning sample is preferred. Now, when the proteinuria is pathological, the most common cause of proteinuria in our country, if you take nephrotic proteinuria, is diabetes. Now, we'll exclude diabetes from this proteinuria because we know that diabetes is a cause of proteinuria. However, there are some pathological proteinuria could be because of primary glomerular disease, secondary glomerular disease, and other forms of interstitial disease where the proteinuria could be minimal. Or it could be overflow proteinuria like Benz-Jones protein, leukemias, rhabdomyolysis, intravascular hemolysis, etc. Now, once you have a significant proteinuria and there is no diabetes, generally we don't biopsy a diabetic. So the patient undergoes an ultrasound guided biopsy of the kidney, and these are the various diseases according to the age groups that have been found out. So why have you have to check this proteinuria is because of if you don't follow this proteinuria, or you allow it to progress, when the proteinuria becomes massive, then the kidney disease also worsens. So these are the various disease entities that could be diagnosed by proteinuria. I mentioned that diabetes does not require a renal biopsy generally, but there are certain circumstances where a diabetic has to be biopsied. So, whenever you feel that there are plenty of RBCs in the urine, RBC casts in the urine, or this patient has got some ischemic kidney disease, uncontrolled hypertension, or massive proteinuria, or relatively less proteinuria, or if the GFR is declining very rapidly, or if you suspect that this patient could have an SLE or some other collagen vascular disorder, then these are conditions, these are situations where a diabetic can also undergo biopsy, where you suspect that the kidney disease is not diabetes but something else. So, before I conclude, let me tell you that there is a good correlation between 24-hour urine protein and PCR to detect early kidney disease. It helps you to retard the progression of disease, and also it's an important indicator of mortality. It reduces the eGFR as the proteinuria worsens, it accelerates kidney failure and progression to dialysis and transplant. Proteinuria initiates heart and kidney disease, not always. All proteinurics do not develop kidney disease, but large majority do. This is Thomas Addis. He's one of those big names in the Guy's Hospital, London. When he says, when the patient dies, the kidneys may go to the pathologist, but while he lives, the urine is ours. It can provide us day by day, month by month, and year by year with a serial story of the major events within the kidney. Thank you very much for the patient listening.
Thank you, sir. Thank you for an elaborate presentation, especially for the clinician, sir. It was very wonderful presentation. Thank you, sir. Now it is open for a discussion. So I think we have 5 minutes for questions. Okay. So it is open for questioning. We have 3 topics.
Sir,
Yes.
hello, sir. Hello,
It's working. It's working. You can
Sir.
proceed.
sir. I have two questions, sir. I come from a medical college where there is no consultant nephrologist, sir. First question is, we are witnessing a lot of AKA cases, mostly because of infectious diseases, sepsis, and then snake bite. Some physicians prefer to refer the patient early, and some physicians they just wait. Since it is a pre-renal cause, they treat the cause and they wait. My question is, what is the exact time where we have to be alert and okay, this is the time we have to refer the patient, we should not waste any time, because I don't see there is proper criteria or protocol that we are following. I just want to when to decide that we have to refer the AKA patient, even though it is a pre-renal AKA, sepsis, whatever may be the cause. So this is the time we should not wait. We have to refer to a consultant nephrologist, because we also don't want to overcrowd the nephrologist with useless. And the second question is, sir, CKD cases, I have been following a lot of cases. They are in maintenance dialysis in our unit. We don't have emergency dialysis. Okay.
Okay, so let me answer the first question. It's very important that when there's a no nephrologist, a physician should equip himself better to deal with these patients. Now, the history is very important. Somebody's got diarrhea, and you know there is a pre-renal azotemia, assessment of the volume situation. Ultrasound again can be used to look at the IVC diameter. Of course, other simple things like looking at the JVP, the skin turgor, etc. Postural hypotension that will help you to assess the volume status. So volume can be replenished. So a pre-renal azotemia has to correct itself if it is dealt with at the proper time, or it is progresses to renal. So what indicates to you that the patient is worsening is a poor urine output. So when the urine output is declining, you're not very happy, or the patient is anuric in spite of your volume repletion, then that is a time I think we must say stop, because the creatinine will take some time to increase. So for creatinine to take steady state, it takes about 48 hours. So a creatinine rise of 1 to 1.5 is significant, especially in pregnancy when the creatinine is between 0.4 to 0.7. A creatinine of 1 or 1.2 in a pregnant lady postpartum with an antepartum hemorrhage is something very significant. So at that time you must refer. So mostly you look at clinical. Second is laboratory. If you have an ABG, worsening acidosis or hyperkalemia, of course these could be managed clinically, provided you have confidence to manage this. But these are situations of impending hyperkalemia that is refractory to treatment with calcium gluconate or salbutamol inhalation, or an acidosis that is not correcting with soda bicarb, or a volume repletion done and since till the patient is not making enough urine. Make sure you rule out an obstructive nephropathy by doing an ultrasound. So these are situations where you think, okay, fine, I cannot handle this, I have to refer. Not that all your referrals we would be dialyzing or something. We would again still wait. But why we are waiting is we have a team and there's a 24-hour somebody looking at the patient. And then we would take a call. So not that the patient may say you referred, but they didn't do anything, but we recovered. Okay, fine. But then the unit is there, 24-hour by 7 services are there. So even a referral case, we would wait sometimes and then take a decision on dialysis a little later, or may not even dialyze. So this is these are the things that you have to keep in mind.
Adding further to what Dr. Edwin said, if the urine sediment is active, if it shows RBC cost or plenty of RBCs in urine sediment, whatever, irrespective of the severity of kidney failure, you please refer, because you may be dealing with a kind of a rapidly progressive glomerulonephritis,
Yes,
and the time is gold over there in addition to that. And as Professor Edwin highlighted, always the first step is that any patient you come across with kidney failure, even before you want to make it whether it acute or chronic. That is not the first thing is that you have to identify the presence of one or more reversible factors of kidney function. The most thing is that hypovolemia, most important thing is hypovolemia, infection, obstruction, hypokalemia, hypercalcemia, congestive cardiac failure, pericardial tamponade, hyperuricemia. Diligently look for the presence of these things. You try to correct them, address them. You can get some improvement in the kidney function. In spite of that, if it is not improving, refer. And anuria for more than 12 hours, you don't have any business to retain because suddenly the patient may worsen, and then it may be too late for the patient. And make it a point, as Professor Edwin highlighted, look into the urine sediment. Plenty of RBCs in urine sediment in the absence of urinary infection or any other cause. And RBC cost, if they are able to demonstrate, you are dealing with an acute glomerulonephritis. It can be a crescentic glomerulonephritis.
So my second question is, in CKD patients, sir, we are following lot of CKD patients. We are elective dialysis is going on in our college 24 hours. So I see lot of patients, even young patients to old age patients. I think the cause of the CKD has not been properly evaluated. Even the consultants, when I used to discuss, they say, இதுக்கு மேல என்ன பண்ண போறோம், anyway patient ended up in CKD. I just want to know what will be the consequence of ignoring this, or is it justified to ignore the cause of the CKD and just treat it as a CKD alone, sir? Thank you.
See, what happens is most times when the patient comes to us, the kidneys are already very small. When the kidneys are very small, it is very difficult to biopsy the kidney. One, because the cortex, where 95% of the glomeruli are there, is thinned out. So when you try to do a biopsy in these situations, you may injure the arcuate artery and produce a extensive bleed, uremia being a bleeding state, right? And if you get a biopsy, you may not get sufficient information. It may just show tubule atrophy, interstitial fibrosis. It is very, very important to recognize native kidney disease as a cause of renal failure. There are certain diseases that can recur after a transplant. So if a patient is going for transplant and come with small kidneys, we do make a diligent search. But unfortunately, when the kidney is contracted or we don't get any other clue, we are unable to proceed with anything further. So in the global dialysis perspective that Giri sir projected, diabetes is a common cause of CKD in our country, chronic interstitial nephritis, and CKD-U. Now the CKD-U is undetermined etiology. We do not know what is the etiology. So unfortunately, if you go to a dialysis unit, 80% of the patients, you may not know what is the diagnosis because they come with a creatinine of 5 or 10. So we are unable to biopsy. If there are some extra renal features, then we would look at doing something like somebody's got polycystic kidney disease. Then we know that this is a native kidney disease is present. Or if there is somebody presented with a thrombotic microangiopathy and then progress to a kidney disease, then we would do a genetic panel for hemolytic uremic syndrome, TMA, etc. Now the genetic testing is available, but the genetic testing is not again very conclusive. A lot of times there are some pathogenic variants or non-pathogenic variants we get. So mostly what you're saying is true, that we are unable to get a native kidney disease, though in a transplant unit, we always try to find out what is the native kidney disease because we have to deal with these patients for a transplant.
Card tests are available for leptospirosis and scrub typhus, sir. Are they validated? Are they proved useful?
Which one, sir?
Card test.
No, sir. IgM ELISA is more reliable.
Reliable.
IgM ELISA.
Thanks, sir.
Once there is overt proteinuria, the decline in GFR is 1 ml per minute per month. So which means once there is overt proteinuria, you lose about 10 to 12 ml of 10 to 12 ml of GFR per year. It is a relentless progression only. That is why we look at early detection of nephropathy by doing the urine albumin creatinine ratio, and at that time use effective drugs to control the blood pressure and also the diabetes. Now we have important drugs like the SGLT2 inhibitors and the MRA, the finerenone, and the GLP-1 agonists. So these drugs can be used in various combinations. They not only provide renal protection but also cardiac protection. But once overt proteinuria sets in, it's only a relentless progression. Ideally, optimal dialysis should be at least 16 to 20 hours per week. But again, in a country like ours where a lot of economics is involved in dialysis, though we have insurance programs and all that, generally it is a weekly thrice dialysis. But for some patients, we make it weekly twice. Suppose there is some residual renal function. He's making about 500 to 600 ml of urine per day. His interdialytic weight gain should not be more than 2% of his dry weight. So he doesn't come in with emergencies, with pulmonary edema, otherwise. So these are situations where you can manage somebody on a weekly twice dialysis. There has been some scientific work done on this, and if a patient is able to manage without landing up with emergencies or excessive weight gain, they can be managed on weekly twice dialysis. Somebody who's well dialyzed will not have any vomiting, will able to eat well, will have a better quality of life, will be able to. There are a lot of patients who come driving their bikes to the dialysis room, finish dialysis, and go back. There are some people who come on Sunday getting dialyzed, or nocturnal dialysis done in certain centers where the patients finish their office work, come and get dialyzed, and go back home the next day. So all these options are there. So basically, whether weekly twice or thrice depends on how the patient behaves. If he's coming at 2 a.m. at night on weekly twice dialysis, 2 a.m. his dialysis is due tomorrow, but he comes in today, then he has to be switched over to weekly thrice. This could also be due to become sometime fluid non-compliance or some excessive eating, etc. That could give rise to these situations. Weight gain is a very important criteria. Suppose his dry weight is, let's say, 45. We would allow a 1 to 2% of the body weight gain. Suppose the body weight gain is more, body weight gain more is only more fluid, nothing else. So he gains 3 liters of fluid between dialysis and he gets breathless. Then he has to be switched over to weekly thrice dialysis. There are patients who will require alternate dialysis also.
Thank you, sir. Thank
So-
you. For want of time,
Sir,
we are restricting the
Sir,
questions, doctor. Please, next session is on you. Thanks a lot. So we had a very wonderful session. Thank you so much, sir.
Thank you very much.
Thank you, sir. Now I request Dr. M. Shivashankaran sir and Dr. Balamurugan sir to felicitate Dr. P. Giri sir for his lecture. Next, I request Dr. Balamurugan sir to felicitate Dr. N. Gopalakrishnan sir for his lecture. I also request Dr. P. Giri sir and the other professors to felicitate Dr. Balamurugan sir and Dr. M. Shivashankaran sir for chairing the session. Thank you, sir. For the next session, we invite the chairpersons, Dr. Ravichandran sir, Dr. S. Sugumar sir, and Dr. Sudhagar sir to come over to the dais for chairing the session.
And the next topic for the session, non-invasive multimodality cardiac imaging. I request Dr. E. Prabhu sir to come over to the dais.
I request the chairperson to introduce the speaker.
Good morning, everyone. It's a nice occasion today to chair the session. Today's speaker for this session is Dr. Prabhu, Senior Consultant at HOD, Institute of Nuclear Medicine and Molecular Medicine, Multi-Speciality Hospital, Omandura, Chennai. Other qualifications, fellowships, awards, achievements are many. Fellow of Royal College of Physicians, Glasgow, Fellow of International Medical Sciences, Fellow of Indian College of Physicians, Fellow of Indian College of Nuclear Medicine, Fellow of American College of Physicians, experience 2014 till date, HOD of the Institute of Nuclear Medicine, 2011 to 14, Medical Director, Global Hospitals, Chennai, 2006 to 2010, Associate Professor, Head of the Nuclear Medicine, SRMC, 2003 to 5, Assistant Professor of Nuclear Medicine, Division of Madras Medical College. All the more is a, is a today's APA chairperson, is a good friend of mine, eminent speaker. Topic is very good topic. We are ready to listen to you, sir. Giving a good applause for our chairperson. Thank you, sir. Please over to Dr. Prabhu.
Thank you, Chairman, for a very, what happened? Thank you, Chairman, for this wonderful introduction, and we are humbled. In fact, before starting my lecture, I'd like to invite you all for the upcoming 25th Annual All India Postgraduate Teaching Program this coming weekend in Chennai. And I should thank Professor Anita Madam, Professor Sethuraman sir, and all the doyen physicians of Tiruchirappalli for putting up a very beautiful scientific program and giving challenging topics for all of us. And it really made us thinking and learn a lot. With these few words, I'd like to see how the heart is made up of. What we do is take a small piece of the heart. In the small piece of the heart, you can see the myocardium, epicardium, the endocardium, and all these smaller structures. We still divide it further, mechanically or enzymatically. We can still get a lot of other cells of the heart, like the cardiac myocytes, the fibroblasts, the pacemaker cells, the ventricular myocytes, the lymphatic cells, endothelial cells. Even though the endothelial cells are more in numbers, it is the cardiac myocytes. Almost it occupies 95% of the heart volume, and it is larger in size. So all these cells can go in for a failure. So any small failure in any of these cells can reflect clinically as a heart failure. For driving these cells, we need a powerhouse called the mitochondria. And this mitochondria is undergoing a lot of dynamic changes within the heart. Can be contracting, or can be stretching, or splitting, or fusing with one another, or dividing. So many dynamic changes are happening inside the mitochondrium. In fact, 40% of the cardiac myocytes, it is filled with mitochondrium because it requires a lot of energy to keep on contracting continuously. If only we can get an opportunity to put some track inside the mitochondrium, we'll be able to appreciate the viability of the cardiac myocytes. This is what happens. What happens? The perfusion defect happens, then the metabolic changes happens, the diastolic dysfunction, systolic dysfunction, then only the ECG changes happens. By the time we appreciate the ECG changes in the heart, that means that a considerable amount of damage has already happened. And then it appears as a chest pain and of course the myocardial infarction. For imaging the changes, we have the PET-CTs and SPECT-CT, which can image the functional changes that are happening at the perfusion and the biochemical levels. Then the diastolic dysfunction can be easily be assessed by MRI and CT, then the ECG and the clinical manifestations. Just to give an idea how we can divide the modalities of imaging the heart into ionizing modalities, and those that don't use non-ionizing radiation, and those who use ionizing radiation. What happens? We have SPECT, PET, and FOSPAR studies. These are the studies which comes from the nuclear medicine, and they can visualize the physiological changes that take place in the heart. Then we have the CT scans, ultrasound, and Doppler. That means that we see the anatomical changes that are happening in the heart. We will be hearing about more about Raman imaging in the future. The Raman, Sir C.V. Raman imaging, and so many things are happening in the exciting developments are happening in the future. These are the developments that are currently happening in the conventional modalities. We have that speckle tracking echo, and with this echocardiogram it gives a very high resolution. It is in the skill of the operator to identify and analyze what are the changes that are happening in the heart. Then we have the photon. We'll be having the photon counting CT, which has a very, very high degree of resolution, especially in identifying the calcified coronaries. Then we have the SPECT and PET, where the resolution is not good, whereas sensitivity is good, and we can see the functional changes that are happening. Then the cardiac MRI. What happens is, in the echocardiogram, we can literally see how the heart is literally squeezing the blood into the circulation. In fact, what you have to appreciate is we are drowned in a ocean of atmosphere. The heart is pumping against the pressure, atmospheric pressure, to maintain the tissue perfusion. So much amount of energy is generated, and this can be appreciated only in the echocardiogram, all the movements that are happening. Then in future, what we'll be hearing? We'll be hearing about using non-ionizing radiation modalities. Near infrared fluorescence imaging, which has a very high degree of resolution. We'll be hearing about Fourier transform infrared spectroscopy, then Raman imaging and the surface enhanced Raman spectroscopy. These are the images which have very high degree of resolution and very low penetration. In nuclear cardiology, we have the SPECT CTs, the PET CTs for imaging the myocardial perfusion and metabolism. Then we have the PET CTs, where we can see the metabolic activity that is dynamically taking place in the heart and cardiac innervation. Since I am a nuclear medicine physician, I'd like to discuss more about it. What are the indications for doing a myocardial perfusion imaging? One is for diagnosis of coronary artery disease, and another is for evaluating a patient with known CAD. For a non-diagnostic exercise history, we have for a poor mobility, especially patient is amputated, obese, they are unwilling to walk on a treadmill, and patients with renal impairment, and risk stratification before surgery, and assessing the myocardial ability before doing a revascularization procedure, whatever it is, and risk stratification of the patients. These are the indications for doing a myocardial perfusion imaging. For imaging, the ideal tracer is oxygen 15 water. Whenever the coronary blood flow increases, there is a proportional increase in uptake of oxygen 15 water. But then there are a lot of new tracers that are coming up. The one which is promising is a fluorine 18 flupyridase. This is what we'll be going to hear because it has passed phase 3 trials. It will soon be available for commercial imaging, commercial purposes. And we are extensively using the sestamine and tetraphosphine because these are the tracers that goes into the mitochondria and the heart. And whenever the cardiac myocytes are normal, there is rich uptake of tracer. And if it is ischemic, there is less uptake. Then if infarcted, there is no tracer. This is how it looks like. What we do is we cut the left ventricle in rings like, and in the 12 o'clock portion is the anterior wall, and 3 o'clock is the lateral wall, 6 o'clock the inferior wall, and 9 o'clock is the septum. Here we can see these are the tracers which have been commonly using, the one that is going to be used in the future. This is one of the studies what we did in our institution. In this, we can see the uniform tracer distribution, and in a normal myocardium, when a dynamic image, we look for systolic thickening of the myocardium. In the earliest sign of ischemia, this systolic thickening is lost. And whenever the myocardium is ischemic, we can see a hugely dilated ventricle. Here there's a perfusion defect here from 6 o'clock to 3 o'clock, inferior lateral region, corresponding to the circumflex artery territory. This is what it is. What we do is, we cut the left ventricle into rings. The apex will be in the center, 2 midventricular rings on the base of the heart. We assemble one over the other, give you a 2-dimensional, something like a watch-like picture, and then you'll be able to understand and quantify exactly what exactly is happening in the mind related to myocardial perfusion. We can do dynamic images. Sometimes we get a systolic ejection fraction will be less. Diastolic ejection, during stress it will be, EF will be more, rest it will be less. Or during the diastolic dysfunction, we'll be having stress will be less, stress will be more, and rest will be less. Sometimes the wall motion abnormalities in LV dysynchrony, all these things can be appreciated. By just one look at the images, we know that there's an extensive infarct from the LAD territory and RCA territory. Just one look at it. Sometimes in patients who have breathlessness, when we are evaluating, we can see absolutely normal left ventricle, and we can see the intense uptake in the right ventricle. The right ventricle is very thin. It is thinner than the resolution of the camera. Normally, we don't see the right ventricle. What happens whenever we see the right ventricular activity? That means that it is thick beyond 5 millimeters. It gives pulmonary hypertension. That it reveals focal pulmonary hypertension. That indicates not so good prognosis. In women, evaluating women with heart failure, of course, there are a lot of varied presentations, and this is the algorithm we apply. Normally, we do the easiest available stress echo, and if it is not available, we go for the SPECT CT. Sometimes we do get in certain patients will be absolutely normal myocardial perfusion, and after for treatment with statins, we can say that the perfusion has decreased, almost similar. When we do a quantification with cardiac PET, we can see a remarkable increase in myocardial perfusion. We can get 3.2 ml per gram per minute. There's so much amount of blood flow into a particular region. What we do is this SPECT CT gives anatomical, physiological information. We combine with CT, we get the anatomical information, and in almost all the modern imaging modalities is always a hybrid machine where we can see the functional and anatomical information. And this is how we can see how we are salvaged. The present who presents somebody who presents with chest pain in an emergency, we just inject the tracer and stabilize the patient, and we get the picture what exactly was the time, what was the present at the time of presentation the emergency. Then we do a revascularization procedure. Once the patient is stable, maybe about 3-4 days later, you can see the reversibility to a great extent. In such conditions, these are the patients who will be able to be greatly benefited by doing a bypass surgery or whatever it is. The cardiac MRI also it is possible, and these are some of the studies where the thickening can be appreciated in cardiac MRI. In some of the modern imaging modalities, we can see the atherosclerotic plaque. There are tracers which cause exclusively atherosclerotic plaque. These are the advantages of having hybrid imaging. They have higher performance than comparative single imaging modality. Then it gives risk stratification. You can always get some information about the culprit lesion. You can also evaluate the myocardial viability, coronary viability, and all for guiding how whether a CABG will be beneficial or a stent can be beneficial. This is something new, cardiac fibroblast activation imaging. It is available in Madurai. What happens is after the advent of gallium-68 generator, we do what is called a FAPI scan. And when the FAPI scan is done, when there is intense uptake, it gives us the expression of fibroblast activation, and it indicates fibrosis. Sometimes there is excessive washout of sesame B from the tracer, and these are the patients who this is because of the expression of P glycoproteins, and these are the patients who respond poor to all the therapeutic measures. In diabetic heart disease, we go for what happens is the mitochondrium may have increased free fatty acid uptake. There will be increased atheroma formation, reactive oxygen acid formation. There is decreased ATP production. All these things can be evaluated non-invasively. A lot of trials like DIAT, COURAGE, INSPIRE, BARI-2D trials. All these things are able to identify and quantify the degree of ischemia in the myocardium non-invasively. There are a lot of what happens is the major cardiac events can be predicted, and heart failure can be predicted in diabetes by doing this particular study. I'm imaging cardiac amyloidosis. And this amyloid proteins gets intensely deposited very aggressively, and what we do is technetium pyrophosphate scan. This is what we routinely do in our department in multi-super specialty hospital, and we can see that intense uptake. Even the heart is rich in myocardium. When the heart doesn't have any amyloidosis in the myocardium, that means it doesn't have. So what happens? We give a scoring compared to the uptake of amyloid system, this pyrophosphate with the rib and the heart, and that is how we will be able to quantify the severity. The cardiac MRI, SPECT CT, and PET CT, everywhere everything is compared, and studies have shown that the pyrophosphate imaging that was sensitive enough to identify the cardiac amyloidosis that is happening. Another thing we can image is the cardiac autonomic innervation. There's a good balance between the sympathetic and the parasympathetic innervation. We use what is called as meta-iodobenzene codeine, iodine 123 or iodine 131 MIBG scans. That gives us an idea about the distribution of sympathetic innervation of the heart. Normally, that's how it looks like. It is a very good uptake of tracer, and we can see the sympathetic innervation is decreased in atrial fibrillation, cardiac myopathies, and cardiotoxicity, chemotherapy, and all these things. There was one study called as the Admire HF study, where when the uptake of tracer, when the heart can be seen clearly with this tracer, that means that it has a good prognosis, whereas a patient in failure where the heart cannot be seen, that indicates poor prognosis. So these are the consensus in nuclear imaging. So one imaging technique cannot give answer for everything. So it has to be one, we have to examine the patients clinically and ascertain what could be the best method that gives us the maximum information to us. And it is a question of availability of the modality, accessibility, and the cost involved. There are always improved outcomes. Whenever we see improved clinical outcome, that drives us to give better, more research and better imaging methods and better outcomes. This is the algorithm, what we do in cardiac imaging with multimodalities. When we have a strong suspicion of intermediate probability of coronary artery disease, when it is a low probability, of course, we do a calcium CT and we just do optimum medical therapy. If there is an intermediate to high probability, we do a cardiac MRI if it is available. If a cardiac MRI is not available, we go for if there is no contraindication, we go for a stress cardiac MRI. With stress, we use adenosine, pharmacological stress. Whereas if it is there are contraindication, suspect some valvular disease, we go for SPECT CT, and if there are valvular diseases there, we can go for stress echo. This is how we normally work up in a day-to-day workup practice. What happens is huge amount of volume of data is generated when we are analyzing the patients. These patients come from various geographical distribution. For analyzing the findings, now a lot of artificial intelligence is applied. And when we are processing large volume data with ECG, X-ray, and integrate everything to find out the prognosis, use extensively the artificial intelligence. There are periodic guidelines that are issued by the professional bodies because there are a lot of rapid developments that are happening in the field of cardiac imaging. And these are the common professional bodies that give updated periodic guidelines. To sum up, what happens is the cardiac SPECT and SPECT CT helps us to image and quantify the cardiac dysfunction at the level of the molecules. And it helps us to predict the major adverse cardiac events. We can image cardiac innervation of the heart by using meta-iodobenzylguanidine and predict the heart failure and prevent the progression of heart failure, even the subclinical heart disease itself. And by using multimodality imaging, we can see the disease process at the anatomical, physiological, and molecular levels. For processing large volume of data, we extensively use artificial intelligence. And thank you all for patient.
Thank you, sir, for your excellent and elaborate lecture on non-invasive modalities of cardiac imaging. It was really an eye-opener for all our practicing physicians, and you have fed us with a lot of information, sir. Thank you for your lecture, sir. And we'll have question answers in the end of the session.
Thank you, sir. And next we invite Dr. Joseph Theodore from Tiruchi on the topic reversible cardiomyopathy.
Present duty to introduce the speaker of this topic, Dr. Joseph T. He is a consultant interventional cardiologist and electrophysiologist, Kaveri Heart City. He has his qualifications include MRCP and Young Investigator Award, Cardiac Society of India Conference, and Best Paper Award in OMC. He has a lot of publications to his credit, and is a young progressing cardiologist of Kaveri Hospital. With this small introduction, I invite Doctor to deliver his lecture.
Thank you, sir. Good morning, one and all. At the outset, I would like to thank the organizing committee of Tapicon for giving this opportunity, and also CRIB for the topic, because it is not a cut copy paste topic. So I'll be my role agenda would be to go ahead and tell what is reversible cardiomyopathy and which are the real life case scenarios which I'll be talking about now. And with that, we'll go into a general approach of how do we diagnose and treat these kind of conditions. And project the slide. Fine. So the agenda would be I'll show some real life cases. We'll go into the definition and etiology and general approach. So this is the case one. So 65-year-old man who's I think nurse's father from Chennai. Okay, had recurrent admissions for heart failure, and he was evaluated with ECG, echo, and angio was also normal. He was diagnosed to have non-ischemic DCM and was planned for cardiac transplant. All his routine investigations were normal, and he was referred to Trichy, okay, and was listed here because there was regional preference for cardiac transplant, organ donation. So that's the reason we also listed the patient. But when we went through the battery of investigations which he has been done, what you could see is very importantly, his TSH was more than 100. Okay, so this is the echo of the patient before giving thyroxine, and this is the echo of the patient after 6 months after giving thyroxine. So you could see there is a gross difference. In pre-echo, the LV is dilated, okay, LV is not pumping well, but post-thyroxine, after 6 months, his LV has almost returned to the normal. So this patient is a simple case of hypothyroid-induced cardiomyopathy and not a case for a cardiac transplant. This is what we need to first remember. The second case which I want to show you is 32-year-old person, fever, URI for almost a month before, and he presented with severe biventricular dysfunction. This was during the first wave of COVID pandemic, I think. His COVID was repeated, RT-PCR was negative. His routine investigations were negative, and inflammatory markers were positive, and cardiac enzymes positive. The working diagnosis was post-viral myocarditis. So his ECG, you could see, is a low voltage complex, which you can typically see in the myocarditis. Okay, and this is the echo of the patient. You could see in the echo, the heart wall is slightly thickened, as Dr. Prabhu was saying about taking an MRI and all those things. Even an echo, you'll be able to pick myocardial edema. So this heart wall is thickened, it is dilated, and is not pumping well. So it's a typical case of a viral myocarditis. Here we did an MRI. MRI was showing what? This was a subepicardial late enhancement in both RV and also in the LV. So what does this mean? This patient developed pump failure, and we put the patient in ECMO for almost 12 days. Post ECMO, he was slowly weaned off, okay, and then he was treated with steroids and everything and recovered with supports, and he's now a sales manager in Middle East with no drugs. So this is one other example where a cardiomyopathy can be completely reversible. This is what I want to highlight here. So this brings us to the definition of reversible cardiomyopathy. Any cardiac muscle disorder which is reversed naturally or by intervention completely or partially is reversible cardiomyopathy. So the point to be noticed here is muscle disorder. It is not a vascular disorder. So you cannot take an ischemic heart disease and try to do an intervention and improve the EF and say it is a reversible cardiomyopathy. So identification of this reversible causes can alter the course of the disease early, and early diagnosis is essential to improve the outcomes, because if the heart dilates or if the heart balloons out of proportion, whatever you do, you cannot bring the balloon to the back to its normal size. So if it goes more than 7 centimeters, if it is an hypothyroid cardiomyopathy, it goes in more than 7 centimeters, the elasticity goes. Okay, so you will have to diagnose it early and treat it to prevent catastrophic outcomes. So the etiology would be, reversible cardiomyopathy would be, it can be divided into an inflammatory myocarditis, infection, autoimmune granulomatous myocarditis, which includes the TB and the sarcoid, metabolic cardiomyopathy, including electrolytes like hypocalcemia, hypophosphatemia, endocrinal, thyroid, acromegaly, all those things can be included, and toxins, alcohol, chemo drugs, and there are lots of drugs, antidepressants, what you call even antiretroviral drugs. All these drugs can cause this kind of reversible cardiomyopathy. And pregnancy-associated peripartum cardiomyopathy is one common reason, and stress-induced cardiomyopathy, which is commonly known by Takotsubo cardiomyopathy. and tachycardia-induced cardiomyopathy. And there is one more newer term which is coined here is electrical cardiomyopathy. Okay, that is because of electrical reason, that is either because of left bundle branch block or right bundle branch block or bifascicular block, the heart is not pumping well. Okay, so the slowly the electrical disease gets transferred into a myocardial disease there. So that is again called as electrical cardiomyopathy. These all things are all reversible here. Nutritional, which is not very common, but thiamine deficiency is common in India, but it's more common in sub-Saharan areas where selenium, hypocalcemia, hypophosphatemia also can result in reversible cardiomyopathy. So the true incidence is not known. So the recent trials have shown that almost 20 to 50% of these some cardiomyopathies would be reversible, and it is very important to find them early and treat them early. The most common in our area, okay, in our Tamil Nadu or in India would be alcoholic cardiomyopathy. Okay, you can commonly seen in men, which is who are 35 to 55 years of age. Phenotypically and clinically, it is closely resembling idiopathic DCM. So many a time, what you will do is you will diagnose this as idiopathic DCM without taking a proper history of alcohol intake in the patient, or you will not take a detailed alcohol history in that patient. So appears to be both dose related and it responds to cessation of alcohol. Most men who take alcohol more than 80 grams of ethanol for almost per day for last 5 years will develop this alcoholic cardiomyopathy. And women who are taking lesser amount can also be prone to this. So the mechanism of injury would be a direct toxic efforts of alcohol on the myocardial muscle. It basically affects the excitation contraction coupling system. So sarcolemmal proteins are affected. Because of that, you get alcoholic induced cardiomyopathy. And many a times what happens, there can be genetic variations like alcohol dehydrogenase mutation and also DD enzymes of AC inhibitors. All these things have a predilection for this alcoholic cardiomyopathy. So 30% of asymptomatic chronic alcoholics have this some LV dysfunction, which will be noted. It is unusual for cardiomyopathy and cirrhosis to coexist, although cirrhotic patients can have asymptomatic LV dysfunction. A finding which is common in this alcoholic cardiomyopathy is many of these patients will have skeletal myopathy also. In that, you'll have pelvic and shoulder girdle, which will be commonly involved. So this is again an example of a patient, a cirrhotic patient who has no heart failure symptoms. What you see here is in a normal 2D echo, his EF is normal. Okay, I think it's not playing, but his strain echo shows a decreased value. Less than minus 16 is very much decreased value. The average value is only minus 10 here. So this is an example where you pick an alcoholic cardiomyopathy very early. You do a strain echo and pick his strain values. You could see that his myocardium are getting damaged. So treatment, as I told earlier, cessation is very important, and repletion of nutrition supplements and electrolytes also is important. With abstinence, almost 50% will have normalization of LV function at the end of 1 month. So going back to the another one, not rare, okay, very common case which we will always find out is peripartum cardiomyopathy. This you find more common in black race, in multiparous women, older maternal age, and preeclampsia. Symptoms of heart failure will be masked in this pregnancy women because they attribute many of the symptoms to the pregnant state. So they will come to you at a later state and in a sicker period. So the etiology, there are multiple etiology which have been told, like virus, autoimmune reaction to the prolactin, all those things. But the most common is it is basically an abnormal immune response to pregnancy. So what should you remember in a peripartum cardiomyopathy is 1/3 rule. 1/3 of this patient will recover completely. 1/3 of the patient will have a recurrence in the next pregnancy, and 1/3 of the patient will go into a heart failure symptom at a later point of time. So these things have to be remembered when you treat a peripartum cardiomyopathy. So follow-up echo is required. Even after the echo normalizes, you continue the beta blockers and AC inhibitors in these patients for at least 1 year. That is the usual guidelines. So going back to the another important reversible cardiomyopathy, which is a stress-induced cardiomyopathy, which occurs commonly in postmenopausal women. That is what is depicted in literature, but you can see it all over in men and also in younger females also. So it accounts for almost 1 to 2% of cases with acute MI, which will be wrongly diagnosed as MI. So Takotsubo ECG will look like an acute MI ECG, but many times you will be wrongly diagnosing it as an acute MI. So it can present as heart failure or arrhythmia, also as a VT storm. And in neuro ICU, we could see that stroke heart syndrome, where you get a stroke, your LV function can come down. that is called a stroke heart syndrome. It is also a component of a Takotsubo cardiomyopathy. So how does it happen? Any emotional or physical stress will lead to increased sympathetic activity. Sympathetic excitotoxicity will impair the heart function. And since the apex, what I say, heart apex, we always think that apex contracts towards the base in heart, but it is always the base which contracts towards the apex. So apex has the more sympathetic density fibers. So in those kind of scenarios, apex will be more affected. So because sympathetic excitotoxicity is the baseline for this Takotsubo cardiomyopathy. So apical ballooning is commonly seen. Here you could see an LV angiogram where there is an apical ballooning which is commonly seen. So the treatment is, there is no specific treatment. Heart failure treatment and beta blocker seems rational and good. It has got a good prognosis. But sometimes in ICU settings, in old age people with comorbidities, Takotsubo cardiomyopathy can also be disastrous to the patient. So coming back to case 3, again we'll go to real life scenarios. 28-year-old, recurrent episodes of palpitations, severe LV dysfunction. What you see in the ECG? Right bundle branch block with right axis. It can be an SVT with aberrancy, or it can be a fascicular VT. Okay, so if it is a right bundle branch with right axis, it is a anterior fascicular VT. Okay, because AV dissociation is not very clearly seen, but we took him to the what we did is we did an MRI for the patient. MRI, what you see is dilated LV, which you could see in the echo also, is EF of only 25%. And then we took him to the lab. When we took him to the lab, we found that it's a fascicular VT. We found out the potential, ablated the patient there. Ablated by putting a catheter inside the left anterior fascicular area, ablated it and terminated the tachycardia. Once we terminated the tachycardia, his EF almost normalized to 50% within the span of 3 months. So this is one area in cardiology where you can cure the patient. Okay, if you put a stent, it doesn't mean you cure a patient. It is by taking a bigger disease and giving a lesser disease. But here, you cure a patient completely, you need not visit the doctor again or a cardiologist again. So tachycardia-induced cardiomyopathy, it refers to impairment in LV function secondary to tachycardia, which is partially or completely reversible after you normalize the heart rate or the rhythm. It can happen as early as 6 hours of tachycardia, or sometimes it can be after a persistent tachycardia after a month. It is continued deterioration of LV function happens. Even a PVC more than 10% load in a day can cause tachycardia-induced cardiomyopathy. And sometimes when you control AFib, you control the rate, but your rhythm you don't control. When you don't control the rhythm also, sometimes you will lead to this kind of tachycardiomyopathy. So treatment will be drugs and ablations all the time. And as I was telling you earlier, a new term is electrical cardiomyopathy, where a 60-year-old person, heart failure, not responding to drugs, even from a distance, you can see this is an LBBB, left bundle branch block. Okay, and what we did for this patient is a CRTP. Okay, when there is a left bundle branch block, your current doesn't go to the left side of the heart. So if it doesn't go to the left side of the heart, it doesn't synchronize well. For that, you synchronize by putting a CRT. When you put a CRT, the patient's LV function, electrically it gets corrected. You can see the LBBB disappears now. And after that, what happens? This is before CRT, you could see the LV is dilated and it is not contracting much. There is still cavity which is preserved when it contracts. But on the other hand, after CRT, what you see? LV is very much contracting and the cavity is almost obliterating. So this is another area where you can cure the patient of a cardiomyopathy. So these are all intervention required, intervention where we do and cure the patient of cardiomyopathy. And this is one example of, very important example of a drug-induced cardiomyopathy. This is one of a paper which is published in JAC, which is olanzapine-induced cardiomyopathy, which is, many of the antipsychotics have this cardiomyopathy issues. So there are lots of drugs. Most important, your chloroquine, your antiretroviral, your antidepressant, your chemotherapeutic drugs. All these things will have an detrimental effect on your heart. So most important is chemotherapeutic. Chemotherapeutic, there are two types of damage which can happen. It can be like an anthracycline induced damage, or it can be trastuzumab, monoclonal antibodies type of damage. What is the difference between two? In anthracycline, the cell death happens. In cell death happens, whatever you do, you cannot recover the function. But in a monoclonal antibodies, many a times it is only a cell dysfunction. You can treat the patient or stop the drugs and you can improve the LV function. Many times all this chemotherapeutic induced cardiomyopathy, AC inhibitors and beta blockers can be prescribed pre-chemotherapy agents so that you can prevent or avoid the complications of LV dysfunction. So I'll finish with one more onco case. This is an interesting case of oncocardiomyopathy. A 36-year-old gentleman, papillary carcinoma of thyroid with heart failure, multiple episodes of palpitation for 6 months. His angiogram was normal. He was diagnosed to have RVOT-VT and ablated. He had recurrence on antiarrhythmic drugs. His VT episodes increased every day and it was almost present every day. So it was a slow VT which he was tolerating. So he was referred to us. What we did, this is the ECG which you could see. Here 2,3 AVF is positive in a VT, and this is one more ECG where here 2,3 AVF is negative. So what is happening here? There's a multiple sites there are VT which is coming. So at our center, what we did, we put him on antiarrhythmic drugs. ECG during tachycardia has multiple morphologies, so we didn't try to we didn't try to ablate the patient. We did a PET scan, which Dr. Prabhu was talking about. We did a PET scan. What you see here is in an orange background, you see some red areas. Okay, those are all uptakes, PET FTG uptakes, which means there is an inflammation which is present. So we did a biopsy for this patient from the node and also from the endomyocardial biopsy, which showed that in the endomyocardial biopsy, it was a non-caseating granuloma suggestive of a tuberculosis or a sarcoid. But in a node biopsy, it was a metastatic deposits from papillary carcinoma. So his blood parameters were all normal except for increased inflammatory markers. His MAN2 was positive, no active TB, and then his LV has gone severely bad. EF was around 26%, and he was running VT, slow VT all the time. So what was the working diagnosis? It was a cardiac sarcoidosis, probably, and with the papillary carcinoma of thyroid. He had an ICD implanted and started on steroids, both oral and pulse steroids. He underwent total thyroidectomy with radical neck dissection under general anesthesia. But VT and heart failure persisted. What we did, then we went back to the literature. When we went back to the literature, there are terms something called as cardiac sarcoid or sarcoidoid. Okay, here in oncology patients, there might be sometimes called as a sarcoidoid reaction. This is a papillary carcinoma. Sarcoidoid reaction can happen even in the heart, but we do not know unless we properly do the biopsy between both the node and also the heart. In oncology patients, this happens. So this distinction is very rare, but heart was showing non-caseating granuloma. And most of the time, the common mechanism here is cell-mediated immunity. And TNF-alpha is the most important mediator. What we did for the patient, we did an anti-TNF therapy with adalimumab. With that, almost his VT episodes decreased in the second day onwards. And inflammatory markers came down. Then the echo showed improved LV function. So this is another example where you will have a reversible cardiomyopathy. So January 2009, you could see on an orange background, this red spots. But in April 2009, repeat PET scan, there are no red spot here. So to recap, careful initial evaluation of the history, both the toxin and the alcohol intake and everything is very important. High index of suspicion for reversible cardiomyopathy should be kept in mind. TSH, whenever I see a patient with an idiopathic cardiomyopathy, there are few important investigations which I order. That is thyroid, vitamin D, serum calcium and phosphate sometimes, and sometimes in some cases serum iron and AC levels. All these things will be done before I label that patient as an idiopathic cardiomyopathy. And cardiac MRI and PET are useful imaging tools, especially in patients for prognosticating and also finding the treatment for inflammatory cardiomyopathies. And prognosis and outcomes in reversible cardiomyopathy is far better than non-reversible cardiomyopathy. And treatment, most of the time, is reversal of the inciting agents or causing or the cause, and supportive care is more often important. So I'll end by invoking my professor. One of my professors is also sitting here, Dr. P. Chitrambalam. Professor Dr. Balachandra Jayaraman, okay, who has been instrumental in making me read cardiology and the way I look at cardiac patients. So he always tells me one thing: see it big and keep it simple. Okay, so you need not worry about cardiac sarcoid and sarcoidoid, but do not forget about hypothyroid-induced cardiomyopathy or an acromegaly causing cardiomyopathy. Those things are reversible, and all the time it can be treated. Thank you.
Thank you, Dr. Joseph, for your excellent and informative lecture on reversible cardiomyopathy. And particularly, you have emphasized your points with a lot of case scenarios. And I hope it will be definitely useful for the practicing physicians. Thank you very much.
Thank you,
And we'll
sir.
have questions on the end of the third lecture.
Thank you, sir. For the third session, I call upon Dr. T. Geeta ma'am on the topic ABG cornerstone in ICU. Over to you, ma'am.
Good morning to all. This is Dr. Geeta, a professor of medicine, Coimbatore Medical College, and she is also a nodal officer for CBME Freedom. And she received FICP and during 2016 Apicon, associate editor of Medicine Update Apicon, and associate editor of Progress in Medicine. And she has published case reports and review articles in various national journals and delivered a SK Rogen Memorial Oration at Tapicon. And she has contributed review articles in many national nutrition journals. Now it is over to Dr. Geeta to deliver the speech.
Good morning to one and all of you gathered here, respected chairpersons, respected dignitaries on and off dais. There are so many of my students I see here, colleagues. I'm so happy to be here to deliver on a very fascinating topic. That is how I would like to call this topic, because arterial blood gas analysis always fascinates. And the topic that has been given is, it is a cornerstone in ICU management. Rather, I have put it as, is the ABG the cornerstone of ICU management? The reason why I have raised this question is, in one of the critical medicine journal of India, there was an article which suggested that in one particular tertiary care hospital in which they have taken the statistics, more than 900 arterial blood gas analysis samples were taken in a 3-month period, but only 250 samples were analyzed and it was put to therapeutic advantage. So, why? Is ABG done as a routine test where the interpretations are missed? So, rather, we need an individualized approach because it reduces the number of ABGs, the cost factor, it's invasive, it's associated with pain. So, it is highly ideal that we decide whether a patient really needs. So, how is it relevant in our day to day practice, and in particular in an emergency department or a critical care setting? ABG can never diagnose. ABG does not treat. ABG is not a screening tool. ABG helps in the diagnosis. ABG aids in therapeutic information. And this is exactly how we put it into practice. So, rather than the conventional way of talking about ABGs, I've tried to bring it to the most practical advantage that can be done on the basis of my own experiences in our ICU and on the basis of the various literature that I have referred to. So, ideally speaking, an ABG is of use, or rather, it has significance. Number 1, oxygenation. 2, ventilation. And 3, in assessing acid-base balance. Number 1, oxygenation. For oxygenation, as we all know, it is the partial pressure of oxygen. We represent it with small letter A. The partial pressure of oxygen represented by capital letter A stands for alveolar oxygen. The partial pressure for any of us, you can calculate it even now. It is your age plus 10 by 4. That is the alveolar partial pressure of oxygen that each of us needs to have. So, by finding the difference between this alveolar and arterial partial pressures of oxygen, we get a lot of information regarding diseases pertaining to VP shunt, VP mismatch, shunt disorders, diffusion abnormalities, etc. And the third important measurement is what is called as PaO2, that is partial pressure of oxygen in the arterioles divided by FiO2, fractional inspired oxygen. This ratio has an ideal usage in assessment of patients with ARDS. Second is assessing ventilation. Ventilation is the process of movement of air into and out of the lungs, whereas oxygenation is the actual process of oxygenation. So, for ventilation, we use pH. For ventilation, we use partial pressure of arterial carbon dioxide. There's one more value that is called EtCO2, that is end tidal carbon dioxide. This is not estimated using an arterial blood gas analysis machine, but if you have a captometry in the emergency department, it is an ideal instrument because a difference between PaCO2 and EtCO2 has great value in assessing number one, what is the responsiveness of a patient to CPR, the prognosis in patients with COPD, perfusion of the lung. So there are so many advantages. Next is the third important significant aspect of assessment using ABG is, as we all know, acid-base balance. The two important criteria include bicarbonate for the metabolic, PaCO2 for the respiratory. The moment we talk of acid-base disorder, we next find out which is the primary, and any acid-base imbalance will try to compensate. Body always compensates for everything that goes wrong. For metabolic acidosis and alkalosis, the body finds it simpler because the respiratory process is fast, and so the process of compensation hardly takes minutes to hours. Whereas for a respiratory disorder, it takes hours to days. This is the singular reason why, when we try to calculate the compensation for respiratory disorders, we have an acute calculation and a calculation for a chronic disorder. So, I have not elaborated on the slides. In fact, I am a bit scared of calculations. So, I have just tried to find out the easiest, nearest value, which, if added or subtracted to the value that we get, will be easy in an ICU or critical care setting for a fast workup. So, to give an example, if you have a metabolic acidosis, for every milli equivalent decrease in bicarbonate, the PCO2 can be expected to decrease by 1 to 1.5 millimeters of mercury. So, also you have on the other side the calculation for metabolic alkalosis. As I already told, when you have respiratory acidosis and respiratory alkalosis, you have an acute and a chronic compensation. Acute, for every 10 millimeter mercury increase in PCO2 above 40, that is what I've tried to indicate there, the bicarbonate rises by 1 milli equivalent per liter. If it is chronic, it is 3.5 to 5, and I have mentioned it as 4 milli equivalents per liter. And similarly, you have for the respiratory alkalosis. So let us learn about some of the facts of compensation. So it's just to reiterate, metabolic compensation is always, for metabolic disorders, it is easier. For respiratory disorders, it has got its acute and chronic components. And the determination of compensation has to be done, please underline this point, only after good history taking. Every speaker I note always mentions the significance of history taking and a clinical examination. And this is particularly true when it comes to respiratory acid-base disorders. We also have what is called as the mixed acid-base disorders. It's not always a simple respiratory acidosis or respiratory alkalosis. Many a time we have mixed disorders. It is nothing but a combination of two or more primary acid-base disorders. You have to suspect it on the basis of number one, history. I'll give you examples. 2, physical examination. 3, your serum electrolyte monitoring, the chemistries, and the anion gap. We'll come one by one. To give the simplest of examples, a patient with vomiting can have both metabolic alkalosis because of the loss of bicarbonate, and because the person goes into a state of hypotension and hypoperfusion, there is also the possibility of metabolic acidosis, predominantly lactic acidosis. Another classical example is salicylate poisoning. Salicylate induces hyperventilation and that produces a respiratory alkalosis, and the salicylate per se will produce a metabolic acidosis. Now, when do we suspect? Whenever the PCO2 and bicarbonate move in opposite directions. Though I have not elaborated, I think by now you would have understood that if PCO2 rises, bicarbonate rises to compensate, and vice versa. If it moves in the opposite direction, it suggests that there is a mixture. That means there is more than one primary acid-base disorder. Number two, you have calculations. Suppose the calculations don't meet the standard. It is either more or less. You have to suspect. Number three, you have a normal pH, but you find significant changes in PCO2 and bicarbonate. Suspect. Mixed acid-base responses can also be analyzed by the anion gap. Then I have a series of deltas to tell you. There is a delta anion gap. There is a delta bicarbonate gap. There is a delta gap. And there's a delta or the delta ratio. So all these things have always confounded me, but I found it is very simple. So what is this anion gap? So I'll tell you the easiest way to remember is a NAGMA and an AGMA. NAGMA is a non-anion gap metabolic acidosis. Commonest reason is diarrhea or renal tubular acidosis. And AGMA, that is anion gap or high anion gap, is just called anion gap metabolic acidosis. The commonest that we see in day-to-day practice is diabetic ketoacidosis. Then we'll come to a group of these deltas. So this is just to highlight the commonest reasons of NAGMA and AGMA. So what is this delta anion gap? You calculate anion gap, which is normally 10 to 12. I mean, this is normal. So higher than 12 is called as anion gap. I suppose all of you know the calculation. Delta anion gap is the extent to which or the magnitude of the anion gap. So you subtract 10, that is the baseline value of anion gap, from the anion gap that you have calculated. That is delta anion gap. Delta bicarbonate gap is 24, that is the baseline, minus bicarbonate, that is the magnitude of reduction of bicarbonate. Delta gap, this is the delta anion gap minus the delta bicarbonate gaps. The moment you start calculating, all these things are very simple. Then the delta, that is nothing but the ratio. So delta anion gap by the delta bicarbonate gap is called delta or the delta ratio. The delta gap and delta ratio are calculated differently, but the purpose is the same. The aim is to identify the presence of mixed multiple primary acid-base disorders. So don't get confused by this. Delta anion gap, you can just note down, put in your thought process later, and you will reason it out. So a delta anion gap which is lesser than the delta bicarbonate means that there is a combination of AGMA plus NAGMA. If delta anion gap is equal to delta bicarbonate, it is a pure AGMA. Commonest is DKA. If the delta anion gap is higher than delta bicarbonate gap, it means that there is an AGMA plus a metabolic alkalosis. So just note it down, then think over, you find it's very interesting. I spoke of many gaps. So we have spoken of all the delta gaps. Now, what is this osmolar gap? Whenever you find a patient in high anion gap metabolic acidosis, just calculate the osmolality and find the difference between the actual osmolality and the derived osmolality, which we do it in our ICU setting. Normally, it is less than 10. If it is more than 10, one of the commonest reasons is toxicity with alcohol or alcohol group of compounds. This is osmolar gap. There's one more gap, that is the PCO2 gap, partial pressure of carbon dioxide gap. What gap is it? So, in an ideal ICU critical care setting, you have a patient who has got a central line. Through this central line, you can obtain blood and you can get the PCO2 of the central venous blood, number one. Simultaneously, take the blood sample, arterial blood sample of the patient. So you have a venous sample, you have an arterial sample, you calculate the PCO2 difference between these two samples, and this is called as the PCO2 gap. The purpose of this PCO2 gap, this is particularly significant in patients with sepsis and septic shock because it helps in analyzing whether the patient needs fluid resuscitation, whether the patient needs an inotropic support, or if the patient has a good prognosis. All this can be assessed by this PCO2 gap. And finally, we have a saturation gap. In methemoglobinemia, ABG cannot analyze directly. But if there is a high PaO2, all of us know that if the PaO2 is above 80, it's enough. We all have a saturation, SpO2, that is 100. But you find that the PaO2 is normal or sufficient enough, 80 plus, but you find that the PaO2 is less. It suggests, in the presence of a cyanosis, it suggests highly that the person is possibly having a methemoglobinemia, and this is what is called as the saturation gap. So this is just an example of relationship. It is given in much more detail. You can go through. There is always a relationship between PaO2 and SpO2. So this is just a case scenario to tell you. I was talking so much of all the gaps and other things, but again, it all boils down to number one, history taking and clinical examination. If you do not take a proper history, I will tell you how you can be misled by just seeing the ABG and calculating the compensation. So here there is a patient. I had few more cases, but time is short. This patient is unknown. He is not able to tell his history. He comes in respiratory distress. Now his ABG was done. Nobody could talk to him. His pH obviously shows that there is an acidosis. His PCO2 is high. So what type of acidosis? There's a respiratory acidosis. His bicarbonate is 35. Obviously, there is a compensation. And if any of you had been smart enough to calculate, I'm sure you would have calculated that the compensation is around 3.5 to 4 milliequivalents per liter for every 10 millimeter mercury increase in PaCO2, which means that around 11 to 12 milliequivalents of bicarbonate have poured into the system and it has come to 35. When will 3.5 to 4 milliequivalents of bicarbonate enter? If it is a chronic state. So, ideally, if I am given this ABG or any of you given this ABG, will tell the diagnosis as compensated chronic respiratory acidosis. Am I right? But it is possible that the patient is in acute respiratory distress. For an acute respiratory distress, don't you think the bicarbonate compensation is too high? So what does it mean? There is a possibility that he has an acute respiratory acidosis with a metabolic alkalosis. So an ABG can mislead you if you do not know the primary history of the patient. So this is just to give an example. Never see anything without getting the history. Okay, we also have some other parameters, base deficit, base excess, plus or minus 2 is the normal difference. And base deficit is supposed to be a useful indicator for volume deficit in trauma patients. Now, many a time, VBG is comfortable, artery is really tough, painful. And if you go through the textbooks, you have a big column to say the difference between ABG and VBG. Again, it's a very simplified slide to say what is the major difference you need to know? The arterial pH. If you add 0.03 to the venous pH, it is arterial pH. And if you add minus 4 millimeters of mercury from the venous partial pressure carbon dioxide, you will get the arterial partial pressure carbon dioxide. So if you just remember these, it is more than enough to do a very good ABG assessment in the ICU. Now let us see a series of situations where ABG can really be put into practice in the critical care situation. In type 1 respiratory failure, please understand it is a hypoxemic situation. You need not have a change in the pH. In type 2, it is always a high PaCO2, which causes a respiratory acidosis. How do you assess a person in dyspnea using an ABG? Number 1, history. Number 2, clinical examination. Yet you have not got any interpretation. How the ABG helps is, if a patient is dyspneic, it helps us to find out whether the dyspnea is on account of increased mechanical effort, where you will have respiratory acidosis, or whether it is a compensatory tachypnea, in which case you will have a respiratory alkalosis. So these are some of the fundamentals which help you to identify the patient's nature of dyspnea. I request you for 2 more minutes, sir. And if you are going to do ABG in ARDS, I told you the most important value to be assessed is PaO2 by FiO2. ARDS is a situation where you have severe hypoxemia. A progressive hypoxemia means that the patient has got a bad prognosis. How is ABG helpful in COPD? Many of our patients come with a very high level of carbon dioxide. They are in carbon dioxide narcosis. But if the patient gets mentally uptended, then comes the role of ABG. How does ABG guide your ventilator therapy? It guides you. It guides us because we are going to be bothered about 2 parameters through the ABG when we are giving ventilatory support. Number 1 is PaO2 and number 2 is PaCO2. And for the most simple way of explaining things, if you want to stabilize PaCO2, you have to monitor and alter the tidal volume and the respiratory rate. If your focus is on PaO2, you have to bother about the PEEP and the FiO2. So you just remember these things, it's very, very useful. And BiPAP is another setting where it is extremely useful, especially in patients with sleep apnea and COPD. In bronchial asthma, you just have type 1 respiratory failure with a hypoxemia. But the patient may start hyperventilating, can go for respiratory alkalosis, and if not appropriately managed with bronchodilators, in due course you find that the PaCO2 keeps building up. It shows that the patient is in need of a ventilatory support. Pulmonary embolism, ABG does not diagnose. You have normal lungs, but you have severe hypoxemia. And that is how it is going to help you to diagnose. In diarrhea, it's a clear case of metabolic acidosis, and the only treatment is you have to treat the diarrhea. ABG in sepsis. Already I gave you an example where you use the central venous monitoring of partial pressure of carbon dioxide and the arterial carbon dioxide. You can find the difference. And in sepsis, it is also helpful to estimate the lactate levels. Lactate helps in prognostication of patients in sepsis. And one important thing you must remember, if the lactate is more than 10 millimoles per liter, please don't give norepinephrine. Epinephrine and norepinephrine produce glycolysis that will in turn further increase the lactate. So there are so many things that you get as information as far as sepsis is concerned. And of course, diabetic emergencies. Many a time, even in the past, including me, we have just given bicarbonate. No, it is not to be done. There are a lot of controversies. Initial stage of DKA, it is AGMA. Recovery phase of DKA, it is NAGMA. In NAGMA, if the patient still is acidotic, there is a role for bicarbonate. In AGMA, only if it goes less than 6.9 or 6.8, there is a role for bicarbonate therapy. So, from all this, you understand that ABG does not diagnose, does not treat, but it aids in the process of diagnosing, differentiating, prognosticating, and in guiding the management of so many conditions like DKA, sepsis, COPD, uremia, etc. And for the purpose of resuscitation also, whether you need to alkalinize, and always remember normal saline is one of the most commonly used IV fluids. It's an acidic fluid, and this can also produce metabolic acidosis. So it's a sum up. So to sum up in the most practical way, ABG is for identifying oxygenation, ventilation, acid-base balance. And a normal ABG does not mean that the treating physician is on the right track. Never use the ABG, never think that you have to bring it to the ideal pH during treatment of a patient. It is not at all. And normal PO2 does not rule out a respiratory failure, especially when you are giving supplemental oxygen. See, we have to take, it's a long thing that can be discussed on and on. When you are having supplemental oxygen, you will find that the PaO2 is 140, 150, etc. So you have to take all those things into consideration as well. And acid-base analysis has to be done only in the setting of ideal history taking and clinical evaluation of the patient. Find out for mixed respiratory disorders. Some of the mistakes all of us do, which need to be avoided, and appropriate use of ABG to be undertaken includes avoid giving lots of saline, especially when the patient has metabolic acidosis. Number two, using ABG values to dictate major decisions like intubation. The classic example I'll tell you is a COPD. Patient will be comfortable, but his PCO2 will be 70, 80. It is normal for the person. Don't intubate just because a patient has a high PaCO2. It is to be monitored only on the basis of a clinical presentation. Blindly administering bicarbonate. Never do it. And number four, endlessly adjusting the ventilator to make a perfect ABG. It's not at all needed. So I think from a very practical point of view, ABG should reach out to you and please use it. It should be patient-centric, patient-specific, so that it is of ideal value in your critical care setting. So this is something which I love a lot. Robert Frost said, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. We've got lots of things to learn and miles to go before we sleep. Thank you very much.
Thank you, ma'am, for your excellent and very clear-cut lecture on arterial blood gas analysis. You have covered all the basic aspects as well the advanced information on ABG. And you're a gifted teacher for your PG students, ma'am. Thank you very much for your lecture. Thank you.
One small question, madam. COPD with the type 2 respiratory failure is on NIV. PCO2 has come down, but reaccumulates. How will you manage? What is the advice?
Sir, BiPAP settings are ideal for it. Usually we go on the basis of the IPAP and the EPAP. EPAP is essentially the PEEP. So whenever there is a carbon dioxide accumulation, we enhance the IPAP. If there is a hypoxia, we enhance the EPAP. The difference between IPAP and EPAP is called the pressure support. So when you give an appropriate pressure support by adjusting these pressures, usually we have a very good response in the form of reduction in CO2, sir. Our patients do very well with this kind of management.
Floor is open for discussion for questions. One question to cardiologist. Sir, in stress cardiomyopathy, in stress cardiomyopathy, what is the indication to do angiogram?
Most of the time, stress cardiomyopathy, the scenario dictates, okay, whether it is a stress cardiomyopathy or not. But to definitely prove it is stress cardiomyopathy, you need to have an angiogram to show that there is no block in the vessel. So we don't usually do like that, but if there is a doubt between a stress cardiomyopathy and an MI, we want to rule out, it can, a stroke patient can develop an MI also, and that can be stress cardiomyopathy also. In those kind of scenarios, when you want to differentiate clearly, we will do a angiogram. Otherwise, most of the time it can be managed without an angiogram.
Would you like to stop ARB, ACE, beta blockers?
For whom, sir?
For the stress cardiomyopathy.
No, stress cardiomyopathy, we will continue at least for 6 months after recovery of LV function.
Thank you.
In Tokosubo cardiomyopathy, sir.
Which one, sir?
Tokosubo, some stress cardiomyopathy. That apical ballooning is 100% it is present or not?
No, initially apical ballooning was initially told as a, because sympathetic fibers are more in the apex.
Okay.
That's the reason why apical ballooning happens in stress cardiomyopathy. But there is something called as reverse stress cardiomyopathy, where base balloons and apex is normal. So commonest form is apical stress cardiomyopathy, where apical ballooning happens. But less common, there is base stress cardiomyopathy is also there.
And sympatholytics will be useful?
Sympatholytics is rational, sir, but you will use it only for heart failure, not for decreasing sympathetic drive.
Oh.
Yeah. Sir, a tachycardiomyopathy can develop LV dysfunction within 6 hours of setting of tachycardia. But many of time, it is usually at least 1 week. That is what literature says. But there has been tachycardiomyopathy within 6 hours of setting of tachycardia. And usually after ablation, the LV function will recover within a month.
My question to Dr. Geeta, madam. And PaO2 and FiO2 ratio, how does it help in weaning the patient?
Weaning the patient, I think we have to go only by of course, we can monitor it on a regular basis, sir. Any patient who is having ARDS with the PaO2 by FiO2 of less than 300, it suggests an acute lung injury. Of course, it all depends upon the basis of the ventilatory management, and we going for serial monitoring of the ABG, and at regular intervals we can monitor the PaO2 by FiO2. And one more thing to be remembered is every time if it is difficult to monitor with the arterial blood gas analysis, we can also use the SpO2 with the pulse oximetry to monitor it as SpO2 by FiO2. So it has to be only by a series of monitoring. And of course, it is not the monitoring alone. It is again to do with the clinical improvement of the patient.
When pH is normal and PaO2 and that bicarbonate is a huge deviation rather than compensation, when you think mix it, madam?
So we go only by the calculation of the PaCO2 and the bicarbonate. So we have to find out if there has been any of these parameters which has caused the compensation, or if the compensation is not on par, depending on the history again, we'll have to think of that particular metabolic disorder or the respiratory disorder.
Okay, madam. Thank you. It is very difficult to include everything in 20 minutes for ABG. Thanks for your elaborate presentation, madam.
Thank you, sir.
Yes, we are all accustomed to giving NS, and NS can aggravate the underlying metabolic acidosis. But one thing, as all postgraduate students here, there are quite a lot of people because you are the people who manage. You must remember that DKA is something which is highly dependent upon our fluid therapy and insulin therapy because the keto acids constitute the major acids which are responsible for the high metabolic acidosis. And these keto acids will be lost in the urine as you improve the perfusion. And second thing is insulin will obviously when you are giving insulin, the acidic component will become intracellular. So as a result of this, you find that the patient quickly recovers. But of course, there are studies to suggest that when it is less than 6.9, you go by your standard administration of soda bicarb, which I think all of you know by the calculation, you can go ahead. Even now, yes, we are giving as the fluid of choice, though it is recommended that if available, you can go for balanced crystalloids, which includes ringer lactate and plasmolites.
Now we close the session. Thank you, madam.
Thank you once again, dear esteemed speakers, for delivering your talks. And thank you to the chairpersons to have chaired the session. I request Dr. Ravichandran sir to felicitate Dr. E. Prabhu sir for his talk. I request Prabhu sir to kindly come onto the stage. I request Dr. Sugumar sir to felicitate Dr. Joseph Theodore sir for his talk. I request Dr. Sudhagar sir to felicitate Dr. Geeta ma'am for her talk. I request Dr. E. Prabhu sir to felicitate Dr. Ravichandran sir and Dr. Sugumar sir for chairing the session and Dr. Sudhagar sir for chairing the session. Thank you, sir. Now we start with the next session on newer technologies. I request Dr. Suresh Khanna and Dr. Chitrambalam sir, who will be joining us later, and Dr. K.V. Murali sir to chair the session to kindly come out to the dais.
For delivering the first talk of this session, I welcome Dr. Meena Kumari ma'am to the dais to give her talk on ABPM.
The outset, I thank the organizers for giving me the opportunity for chairperson. I request Dr. Meena Kumari to take over the session.
Thank you, sir. Good morning, all of you. I thank the organizers of Trichy Tapicon for giving me this opportunity. My topic is ambulatory BP monitoring. So, hypertension is a devastating disease. It's now considered as a pandemic disease with consequences and as a preventable risk factor for death. So, this picture shows the various types of BP measurements. The first one is the aneroid or mercury sphygmomanometer, which we conventionally use. The next one is the automated office BP monitor, This does not require a physician or nurse to measure the BP. So, thus it decreases the white coat response. The third one is the home BP monitor, and the fourth one is the ambulatory BP monitor, which we are going to discuss. So, a quick recap of the hypertension guidelines. A BP of more than 140 by 90 is classified as hypertension according to JNC 7 guidelines, also in JNC 8. And a BP of more than 130 by 80 is called hypertension according to ACC AHA guidelines. So, we can also study the patterns of blood pressure using the ABP monitoring. First one is the white coat hypertension, in which the office BP is high and the home BP is normal. The masked hypertension is quite the opposite of white coat hypertension, where the office BP is normal and the home BP is high. So why do we need 24 hours ambulatory BP monitoring? So this is due to the entity called BP variability. The blood pressure variability is now considered as a novel risk factor for cardiovascular disease. So various studies support this. The BP variability itself increases the target organ damage. What are the indications for ABP monitoring? So we use it in white coat hypertension, masked hypertension, nocturnal hypertension, resistant hypertension, episodic hypertension, and in patients with high risk of future cardiovascular events. It is also useful for titrating antihypertensive drugs in borderline hypertension, hypertension detected early in pregnancy, in obstructive sleep apnea, syncope, and orthostatic hypotension. And how do we use the ambulatory BP monitor? It involves measuring the blood pressure at regular intervals, usually every 20 to 30 minutes, over a whole 24-hour period, while the patients can do his normal daily activities, including sleep. It actually consists of a portable monitor that is similar to a Holter monitor, where the monitor is worn on a belt. It is connected to a standard cuff on the upper arm. When the recording is complete after 24 hours, the device will be disconnected and the computer prepares a report of the 24 hours BP, daytime BP, nighttime BP, sleep and awake BP, average systolic, diastolic BP, and heart rate. So the nighttime and daytime BP recordings on the ABP monitor can be self-reported or by fixed time reports. And every 30 minutes, the cuff inflates and deflates by itself after recording the BP. So a good ABP recording requires at least 20 daytime recordings and 7 nighttime recordings, according to the guidelines given by European Society of Hypertension. So to start with, the patient should finish his daily routine like bathing, brushing, etc. Eating, exercise, watching television allowed. No showering or driving. A diary sheet is given to the patient to note down the timings of his daily activities so that we can assess the daytime and sleep timings. So normally in a sphygmomanometer, we listen to the Korotkov sounds and we calculate the systolic and diastolic BP. But in these automated machines, we are going to use cuff oscillometry. So it measures the oscillations of the blood flow within the brachial artery. The monitor defines the maximal oscillations as the mean arterial BP, and then it uses an algorithm and calculates the systolic and diastolic BP from the mean arterial BP. So what are the advantages of the mean arterial BP when comparing with the conventional BP monitoring? So apart from measuring the mean BP, we can also find out other parameters like the dipping status, morning surge in BP, the blood pressure variability, duration of drug effects, which we cannot get these information from the conventional BP apparatuses. So this slide is very important because the thresholds of BP differ from the conventional BP apparatuses. So the BP of more than 140 by 90 is classified as hypertension according to the office BP, whereas these thresholds vary with the ambulatory BP monitoring. So the daytime BP, if it is more than 135 by 85, we call the patient is having hypertension. Nighttime BP of more than 120 by 70 is the patient is having hypertension. And the 24 hours mean BP, if it is more than 130 by 80, patient is having hypertension. So the home BP threshold is also different. If the BP is more than 135 by 85 in the home BP monitor, we classify as hypertension. So these thresholds are different from each other. Ambulatory BP values which are above normal but below the threshold values are classified as high normal values. Then we can also study the dipping status. So nighttime average systolic and diastolic BP should be at least 10% lower than the daytime average BP. And what is blood pressure load? So this is the percentage of time the BP readings exceed the hypertension threshold throughout the 24 hours. The BP load should be less than 20%. So this picture summarizes the hypertension thresholds. So here we can see the 24 hours recording where the graph shows both the systolic and diastolic BP are within the range, and we can see the dipping of BP during the night hours. The next graph shows, the first one on the right panel shows the systolic and diastolic BP recordings are above the threshold range, but still we can see the dipping. The last picture shows the hypertension, the BP recordings are above the hypertension thresholds, but there is no dipping. So the first picture is normal. The second picture is hypertensive dipper, and the third one is hypertensive non-dipper. So this much information we can get from this. The next parameter we can see is the morning BP surge. Normally we can get the normal BP surge, which is a circadian rhythm, but if it is excessive, it will be found out by the ambulatory BP monitor. So it is average 2 hours awakening BP minus the lowest average sleep BP. So here we can see the morning surge in the BP. So this is an example of the report delivered by the ambulatory BP monitor. Look at the numbers given in red. So the first rows show that the patient is having a BP in the hypertension thresholds. The daytime BP is also high. The nighttime BP is also high, whereas the dipping is only 3.9%. It's 3.9%. So the dipping is not sufficient. It's a non-dipper. And the awake BP is also high, which suggests the patient is having hypertension. Asleep BP is also high according to the ABP thresholds. Whereas the asleep summary, during the asleep summary, the nighttime dipping is 14%, which is satisfactory. So on the whole, patient is having hypertension. Like any other monitoring, ABP monitoring is also having its own limitations. It's not widely available in primary care settings. It is expensive and time consuming. It may cause discomfort during sleep. Patients may be reluctant. Imperfect reproducibility for diagnosis within 24 hours. And asleep BP often not calculated using individuals' sleeping times. And to summarize, BP variability is a risk factor for atherosclerotic cardiovascular events and stroke. ABP monitoring is a gold standard for prediction of risk related to blood pressure, better than conventional BP measurements. And also remember, thresholds for ABP monitoring differ. We have to use ABP monitoring for appropriate cases. Thank you.
Thank you, madam, for your wonderful talk. Yes, we know after the COVID era, most of the patients are using this pulse oximeter, glucometer, and BP apparatus in everywhere. Some of the medical stores and other things will have inga BP பார்க்கப்படும், inga blood sugar பார்க்கப்படும். So the patients are coming here with various BPs. சார் என்ன சார் காலையில் அங்கே பார்த்தேன் பிபி இவ்வளோ இருக்குது, இங்கே பார்த்தா இவ்வளோ இருக்குன்னு சொல்லிட்டு. So we have to judiciously use this ambulatory BP monitoring in various cases like white coat hypertension, resistant hypertension, and we can monitor the patient and correct the patient accordingly. Very nice presentation, madam.
Thank you, sir.
Thank you, ma'am. We'll have the discussion of all the 4 sessions at the end of the session. Now I call upon Dr. Vivek Sundaram, sir, to deliver the second talk of the session, continuous glucose monitoring. Kindly introduce the speaker, sir.
Sir, Dr. Vivek Sundaram, consultant, internal medicine, diabetes and critical care at Sundaram Hospital, Trichy, a 100-bedded multi-specialty center. Graduated in MBBS 2001 and MD General Medicine 2006 at Ramachandra Medical College, Chennai. Trained in critical care and intensive care at Royal London Hospital and St. Bart's Hospital, London. Several publications in international and national journals, multiple poster presentation at various international conferences, conducted multiple workshops on mechanical ventilation and as a faculty in multiple CMEs in diabetes and critical care, and critical examiner for MRCP cases. Over to you, sir.
We currently now dwell in an era where modern technology has to be integrated with human physiology to enhance patient care. In this context, I would now provide you a synopsis of the continuous glucose monitoring system, abbreviated as CGMS, which is a device which can automatically track your blood glucose 24/7. A very good morning, one and all. It's an honor and privilege to interact with you this morning, and my heartfelt thanks to the organizers for this opportunity given. In the best interest of time, I will limit myself to the modalities currently in vogue in India. The schema of my talk will be: what is the unmet need for continuous glucose monitoring system in the first place? Let us delineate time and range. Insights into Freestyle Libre. This is the intermittently scanned CGM, which is currently available in India. And we would dissect the clinical evidence, which has validated CGMS in real-time practice. And finally, the take-home message. Checking your capillary blood glucose with the glucometer is more commonly available and wide in use. When you do a capillary blood glucose monitoring, you get a snapshot of these glucose value with a single prick. And when you do multiple pricks, you get a pattern across the day, and you find all these snapshot glucose values are within the target range of 70 and 180. But what this self-monitoring of blood glucose actually misses is the unrecognized highs and the unrecognized lows between two apparently normal glucose values. So this is what your self-monitoring of blood glucose misses, and this translates into a discrepancy between these glucose values and the HbA1c, which we see in clinical practice. Glucose levels seem apparently normal, but the HbA1c is discordant. Now, this is because you do not have a continuous value. Now, this limitations of self-monitoring of blood glucose can be offset by the use of HbA1c, which is a standard measure of assessing glycemic control, your glycemic burden in the past 3 months. Your target HbA1c is 7%, equating to a mean blood glucose of 154 milligram per deciliter. Now, at similar mean HbA1c glucose values, you can have 3 possible scenarios. The first scenario is, with a similar HbA1c glucose value, you can have a patient who has a peak blood glucose of 250, who has a hypoglycemic value of 50, but still his mean blood glucose can be around 154 milligram per deciliter. Similarly, you have a patient with a peak blood glucose of 230, a lower blood glucose of 70, but the mean is same. And this patient is the ideal patient which you really earn in clinical practice. Your whole of your glucose values stays within the target blood glucose of 70 and 180. So at similar blood glucose values, you can have 3 possible scenarios, but HbA1c does not take into account your intraday peaks and your intraday troughs. It just gives your mean blood glucose value. Why is it important? Because among these 3 patients, the patient who has the limited amount of glycemic variability would fare better, because at similar mean HbA glucose values, patient who has high glycemic variability will have a higher amount of diabetes target organ damage compared to a patient who has minimal glycemic variability. By glycemic variability, I mean the swings in blood glucose values, or else it alludes to the term whereby these oscillations of glucose values beyond a mean are limited. So you want to limit glycemic variability, and you do not have a means to assess glycemic variability, and HbA1c does not take into account the hypoglycemic level. Now, these shortcomings of HbA1c led to the most improvised form of glucose monitoring, which is CGMS. Let us take a very common case scenario. a 54-year-old gentleman with diabetes for the past 8 years. He is currently on premixed insulin, 26 units in the morning and 16 in the night. He is also on metformin twice daily and is decent glucose values. When you see him, encounter him in this outpatient app, fasting of 108, postprandial is 176, his HbA1c is 8.8. Glucose values are normal, but HbA1c is way beyond target. We commonly encounter this in clinical practice. What do you think the possibilities are? The first possibility is he was probably non-compliant with diet until the day before testing. Most of our patients do it. நல்லா சாப்பிடுவாங்க. இந்த டெஸ்ட் எடுக்கிறாங்க மட்டும் ஒரு இட்லி சாப்பிட்டு போஸ்ட் பார்க்கறது. Non-compliant with insulin until before testing. கடைசி ஒரு 2 வாரமா வெளியூர் போயிட்டு இருந்தேன் சார். ஊசியே போட முடியல. டெஸ்ட்டுக்கு முன்னாடி 3 days very compliant with insulin. A1C is way beyond target. Or you do not have a standardized HbA1c assay, a biggest harbinger in our clinical practice, because HPLC is the gold standard of assessing HbA1c. A whole lot of cards, we can give you erroneous values. Or the patient probably has a severe iron deficiency anemia or a rare hemoglobin variant, which can interfere with the accuracy of your HbA1c standard assay. All these are possible. What would your next option be? I would increase the dose of insulin, considering his HbA1c is high. I would not dare do it because his glucose seems normal. So you would not consider increasing the dose of insulin. Rather, I would ask him to check his self-monitoring of blood glucose, jot it down in a logbook, and you ask him to review and sometime later. Fair enough, very much doable. But the ideal way of assessing this patient is advise a continuous glucose monitoring system. Give him a CGMS and go back again. So, as I just alluded to earlier, continuous glucose monitoring system is where you have a simple, minimally invasive, a non-obtrusive skin patch, a sensor, which is implanted in the skin, placed under the skin, and held in place with an adhesive tape. Now, this sensor has a probe which resides in your interstitial fluid, which continuously checks blood glucose values, and this data is stored in the sensor. Now, you have a receiver as such. When you swipe the receiver around 1 to 2 inches across the sensor, you get your glucose value by near communication technology. You have this data transmitted to this reader straight away. So you have a sensor, you have a transmitter which transmits these glucose values, and you have a reader. We call this the intermittently scanned continuous glucose monitoring system. But we need to understand there is a lag time between your capillary blood glucose and the blood glucose in the interstitial fluid by 10 to 15 minutes. So there will be a lag time of, so meaning your capillary blood glucose is 180, there will be a lag time of 15 minutes when you use your continuous glucose monitoring system. But you can use this reader across clothes and you get intermittently scanned real-time glucose values across the day. And what it actually does is, this probe, it checks your blood glucose every 5 minutes. So what you get is, you get approximately 288 glucose values per day. And these glucose values are basically plotted in a graph, which gives you a trend over a span of 14 days, because 14 days is the life of this sensor. So this is what you do with the CGMS. So where is it advocated? Currently, ADA recommends this in all type 1 diabetic patients on insulin. And type 2 diabetic patients on insulin, when you find there is a discordance between your CBG values and HbA1c, or you want to rule out hypoglycemic unawareness. You have uncontrolled hypoglycemia, which is the biggest harbinger to intensifying insulin therapy. Now, this gives you a very reasonable clue regarding his glycemic burden. So you need to use this approximately for at least 14 days every 3 months. Now, this is what the guidelines suggest. See, if you're going to use a CGMS, you have 3 patterns. You have real-time CGM. Real-time CGM is when this data is transmitted real-time into a device or a smartphone, which can be integrated with your insulin pump, and which either increases the dose of insulin or pauses insulin delivery if the patient goes into a hypoglycemic range. We call this a closed-loop system, which simulates an artificial pancreas. The intermittent scan CGM is what I talked about. You have a sensor, you have a reader, and reader displays blood glucose only on demand. Only by bringing the reader near the sensor would you get these glucose values. Professional CGM does not have a reader. Patient comes to you, you fix the sensor, ask him to go back, review after 14 days, and you can download this data in the software and you can retrospectively analyze his glucose levels. based on his lifestyle and eating habits. And based on that, you can tailor subsequent insulin therapy. Time in range is when it refers to the total time a patient spends within the target glucose range of 70 to 180 milligram per deciliter. So you need the amount of time spent within this target range of 70 to 180. Your target is you need to spend more than 70% of the time per day, which is 16.8 hours per day within the specific time. And that is your target of therapy. We call this a TIR. Now, TBR is time below range and TAR is time above range, which denotes the hypoglycemic and hyperglycemic time duration spent within the day. Now, these are reasonable clinical endpoints as a target for diabetes control. When you download these data, you get what is called the ambulatory glucose profile report. We call this the ABP report. In the ABP report, you get the trend over 14 days. This gives your mean glucose value in relation to the target glucose value. 70 to 180 is the target. This gives your mean glucose values as such. Span over 14 days. And you get intraday values, specifically graphical trends all across. What really interests us is three parameters. One, you have the average blood glucose, 173. Your target is 153. And you have the glucose management indicator, which is nothing but the estimated HbA1c based on his glucose values measured in the past 14 days. So this is 7.6% in this patient. And very interestingly, they can measure glycemic variability. We call this the coefficient of variation. Now, in all probability theory and statistics, coefficient of variation tells you the magnitude of dispersion above and below the mean. So the higher the coefficient of variation, more is the deviation or dispersion from the mean. Your coefficient of variation should be less than 36%, whereas it was 49.5 in this patient. Now, this basically gives you the total analysis over 14 days. So what you have in hand is nothing but his diabetes digital ecosystem. Based on this, you can tailor his insulin therapy, his eating habits accordingly. And this is your time and range target, which should be greater than 70%, 16 hours per day. Time below 70 should be less than 4%. Below 54 should be less than 1%. Above 180 should be 25. Above 250 should be less than 5%. So we call this the diabetes horoscope. Your reader would store data for at least 8 to 14 days. Look at this. You have the snapshot blood glucose value. It gives you average glucose value. This gives you the trend, whether your glucose is increasing or decreasing. And newer trends can actually anticipate hypoglycemia in the next 2 hours based on the trend of glucose values. And if you have an insulin pump, it can pause insulin delivery. Amazing, isn't it? Close to the artificial pancreas. And we have time and range per day. And it basically stores the amount of hypoglycemic events you had. I said we call this the ideal diabetes horoscope. So for every 10% increase in time and range, there is a 0.8% decrease in HbA1c. And this translates into decreasing microvascular complications, which is more glycemia dependent. We have clinical evidence to support it. So finally, why would you use a CGMS? One, you want to increase your TIR, thereby decreasing your HbA1c. At least in type 1 diabetes, when they used a freestyle Libre by Abbott, this is the continuous glucose monitoring, compared to the self-monitoring of blood glucose, you have a painless way of assessing your blood glucose without a prick. You can do it at will. All you need to do is just swipe the reader across the sensor. Thereby, naturally, your ability to titrate your insulin values will be much better. That is why you find the time in range improved by at least 1 hour per day. That is quite significant. Is it 1 hour per day compared to your self-monitoring of blood glucose? What about type 2? We talked about glycemic control. What about hypoglycemia? If you use your freestyle Libre, which is the continuous glucose monitoring system, the incidence, the time spent in hypoglycemia, time below range, actually came down by 43%. Quite significant. Why? Because same, going back again. You can have real-time glucose values scanned across using a reader. Thereby, you can have defensive snacking if you anticipate hypoglycemia. It is going to warn you beforehand if your blood glucose goes below. So all these translated into decreased hypoglycemic events. So finally, the take-home message is CGMS is very much essential in all patients with type 1 and type 2 if the patient is only on insulin therapy. Don't ever ponder using CGMS if you're going to titrate overchase. Not really indicated. Use it for at least 14 days, once in 3 months. And I would say time and range is a newer metric to assess glycemic control. Let us be sure this is not going to replace self-monitoring of blood glucose or HbA1c. It is only going to complement your estimated HbA1c by using time in range. I would rather call this the third eye of glucose monitoring. Apart from glucose, self-monitoring of blood glucose and HbA1c, this is the third eye of glucose monitoring. More importantly, not only in optimizing your hyperglycemia, but interestingly in uncontrolled hypoglycemia, where A1C, none of these would help. And the biggest constraint, the only constraint I would say is the cost. But I say if the patient is affordable, why hesitate? Thank you very much. This is just an insight of how a fewer practice would look like. This would be your outpatient clinic probably in 10 to 20 years down the lane. You will be downloading. This will be a virtual clinic. Patient is not going to be there. You're just going to download all his CGMS data, ambulatory BP monitoring data, all his vital, all his scans, and you're going to give a remote prescription. Patient is going to look, and this will be your future female robots who are going to administer injections, and we will all be operated probably by these Da Vinci robots in the future. And this is the reality. We have the new insulin nanopill coming in, and this insulin will be released only in response to hyperglycemia, and we probably have to prepare ourselves for the future. Thank you very much for your kind and patience.
Thank you very much, sir, for your very kind illustrative presentation with case scenario. Yes, you rightly pointed out, CGMS will be very useful for type 1 diabetes mellitus to prevent optimizing the blood glucose, because they are all prone for DKA. And also in the very young pediatric age group, we can avoid multiple pricks for taking the blood. Thank you, sir.
Thank you, sir. For the third talk of the session, I call upon Dr. S. Aravinda Kumar to deliver his talk on extracorporeal membrane oxygenation.
It's my pleasure to introduce my friend, Dr. Aravind Kumar. Yes, we have known each other for more than 10 years, and he's working in senior interventional cardiology at Kaveri Hospital. He's a fellow of European Society of Cardiology, fellow of American Society of College of Cardiology, and associate editor of Progress in Medicine. He has a lot of books and articles to his credit. Aravind Kumar, please.
Thanks for the introduction. Thanks, Tapicon team, for giving me this opportunity. Respected seniors, my dear friends. மேடம் ஒரு சின்ன ஒரே ஒரு சோகம் தான், நீங்கள் விவேக் சொன்னதுக்கு அப்புறம் என்ன போடுறீங்க, யாருமே கவனிக்க மாட்டாங்க. ஸோ ஹேட்ஸ் ஆஃப் டு யூ விவேக் ஃபார் வண்டர்ஃபுல். ஸோ யூ மேட் அஸ் லுக் இன் டு டயபிட்டிஸ் ஆல்சோ, பிகாஸ் ஐ எம் நாட் ப்ராக்டிசிங் டயபிட்டிஸ், பட் யுவர் டாக் வாஸ் ஸோ இன்ஸ்பைரிங், ஸோ தட் யூ லுக் இன் டு டயபிட்டிஸ் ஆல்சோ. It's always difficult to talk after a doyen who speaks so well, right? This is going to be a different, almost a different non-existing entity in this part of the world. It's extracorporeal membrane oxygenator. This is, as the name suggests, it's extra outside the body, membrane is there, and you oxygenate the body. That's as simple as that. So historically, it has been there for long years, and 1950s. Until our old past Chief Minister Jayalalitha had it, no, not many people knew it, and it became much popular after that. And some of the patients do ask us for this modality of treatment, and it has gained more importance in the corporate setup, and now metropolitan cities, and now it is also catching us. And in the last 2 years, we have done 7 cases in our hospital as well. And 1971, the first ECMO was done. And the machine, you can see from the chalk white, the whole room, now it becomes a small trolley. So it's a small trolley, we can move and get the machine, and you can do it in any part of the ICU, and it becomes much more easy. So the principle is very simple. Desaturated blood is drained via venous cannula, and carbon dioxide removed, oxygen is oxygenated, then taken back into the human body. As simple as that. So this is how it goes through the membrane, and this membrane filters and takes out the carbon dioxide and gives the oxygen and takes back. It is pumped with some pressure, so that the takes the blood out and pushes the blood with whatever is the possible pressure which is required to push the blood into the circulation. So extracorporeal life support is very much achieved by draining the venous blood, removing carbon dioxide, adding oxygen, returning to circulation through either a vein or artery. Now I'll go to the next level. Why it is indicated? It is definitely not the treatment. complete treatment and it's not the end stage treatment. You have to think that this is a bridging therapy alone. It's bridge to recovery. The primary problem is something else. Primary problem is something else. It could be a cardiac failure or heart failure or something else is there. So you are trying to bridge until the primary problem is addressed or the primary problem is taken care of. So bridge to decision, provide temporary support to patient and allow clinician to decide on the next step. And bridge to transplant, which is being done in western part of the world, where it has been their plan and until the organ is harvested and until the organ is available, you keep the ECMO for quite some time until the transplant is there. So the different configuration. So for the people who need to understand, it's very, very simple. Venous ECMO means it's only meant for respiratory problem. Romba simple. Do not think about vast thing. Venous, it is only meant for respiratory problem. You just take out, there is some problem in the oxygenation in the lung. So you take a venous sample and then again give it back the venous sample, oxygenate and give it back because you are trying to control only the venous system, so respiratory problem. Veno arterial is the one which I am concerned and I am doing it. So you take it from the venous sample, oxygenate, you are trying to support the heart. The heart is failing, you are trying to support the heart by doing then oxygenation, getting the circulation back with some sort of a pressure so that the heart function is being supported temporarily by this extracorporeal emission. And arteriovenous is the one which is a totally different, which normally we don't do it because the pressure is being generated by our human body, which is not so in our patients, and we don't want much do it in this case. So venous, predominantly the femoral vein is the bigger vein which can be accessed. So predominantly the femoral vein is being used. Veno-arterial is the one which normally we use in our setup, where you take a femoral vein and femoral artery and do the cannulation and do of the procedure. Coming to the important point of our interest is the indications of ECMO. So acute severe cardiac failure or respiratory failure with high mortality risk. The words are very important. And reversible, that is also very important. And non-responsive to optimal conventional therapy. This is the carry-home message of the whole talk. So it cannot be used as a prophylactic for everything, and it should not be used for every patient. Where the mortality is really high, mortality rate with all conventional treatment is really high. Where we have exhausted all sort of medical management and intervention management. We don't have anything to offer. Then we have to do this. But the timing is very important. When to use it? After exhausting, after cellular acidosis happens, you don't do it because that's not going to help. Anyway, the acidosis is going to kill the patient. So you have to optimally time the procedure in such a way that you exhaust all the medical management and intervention management on the given particular patient, but at the same time, the chance of survival and most importantly, reversible cost should be there. If the patient is exhausted and it is a moribund state, you don't do a ECMO and it's just a waste of time and energy. So it's only considered, ECMO is considered as a 50% mortality risk. So you are not going to save every patient. In our hospital in the last 2 years, we did 7, we lost 6, we saved only 1. So it means the mortality rate is very, very high. It's not going to be easy to save a patient with just putting echo. This is not a magic wand that patient is going to jump around and move. It's going to be very, very tough because the indications are very less and choosing the patient is very good. And for respiratory failure, which patient should not be taken. Simple is, whenever there is going to be a chronic problem, there is no point. It's not that you are not going to try and save a patient by doing a chronic ILD. What is the problem? There is hard in oxygen. You are not trying to save a patient by doing a ECMO unless you are planning for a lung transplant. Otherwise, it's not going to work. So it's going to be a bridge to transplant, not a destination therapy. So this is what you have to understand. So any acute problem, you need to see. This is the reversible respiratory failure is the one which we need to take. ARDS, pneumonia, severe acute asthma, where this is reversible. Not a COPD where it is going to be end stage lung failure, then it's not going to be. So these are the possible respiratory cause and cardiogenic shock, which I am concerned, is the primary importance in our setup, in our practice. So where most of the time the insult has happened in the recent times. That is an acute MI had happened or an acute myocarditis has happened, severe LV dysfunction, cardiogenic shock, the heart is not able to pump blood commensurate to the need of the body, then at that point of time, we need to have a system. So we have got some system. See, and there is going to be an occlusion, then go and open. We do angioplasty, fine. But there is going to be a stunning. It's not, heart is not going to respond immediately with an angioplasty. It may take 2 or 3 days, or it may take a week also. So at that point of time, what are you going to support? So we have got something. You have got inotropic support, you have got inodilators, and you have got IABP. But in spite of all these things, you are not able to have achieve the result what is there. So at that point of time, we need to have and something else. The whole system has to be supported. That's the extra ECMO is going to help us out in not only perfusing the kidney as well as taking care of the circulation. So more two organs are important. One is the coronary circulation and it is the cerebral circulation. This is going to be useful when you have a oxygenator and some sort of. So this cannot replace impella. That is a left ventricle assist device. That you have to do. That is a totally different entity, and this is a different entity. ECMO is something different. Impella is much more costlier and much more friendly to the cardiologist, but it is going to be inaccessible for many people for the sheer cost. It is 20 lakhs. This is going to be costing around 5 lakhs. So this is going to be much difference, but for whatever is available given the given place and time in this part of the world, this is going to do much wonder. So what is the typical case? Last week, 4-5 days back, we had a similar problem, patient waiting for an acute CABG, had a urosepsis, so patient was on heparin, and we had to stop antiplatelet because the surgery was planned. So patient was on single antiplatelet ecosprin, and the patient was waiting for CABG, had a acute antireval MI. I had to wheel the patient to the cath lab, do a left main to LAD stenting. So stenting went well, but the patient had a BP of 80, 50 or 60, 50 with the inotropic support. So this is the typical patient. I did a IABP. So immediately IABP, the augmented BP was 100, 110. And this patient was in cardiogenic shock, renal failure. The creatinine jumped from 0.8 to 1.8. So we know this is the patient is crashing. So we promoted patient, advised the patient attenders for an ECMO, put the ECMO, initiated. What happened after 2 days? Patient still in a cardiogenic shock. With ECMO, there was some sort of a urine output, but the kidney failure, thrombocytopenia, and bleeding disorders happened, and we lost on the 3rd day of the patient. So, in spite of all the management, whatever the possible in this part of the world, we lost. But the typical indication is acute myocardial infarction, myocarditis, severe cardiac failure, and periportal cardiomyopathy. All reversible causes can be taken. So the advantage in cardiac failure is biventricular support, bedside immediate application. So it is very easy to wheel and get the patient in. And it is not the destination therapy; it is only a bridging therapy or time to do the proper treatment. The contraindication is do not do it in an unrecoverable heart or not a candidate for transplant. So there is a chronic dysfunction. Do not try and do and waste your time on it. The mechanisms, for want of time, I'll just keep initiate, maintain, and discontinue. We have to ensure that this has been well handled by a group of doctors, not a single person. It requires a cardiologist, cardiac surgeon, and an intensivist who's all trained to do the job, as well as a physician. Dr. Dominic came to our rescue for this particular patient for the management of sepsis. So many people work as a team to get the patient out of this. The complications are many. Most of the time, we lose the patient with the bleeding complications, hematologic abnormalities, because too mmany invasive things are there, and the blood has to go through the extracorporeal system. Means platelet is going to degrade, and it is going to we lose the patient. At the time of lost the patient, the last patient, a couple of days back, the platelet was 34,000. INR was indefinite. It was not clotting at all. So these are a hematologic complication which is going to happen, and we need to address it, and we need to address. So overall, ECMO is very simple. Take the blood from the venous side, put it on the extracorporeal membrane, oxygenate, and get it back to the arterial system. And you have to, until the destination therapy is there, we can support and we can take the patient. Say possibly you can save the patient with much experience and much more. Probably a good, better team. We can make more changes and more wonders in this part of the world. Thank you for your patient hearing.
Thank you, Dr. Arvind Kumar, for an excellent presentation of a procedure which carries high mortality and beyond the pulse of a common man. Thank you.
Thank you, sir. For the final session of this topic, I request Dr. Anbarasu Mohanraj to deliver his talk on valve replacement. Is it a one-stop solution?
Dr. Anparasu Mohanraj, MS, Dippenby MCH, Director and Clinical Lead, Department of Cardiovascular and Thoracic Surgery, Medway Heart Institute, Kodambakam, Chennai. He is thesis coordinator in Dippenby Registrar Madras Medical Mission and primary investigator in Preserve Mittal, co-clinical investigator in Human Stem Cell Research Project. He has published case reports and review articles in various internal journals and posterior mitral left aneurysm, a rare case of mitral regurgitation and weight gain potential in neglected entity during valve replacement. Welcome you, sir, and over to you, sir.
Thank you, sir. Good afternoon, everybody. In the next 10 minutes, I'll try to convince you that valve replacement is not the ideal solution, and valve repair, which is being more and more commonly done, is probably the ideal solution for most patients who need a valve replacement. Now, all of us in this hall would have managed patients on anticoagulation, especially the ones who have had a valve replacement, and all of us know how difficult it's to manage a patient on chronic oral anticoagulation. Either you lose them to lower INR where there's thrombosis, especially if patient is having a mechanical valve, the valve goes for thrombosis and invariably the mortality is high. And if the INR shoots up, it becomes even more difficult. They go in for GI bleeds. If they go in for cerebral bleeds, the mortality is very high. Now, there are issues with anticoagulation. There are physician-related issues, there are patient-related issues, and there are a lot of lab-related issues. A lot of these labs in our country are not standardized. I've seen patients who had a normal INR, and then they check it up, it's low or high, and we end up not being able to manage these patients adequately. And there's a lot of literature on the anticoagulation management. I'm just pulling up a few literature here. This is this paper is from the Department of Hematology in CMC Ludhiana. And when they had a questionnaire for physicians, 2/3 of the clinicians were not aware that different strengths of acetrum were color-coded and available. And majority of them were giving verbal orders. Patients were not having literature, they were not properly instructed. And they felt that vast majority, half of these patients, which the physicians were treating, the physician felt were having thrombotic complications, and the next half were having hemorrhagic complications. Obviously, it means that all these patients are undergoing problems of anticoagulation. Now, this is from the Journal of Association of Physicians of India, and majority of these patients had hemorrhagic complications, and just 1/3 had thrombosis in their experience when they inquired with the physicians. And look at how thin the balance is in maintaining anticoagulation. Just go through the last few lines there. In MVR and double valve replacement, high risk of composite thromboembolic events were associated with INR of less than 2.1 or greater than 2.7 versus INR of 2.5, and a higher incidence of bleeding with such a narrow range of INR. It's very, very difficult to maintain these patients. And we've personally seen that even when patients have an adequate INR of about 2.8 or 3, these patients sometimes go in for acute valve thrombosis or chronic pannus formation, and the valve starts dysfunctioning. And this is from the journal Stroke, where the risk of bleeding was substantial, with major bleeding episodes ranging from 2 to 22% per year, and fatal bleedings were 2 to 9% per year. So if you take like average of these things, by 10 years, at least 60 to 70% of these patients go in for bleeding complications. Now, when we have a choice of replacing valve, we either go for a mechanical valve or a tissue valve. And the mechanical valves have the obvious complication of anticoagulation related issues. Tissue valves have a limited durability. In younger patients, they last about 6 to 8 years. In patients older than 65 years, they last about 10 to 12 years. Now, in our own personal experience, when I was in Madras Medical Mission in 2010 and 11, we tried to follow up 180 patients of these patients who had a valve replacement. And when we tried to follow up them for 10 years, at the end of 5 years, about only 50% of these patients were available for follow-up. And at the end of 10 years, hardly 20% of these patients were available for follow-up. This was actually presented in our national meeting of Indian Association of Cardiothoracic Surgeons. Now, when we look at this talk is basically on mitral valve. We're not going to talk too much about the aortic valve. We have 3 pathologies where we have regurgitation. It's rheumatic heart disease or degenerative mitral valve, which is more popularly called as myxomatous valve.
And third is the ischemic mitral valve, which occurs after a inferior inferior wall myocardial infarction. Now, luckily, with the improving healthcare system of in Tamil Nadu and Kerala, the incidence of rheumatic heart disease is grossly coming down. My own friends and pediatricians hardly see acute rheumatic fever now. Now that opens up a whole lot of degenerative mitral valve regurgitations which come for treatment to us. In fact, most of the in the last 1 year, we've done more repairs than replacements. To me, the mitral valve is a marvel of evolution. The earliest illustration of mitral valve was done by Da Vinci, and look how beautiful the mitral valve is. It's like I've just gotten the interior of a big church in Spain. Look how beautiful the mitral valve is on the right extreme picture. The chordae, the papillary muscles, and the valve leaflets are beautifully designed by nature. And just to cut and throw them into the bin and replace it with an artificial valve is not the ideal solution. So the degenerative mitral valve, it affects about 2% of the population. The spectrum of disease from fibroelastic deficiency to the Barlow syndrome. The timing of mitral valve replacement or repair in a mitral valve regurgitation depends upon symptoms with a dilating LV, a dropping EF, and development of PAH. So the common physician, the mitral valve on the right extreme, I've shown a picture. The AML is divided into A1, A2, and A3 segments, and the PML is divided into a P1, P2, and P3 segments. This understanding of the anatomy of the valve helps us in repairing the valve. Now, we can basically have a posterior mitral leaflet prolapse, which is much more amenable, which is much more common to repair. The other next pathology is anterior mitral valve prolapse, which is slightly lesser in incidence, a bit more technically challenging in repairing, but results are getting more and more standardized. Now, the results of repair are obviously better than replacement. The survival actually approaches the near normal survival in the US population. And in the repair also, the degenerative mitral valves have a much better long-term repair results compared to a rheumatic repair. And the PML prolapse obviously has a much better results in long-term also. Now, surgical technique-wise, we have either a triangular or quadrangular section of posterior mitral leaflet prolapse. If the AML or a commissural prolapse, we give artificial called the neocords. Neocords are made of Teflon or PTFE. Now, I'll just illustrate a few cases quickly next 3-4 minutes so that you can understand. So the PML prolapse is the commonest regurgitation lesion we come across. This is a 42-year-old gentleman who's thin-built, who presented with class 2 to 3 dyspnea. EF is 50. Usually when the EF drops below 55, we start advising surgery for these patients. Echocardiogram, the angiogram was normal, and that was the TE pictures. Surgically, even though we have a good transthoracic echo, we always go or we are guided by the transesophageal echo. And nowadays with the 3D echo, the quality of images are improved, which helps us in assessing the valve and addressing the problem in a better way. And that's the right extreme is the repaired valve, and the left side is what we surgically see. I'll try to skip through these because we are amidst physicians. I don't want to bore you with surgical videos. So we are trying to excise a bit of that prolapsing PML segment there. So we are repairing the resected segment. We always complete the mitral valve repair with the annuloplasty. No repair gets complete without a annuloplasty ring. And that ring is gone in. We are trying to check the valve. Look how competent the valve is now. It's called the water test. We inject saline and see how the valve repair is at the end of the procedure. This is an AML prolapse, which is a 28-year-old gentleman who presented with a class 3 dyspnea. Once again, the EF was 50%. You can see the cobra head like the prolapsing AML there. And that's the 3D picture, which beautifully shows the AML prolapse. And here you can, I'm demonstrating the gross prolapse of the anterior mitral leaflet there. So we are implanting the neocord or the PTFE cord there. I'll go a bit more faster on the video. So that's the artificial cord which is brought out, and then we attach it to the anterior mitral leaflet and repair the valve. And that's the water test being performed, and the valve is competent now. And those are the post-op echo images. So the commissures also can prolapse. Very rarely we see isolated medial or lateral commissure prolapses. And I'll quickly go through those. The commissure prolapse is actually not well seen in a transthoracic echo. The transesophageal echo shows the commissure prolapse much better and helps us in assessing the valve. And what we did is, this was a patient who also had incidental triple vessel disease with moderate mitral regurgitation. We gave him 4 grafts, and the mitral valve repair was mitral prolapse was repaired with neocords, and that's the end result there. And the lateral commissure prolapse into the 7-year-old boy who had a lot of complications during his initial infancy and came up with severe MR. He had a lateral commissure prolapse, and just an annuloplasty stitch with a ring helps us to fix this mitral regurgitation and recovered absolutely beautifully. Now, as and when we develop more confidence with these repairs, certain cases which we would not have operated at all because of grossly sick and dilated heart, we could repair and then get them out beautifully. This is a 37-year-old CRPF employee who had severe LV dysfunction, and that's the LV dimension. The LV was more than 80 millimeters. When the LV diastolic dimension exceeds 70 millimeters, the cardiologist and the surgeon as a group decide we will not try to manage these patients conservatively. Especially when you replace the valve, we cut the cords there, the subalveolar apparatus. That further brings down the LV contraction and affects the survival. So we could achieve a good repair with this patient, and look at the images. Valve is beautifully coapting there. There's no residual regurgitation. And believe me, look at the dimensions of the pre-op and post-op. It was 85 diastolic versus a systolic dimension of 7. Exactly about a year and a half after surgery, it came down to 56 and 46. Though he's got a bit of LV dysfunction right now, he's totally asymptomatic with no regurgitation. A EF of 37 for this patient is quite good. He's back to work and he's absolutely normal now. Thank you for your time, and I thank the organizers to have given me a chance to present this. Thank you.
Thank you, sir. Thank you for your wonderful presentation, sir. Any questions from the audience? Sir Vivek, sir, what's the role of CGMS in gestational diabetes mellitus?
The time in range actually varies in gestation diabetes mellitus, and the time below range also varies in gestation diabetes mellitus. It is currently advocated, but not an absolute necessity. We have this difficult to treat patients, especially a little bit of mild increase in glucose, insulin, the glucose drops in those patients. We can use CGMS as such, GDM.
Question is to Dr. Meena Kumari, madam. Regarding this ambulatory home blood pressure monitoring, as per the article, I read that only 15% of the machines are validated. Regarding the validity of the machine and how to rely on those scores, the machine validity and the scoring system and how to rely on those scores.
I agree with you, sir. Case reports do say that only 15% of the machines are valid. We have started using the ambulatory BP monitors only now, sir. So further studies are required to prove the validity, sir.
Because of late it's a must, it's getting must, it's a useful thing. But before using that, we should know the validated apparatus and which apparatus we can advise the patient or we can
Internal
buy.
we do use Meditech, sir. And we cannot compare with another machines. So Meditech machines are validated internally and we are using that, sir.
Thank you, ma'am.
Thank you, sir.
If there is no other questions, we will conclude the session. I thank all the presenters for their wonderful presentation.
Thank you once again, dear esteemed speakers, for delivering your talks, and thank you to the chairpersons for having chaired the session. I request Dr. Suresh Kumar sir to felicitate Dr. P. Meena Kumari ma'am for her talk. I request you to kindly come onto the stage, ma'am. Thank you, sir. I request Dr. K.V. Murli, sir, to felicitate Dr. Vivek Sundaram, sir, for his talk. I request Dr. Suresh Khanna, sir, to felicitate Dr. Aravind Kumar, sir, for his talk.
I request Dr. K.V. Murli, sir, to felicitate Dr. Anbarasu Mohanraj, sir. And I request Dr. Anbarasu, sir, to felicitate the chairpersons, Dr. K.V. Murli, sir, and Dr. Suresh Khanna, sir. Next, we move on to the sessions. Under the heading Mixed Basket, I call upon Dr. M. Shivakumar, sir, and Dr. Gregory, sir, to chair the sessions.
And the first topic on the mixed basket would be high BP in primary care, how to handle. For that, we invite the speaker, Dr. S. Palnivel Rajan, sir, from Arandangi.
It's a great pleasure to introduce Dr. Pranil Raj. He's a very good friend of mine. He's formerly an assistant professor of medicine in Trichy Medical College. And he's a past state finance secretary, Tamil Nadu IME. Then he's an EC member in Tamil Nadu API. And at present, he's a member of ECG Network of Trichy. With this small introduction, over to Dr. Pranil.
Respected chairpersons, my dear friends and colleagues, good noon to all. My topic here today is high BP in primary care. I'm not going to any depth of other guidelines, details, just in a primary care setup, the patient presenting with high BP, what best can be done for the best interest of the patient, and how do we handle the patients. I'll go through this thing. High BP, other words, hypertension in a primary care through the following headings of introduction, epidemiology, definition, classification in short, then 4 or 5 case scenarios, and the problem and the attitude by the patients and the doctors we face and the management. So as per the WHO estimate, 1.13 billion people are having hypertension worldwide, at roughly around 31%. That is 1 in 3 or 4 people of adult having hypertension. So hypertension is a major contributor to the cardiovascular morbidity and mortality worldwide. That's why it's gaining attention. So almost 2/3 of the cardiovascular disease mortality are attributed to a single disease, hypertension. The reason being, it is usually asymptomatic and is detected either on a routine examination, patient coming for routine checkup, or presenting for any other ailments, fever, body pain like that. Or it is usually detected most often when the patient is landing in the acute coronary syndrome or CVA. The recent meta-analysis reported that the prevalence rates of CAD and stroke have more than tripled in the Indian population. In the inter-heart and inter-stroke study, hypertension accounted for 17.9% and 34.6% of the population attributable risk for CAD and stroke. Presently, the prevalence in urban is 33.8% and in rural areas it is 27.6% with an overall average of 29.8% of prevalence of hypertension in India. So, with the variation according to the social, economic and dietary differences. Why hypertension in India is special compared to Western population others? Because onset is early in life. There is a rural-urban divide in the prevalence. There is a clustering of multiple cardiovascular risk factors, significant seasonal variation of the BP, and rising average of BP of general population, with a low awareness and low treatment and control rates, and with early hypertension mediated organ damage. This is the article published 2 weeks back in the Times of India, hypertension a tickling time bomb in the Indian adolescents. So this is the epidemiology. You can see the rate of awareness and the treatment and the control rates compared to the US. 81% of awareness against 25% in rural India, and 53% of treatment versus only 10% of the rural India are getting treated adequately for hypertension. So when you remember the SPM book, rule of halves, only half are getting diagnosed, out of which half are getting treated, out of which only half are getting controlled. This is a definition. I follow only the WHO and Indian guidelines. There is no European, no American. Indian guidelines of hypertension itself has collaborated, both taking into account the European Society and the American Heart Association, American Cardiology guidelines. So any BP with more than or equal to 140 by diastolic more than or equal to 90 millimeter mercury in any adults more than 18 years is defined as a hypertension. So this is the Indian guidelines of hypertension 4. This is a category of normal, high normal, stage 1, 2, 3, and isolated systolic hypertension, the grade 1 and 2. So let us proceed with some case history where we get. This is all the case history I got in the last 1 week or 10 days. So a 65-year-old female presenting with 2 episodes of TA-like symptoms. So all of a sudden he was normal, but suddenly feeling or altered sensorium with difficulty in speech, with unresponsiveness, but without any loss of consciousness, and recovering back within 15 to 30 minutes. So 2 episodes for the past 3 hours. Brought to me with the patient is conscious, alive, she is talking. Is a known case of hypertension on history. When the drugs for the past 5 years, the thing is he has not consulted anybody and he has changed his drug and asked, bought his, purchased his medical from the nearby medical shop saying for hypertension drugs. So on taking CT brain, it showed a intracerebral hemorrhage in parietal cortex. Luckily it was not a very huge enough, so very small. So the patient survived without any comorbidities. So this is a case history too. 55-year-old male with breathing difficulty for the past 3 days. There is no previous illness and not on any drugs. So simply saying somewhat breathing difficulty for the past 3 to 4 days. Examination, pulse BP was 220, 120 in the auscultation bilateral basal cribs. When you take an ECG, it showed evidence of endocrine damage, hypertension related, LVH. There's an additional point of tall peak T wave. That's a peculiar ECG. You can pick so many things on ECG. So the tall peak T waves suggestive of hyperkalemia. So the problem is in periphery, the patient won't be coming in the mind to take all the investigations. So you have to proceed with step by step. So after taking ECGs, knowing these findings, we can ask for the patient to do a renal function test, and it showed a urea of 55 and creatinine 3.4 with electrolytes, potassium of 6.5. So this is a case of hypertension mediated CKD. So this is a case history 3. A 40-year-old male presenting with acute onset of breathing difficulty since 3 hours. Since afternoon, he was okay. But after afternoon only, he is getting a breathing difficulty. On examination, he is having a tachycardia with BP of 200, auscultation, bilateral extensive cribs. He is having saturation of only 65%. On history taking, is a known case of hypertension and coronary disease on multiple drugs, but he is not on the drugs for the past 1 week. So this is a accelerated hypertension precipitating the cardiac failure. This is number 4, where we experience most of all, including us, a 45-year-old male among one of my own friend and professional colleague, having his BP checked regularly, irregular basis, and it is always 150/100. Actually, it was very difficult to convince him to start an anti-epilepsy drug for the past 1 year, even after initially. But after taking the drug for the past 5 years, still his BP is 140/90. He is refusing to increase the dose, saying that he used to check his lipid profile and renal function test very often and saying that everything is okay and no complications of hypertension I'm having. So why should I increase the drug? So this is the last case history. A 60-year-old male presenting for routine checkup. On examination, pulse is 80, BP 190/100, no symptoms. So this is the biggest problem with hypertension. The patient is always asymptomatic. But when you probe the history, they will say it's a known case of hypertension for the past 2 years and he was taking drug or without any consultation or any checking of the blood pressure for the past 1 year. So, but he's on the drug, in the dosage, inadequate dosage. So when I asked to check his renal function, urea was 35, creatinine was 2.2, ECG showing LVH with strain pattern. So it is again a case of hypertension inadequately controlled, presenting with a CKD and LVH. So this is a patient attitude when it comes to the primary care. They usually say it is not the correct age to take the tablets, and it is high because of seeing you always. Every time they say, sir, வெளில போனால் கட்டாயம் நார்மலாக தான் சார் இருக்கும், உங்களை பார்த்ததுக்கப்புறம் தான் ப்ரெஷர் கூடுதுன்ட்டு. So usually I say, see, while the patients are waiting hall, always you can ask the staff to check the BP outside, and you can very well discard it and you can take it again. So another thing is I can control my BP myself, no need for drugs. Since I am totally asymptomatic, even if you find out in the routine examination, they will ask why I should take a drug because I am totally asymptomatic. So there are a few set of patients who used to take blood pressure tablet only after taking non-vegetarian meals or only at the time of giddiness. And another set of patients, usually this setup happens, they stop the drug after 1 month. Since the blood pressure, we will start that patient on a drug. They will check after 1 month in the nearby medical shop. They will say the BP is normal, so they will stop the drug. So all the previous 5 case history I showed, so they are known hypertension, but they are on irregular treatment or inadequate dosage and finally presenting with end organ damage, either in a cardiac failure or in a chronic kidney disease patient. So when it comes to the physician's inertia, it is the main problem is diagnosing it as a high BP and not in a hypertension staging. So there are very clear-cut indication of staging. Once we tell the patient as you are in a stage 1 hypertension, then definitely the patient will accept and I think they will come back. So usually the history is, most of the time when you ask the history, do you have any BP checked up previously and any previous history of hypertension drug intake? Usually the patient will say, yes, I had 2 years back, I had my BP checkup. The doctor told me BP was little higher. 150 இருக்குன்னு சொன்னாரு, அதுக்கு செக் பண்ணி பாருங்கனாரு. But since I was asymptomatic, I didn't turn up. So probably the problem starts there. So instead of telling them or staging them or telling the seriousness of the complications, simply saying the BP is little bit higher side and you take care of it, and we don't staging it and we don't try to start the treatment as early. So again, not explaining the consequences, delay in initiating antihypertensives, and not mentioning that treatment is lifelong. Coming to the management, starts with the correct diagnosis and it starts with the correct measurement of the blood pressure. Always look for the evidence of target organ damage and other concomitant cardiovascular risk factors. Identification of the secondary cause and search for the cause in case of young hypertension, in case of rapid onset, in case of paroxysmal hypertension, and in case of resistant hypertension, always search for the secondary cause. So it starts with the measuring. This is the most important thing. So the patient should sit quietly, no coffee smoking within 30 minutes before. Recording should be done both in sitting and standing posture, always standing posture to anticipate the postural hypotension. And BP should be checked in both arms. And the one with the higher reading should be given more important and not the one with the lower reading. But the patient will insist us to take the lower reading, but as we should take only the higher reading. The first reading should always be discarded and the later two averaged. Inflate the cuff to 30 millimeter above the level of disappearance of radial pulse. Deflate the cuff at the rate of 2 millimeters mercury, and everything is important. So once you correctly measure the BP, then it's easy to handle. This is a correct way, a proper way of making the patient to sit and measure the BP. Sitting position, back supported with bare arm and supported arm. Is a cuff size appropriate to the arm. The middle of the cuff at the heart level. Lower edge should be 3 centimeter above the elbow crease. Do not talk or move before or during the measurement. It's with the legs uncrossed and the feet flat on the floor. So after diagnosing, noting down the BP, then we go to the investigation part, which is usually the difficult one, the periphery setup, the fundoscopy. So the fundoscopy, as you see, every physician should have a fundoscopy or ophthalmoscope in their table. When we are PGs, we are not allowed to inside the OR without an ophthalmoscope in our packet. I hope the same with now, even with the medicine PGs. So the fundoscopy is the most simplest way to diagnose a malignant hypertension to find out a papilledema. Next comes the ECG, the single best test which can find out most useful cost-effective test to find out the evidence of left atrial enlargement. So that implies the patient at any time can go in for heart failure and the presence of LVH with strain. And the next test you can order is for urine analysis to find out the renal anomaly in the form of albuminuria, and if possible, glucometer, at least with glucometer blood sugar. So these are the basic tests we can ask the patient to do once we diagnose hypertension immediately. So if possible, or say on the same or next visit, you can ask for renal function test, CBC, electrolytes and lipid profile. So I have limited the investigations to the best possible or the least you have to do when encountering a patient with hypertension and before initiating treatment. So this is a management non-pharmacological. The most important thing again is the patient education. The patient education, as I told in the previous history taking, without a proper information regarding the treatment is lifelong and he has to adhere to the medications and very good compliance is needed to avoid the complications of hypertension. That is the most important thing. Then weight reduction, physical activity, alcohol intake. There are many patients in my vaccine, purely alcohol-related hypertension is there. Once the patient stops the alcohol, the hypertension gradually comes down, and we can totally take them out of the tablets also. So always better to stop than, as advised by the Western books, to moderation of the alcohol is not applicable in our society. The salt intake to avoid added salt, to stop smoking, yoga and meditation. Yes, most of the patients will say, I don't want the tablets, I am doing yoga and meditation. Definitely yoga and meditation will help, but the maximum possible reduction in the blood pressure achieved is only 4 to 6 millimeters of mercury when it comes to systolic BP, and maximum is 4 only with diastolic BP. So this is the maximum you can achieve with yoga and meditation. You can very well say them, if they are on stage 2, yoga and meditation, definitely you won't help them alone in treating the BP. You have to start them on drugs. Probably in stage 1 you can allow. Again, DASH is nothing but a diet rich in whole grains, fruits, vegetables, and low-fat dairy products. Then it comes to the pharmacological, the management, the goals of treatment has nowadays shifted from the blood pressure lowering to overall well-being and control. That is, well-being and control of the associated risk factors and protection from the future hypertension-mediated organ damage. So the goals of treatment are shifted from mere lowering of the blood pressure. So there are 5 classes of drugs available currently for stage 1 and stage 2. So we are not bothering here about the hypertension urgency or emergency and malignancy. We are dealing only with the stage 1 and stage 2. 5 classes of drugs: AC, ARBs, CCB, diuretics, and newer beta blockers. The blood pressure lowering treatment trial is collaboration concluded. The treatment with any commonly used regimen reduces the risk of total major cardiovascular events. So the goal of therapy is not only to reduce the blood pressure, but to reduce the total cardiovascular risk events. The use of long-acting drugs with 24-hour efficacy with OD administration improves the patient compliance. The marginal titration of the doses is needed from time to time. Combination therapy always when the patient needs 2 or more drugs. Again, the goal is to prevent, reverse, or delay the complication and reduce the overall risk. The target BP is less than 130, around 130-80 for less than 60 years, and between 130 to 40 and 180 to 90 diastolic in more than 60 years. The target BP should never be less than 120-70. Diastolic BP is a more potent cardiovascular factor in age group less than 50 years, and afterwards it is systolic BP. So the slide, when to start a drug. The evidence is mixed, and primary care physician should choose a threshold based on patient preference, comorbidities, and frailty. In case of stage 1 hypertension, stage 2 you can directly start. For younger age group less than 40 years without comorbidities, the non-pharmacological approach for 1 month can be initiated. But more than 40 years, it's better to start a low-dose single pill even for stage 1 without comorbidities if the physician feels so. What drug to start first in the primary care? A drug of first choice without an investigation. When the patient denies for any investigation, it's ideally CCB. When the patient is ready to take an ECG and a young patient, then you can put a new beta blocker. Because always before putting the beta blockers, you have to take an ECG to find out whether the patient is already having any heart block or not. The drug of choice is when the renal function tests are available, when the patient is ready to take urea creatinine, then it is definitely AC and ARBs. When it comes to old age, when the patient is ready to take electrolytes, then monitoring, then it is CCB along with diuretics. Without any investigation, it's again CCB. The follow-up is review after 2 weeks, always after starting a new drug, and always caution about the first dose hypertension to the patient. Once BP is stabilized, it can be reviewed monthly or once in 3 months. This is the final word. The trials describe population averages for the purpose of developing guidelines, but it is the responsible physician's judgment, and the decision remains paramount for clinical decision making for individual patient. Thank you. Actually, hypertension is going to the next pandemic because the government of India started initiative. So only 10% of the rural patient is already in control. So I think it is going to be year of next 1 or 2 days hypertension, like diabetic clinics. Hypertension clinics is going to come up in a long way. I thank you. I thank the organizers and the scientific committee, Tapicon, for giving this opportunity. Thank you.
Thank you, sir. This is a very much practical and useful talk on for primary care physicians, sir. Thank you.
Thank you, sir. Next, we invite our next speaker, Dr. A.P. Nandakumar from Erode, for the next topic.
I'm very proud to introduce Dr. Nandakumar, consultant physician diabetologist from Erode. He is a consultant, KMCH Erode, Vice Chairman API Erode, Joint Secretary IMA Erode, State EC member TNA API. Area of interest, various publications in the field of diabetes and hypertension. Over to you, sir.
Good morning. At the outset, I thank the Trichy APA and the organizing committee and scientific committee of Tapicon 2022. So today's my topic is PCSK9 inhibitors. So dyslipidemia is a very commonest problem in recent OPDs, and last 10 years we come across young adults with the dyslipidemia due to the obesity and lifestyles. So being a physician, we should, it's usually asymptomatic. So we should know whom to evaluate and to prevent the cardiovascular disease as well as cerebrovascular disease. So many times people with elevated total cholesterols, triglyceride and LDL and ApoB and reduced HDL and this type of dyslipidemia is common, and this is the commonest risk factor for coronary artery disease as well as cerebrovascular disease. And commonest cause is lifestyle due to sedentary lifestyle and type A personalities, and other reasons are hypothyroidism. We should evaluate always a hypothyroidism, nephrotic syndrome, and obesity, pregnancy, and SLE. These are the commonest other reasons for dyslipidemia. So we have to screen anybody who is obese with age more than 40 years, women obese or age more than 50 years, or post-menopausal women, and other risk factors like diabetes, hypertension, smoking, and abdominal obesity, type A personalities, and with the family history of early cardiovascular disease, and physical signs of dyslipidemia at any age like xanthomata and xanthelasma and arcus cornea. And we should also evaluate any evidence of existing atherosclerosis at any age should be screened for dyslipidemia. So this is the eruptive xanthomata or forearm of the patient with severe hypertriglyceridemia, and this is the due to xanthelasma and tendon xanthomata in a patient with severe increased LDL in a familial hypercholesterolemia. There are many drugs are available for dyslipidemia for the treatment. We all know the statins is the commonest use of statin in medicine OPDs nowadays, common especially in diabetes and hypertension, because dyslipidemia is coexisting in this disease. So atorvastatin and rosuvastatin are commonly used, and drugs like bile acid binding resins and fibric acid derivatives, nicotinic acids, and cholesterol absorption inhibitors also used. Despite using in this statin, sometimes many patients are still the LDL level is not achieved less than 100, or in high risk patients we may achieve to reduce to 70, because dyslipidemia is a very common cause of young MI and strokes. So it is our duty to evaluate the dyslipidemia and treat properly. And so in such case, when the statin fails, so there are we need to start a newer modalities. All these years we have only oral dyslipidemic drug. Now recently the PCS9K inhibitors, it is injectable forms, so it can be used for any dyslipidemia which is uncontrolled by statins. So the PCSK is first US FDA approved drug was around 2015. This PCSK9 inhibitors are mainly it improves the LDL receptors, and by which it improves the reduces the LDL cholesterols, and by which it reduces the lipid metabolism and plaque stabilization, and even it reduces platelet aggregations. This is the PCSK9 mechanism, where PCSK9 and LDL particles and LDL receptors, and which is very important in maintaining the lipid metabolism. And the PCSK9 inhibitor prevents the increase in LDL level. And this is the target of PCSK9 level. This PCSK9 contains the signal sequence and N terminus followed by the catalytic domain and the cysteine-rich carboxy terminal domain. And this have a opposite effect, lowering the LDL cholesterol levels, and by which reduces the risk of CAD. So the PCSK are one of the newer molecules. When the growing number of statin adverse patients with the limited alternatives, and especially in population with severe hypercholesterolemia and familial hypercholesterolemia, both heterozygous and homozygous, where we do not achieve optimal LDL level, which can lead to many cardiovascular and cerebrovascular events. So in such cases, and reducing LDL cholesterol will improve the outcome and reduce the CVD risk and mortality and morbidity. So there are PCSK inhibitors. They have the monoclonal antibodies, which is approved in India, and other PCSK inhibitors like antisense oligonucleotides and small interfering RNAs. And this is approved in USA, not in India. So this blockade in PCSK interaction with LDR via monoclonal antibodies. Such two drugs are available in India. That is as per ESC and EAS guidelines. And according to the LDL level, we can divide with high risk and risk, mild, moderate to moderate risk, and along with the coexisting CVD and pre-existing any other vascular disease. Target should be varied according to the risk level. The recommendations for the PCSK inhibitors in relation to patient clinical status and LDL level, the primary and secondary prevention, it can be used according to the risk factors like any CAD or CVD, any peripheral vascular disease, and the LDL level less than 100 or between 70 to 100, it should be used in such cases. So this Irinotecan, it is available in India. It is the first PCSK inhibitor approved by US FDA, now available in India. Second is Avalokumab. It is also US FDA approved, and other drugs are still in trials. This inclisiran is it is US FDA approval drug. It is the this drug is one of the potent drug which is available in US recently. It can reduce the CAD and cerebrovascular accidents by around 38 to 40%. And many studies proves that the elevated LDL cholesterol cause multiple vascular events. In this result, after using the PCSK9 inhibitors, there is a high level of LDL reduction is seen in this inclisiran group compared to placebo. And the two doses of 300 milligram inclisiran regimen produced greatest reduction in LDL cholesterol levels. 48% of patients who received this regimen had an LDL cholesterol below 50 milligram per deciliter. So the serious adverse reactions are commonly the injection site reactions and nasopharyngitis and myalgia. So this PCSK9 inhibitors can reduce the LDL cholesterol and to the target level, and by which it can reduce the cardiovascular risk. And this is the it's the RNA therapeutic inhibitor of PCSK9. It is a long-acting RNA interference therapeutic agent. It inhibits the synthesis of protein convertase subtlesin hexin type 9, a target for lowering of LDL cholesterol. There are many trials which supports the use of PCSK9 inhibitors for reducing the cardiovascular and cerebrovascular events. The common side effects are musculoskeletal strain, nasopharyngitis, and myalgia and diarrhea. And there is no serious adverse events are seen. And there were one grade 3 elevation in the glutamyl transferase level, which is considered to be the investigated to be related to statin therapy. The reduction in level of PCSK9 and LDL cholesterol maintained at day 180 for doses of 300 milligram or more, and by which it's a potent reduction of LDL level. And in multiple trials, there is no serious adverse reactions were seen in this PCSK of inclisiran and other drugs also. So the alirocumab, this is the available monoclonal antibody drug in India. It's around it can be used 75 milligram once every 2 weeks subcutaneously. Other alternative doses around 300 milligram once every 4 weeks. If the LDL response is inadequate, the dosage can be adjusted maximum 150 milligram to maximum 150 milligram every weeks. But it can be used only in adults. The evolocumab, it is the other monoclonal antibody drug, which is available in 140 milligram. It can be used every 2 weeks or 420 milligram once in a month, but it can be used in above 10 years. So the 420 milligram dose can be administered over 5 minutes using the single-use infusion or by giving 140 milligram injection consecutively within 30 minutes. And it can be used in a heterozygous familial hypercholesterolemia. Dosing is 140 milligrams subcutaneously every second week, every 2 weeks, or 420 milligrams subcutaneously once a month. For adults and children aged 10 years and older with homozygous familial hypercholesterolemia, dosing is 420 milligrams subcutaneously once a month, but it can be increased 420 up to 420 milligram every 2 weeks if it is the response is achieved in 12 weeks. There are many clinical trials which supports the PCSK9 inhibitors as an emerging treatment for lowering cholesterol, by which we can prevent young MIs and strokes. These are the many trials. The 12-week trial conducted among patients with primary hypercholesterolemia with mixed dyslipidemia. The PCSK added to moderate to high intensity along with therapy resulted in reducing the LDL cholesterol, and by which it improves the outcome in CAD and stroke patients. So this alirocumab in a hyperdyslipidemia, it is the one of the promising drug, and which can prevent progression of atherosclerotic cardiovascular disease. Like the many drugs, like many trials are conducted, like Odyssey trials, Fourier trial, all supports the PCSK9 inhibitors for reducing LDL level, by which the reduction in cardiovascular and cerebrovascular events. But only few side effects are resulted, which are like muscle cramps, myalgia, and nausea and vomiting. There is no specific organ damage or toxicity reported, and there is all effective reduction in all components of cholesterol like LDL, total cholesterol, triglycerides. There is a mild to no elevation in HDL noticed. Being administered in weekly dose, and in a dose-dependent reduction in plasma ApoB and LDL-C and total cholesterol and triglyceridemia are observed in 47% and 40% and 41 and 63% respectively. It is also associated with the appreciable reduction in the above factors, and regarding the comparison of efficacy of new agents, both newer alicromab and evacumab achieves the LDL reduction in a 3 months level. And this is the clinical practice. Indication is primary and secondary hypercholesterolemia, homozygous familial hypercholesterolemia, and established ASCVD. Administration, as I said previously, the benefits LDL cholesterol reduction by 61% and 61% reduced TB agents events. And iricumab is used in primary and secondary hypercholesterolemia and established ASCVD, and it can be used in 75 milligram every 2 weeks subcutaneous, and it is also 62% decreased rate of MACE seen. And the other drug is still not available in India. So there are many trials supports the PCSK inhibition, by which we can reduce the MIs and strokes and non-fatal CV events, and so it can be used as a preventive tool, and in India it is used only by cardiologists, but it's a physician drug for preventing any cardiovascular and cerebrovascular events. Thank you.
Thank you, sir. We'll move on to the third topic of the session. I request Dr. M. Gunashekharan, sir, to come over to the dais. The topic for this session is the drug which does wonders in heart failure. I request the chairpersons to introduce the speaker.
It's a great pleasure to introduce my bro, Dr. Gunashekharan. He's a consultant physician and managing director of Dravidan Specialty Hospital, Pattukottai. He is a fellowship in Indian College of Physicians. He's a member of ECG and Echo Club of Trichy.
Slide. The full screen slide. Full screen slide. Full screen.
Secretary AP Pattukottai is an State Council member, API, EC member, coordinator RSDI, organizing secretary first South Zone and South Mid Zone Tapicon 2021, and organizing secretary Tapicon 2021. He is a principal investigator in JAT Landscape, Indian Phenotype Registry, IHS, IHS2, TITE and TITE2, Riodra 3, and Legacy and SAY studies. Presented and published papers in IAP India and the Journal of Hypertension, ACCEL. With this small intro, over to Dr. Gunashekharan.
Thank you, Chairperson, for the nice introduction. And my topic is the one class of drugs which does wonders in heart failure. The burden of heart failure in India is very high, and the prevalence is around 1%. And patients with heart failure in India affected at a young age and have a very high mortality both in hospital as well as also after discharge. The mean age of patients very young, and in hospital mortality around 30%, and post discharge mortality around 6 months. And you compare with cancers, actually the heart failure mortality is more high. The 5-year survival rate of heart failure is only 50%, which is very high than that of the most of the cancers in men as well as women. The goals of heart failure care are to increase the survival by reducing the mortality and reducing sudden cardiac death and death from progressive heart failure. And second, reduce hospitalization because hospitalization incurs a bad prognosis as well as the cost. And third one, make the patients feel better, improve symptomatically and quality of life, and slow up
deterioration. To achieve this goal, we have 4 pillars, that is ACE inhibitors or ARB and beta blocker, MRAs and as well as SGLT inhibitors. According to 2022 guidelines, if you look at the patients with symptoms and heart failure, that means that those with ejection fraction less than 40, the first line of drugs will be ARNI. If you look at the other categories, symptoms with heart failure with mid-range ejection fraction, here ARNI will be class 2A recommendation. If you look at the group, that is those with preserved ejection fraction, here also ARNI comes under class 2A recommendation, whereas SGLT inhibitors score overs in those with symptoms of heart failure, whether ejection fraction is less or high. If you look at the data and guidelines, even for the prevention purpose, we can choose SGLT inhibitors in diabetic patients. Even those patients who have structural defect without symptoms by elevated NT-proBNP or either systolic dysfunction or diastolic dysfunction or LV hypertrophy in patients with diabetes, we can choose SGLT inhibitors. This is very strong recommendations by the 2022 guidelines. In 2023, definitely SGLT inhibitors will move one step ahead and become first line strong recommendation for reduced ejection fraction, mildly reduced ejection fraction, as well as preserved ejection fraction. How? That is the evolution of heart failure trials. The first heart failure trials was EMPAREC outcome to reduce the 3-point MACE, non-fatal MI, non-fatal stroke, as well as cardiovascular death, which was significantly reduced from EMPAREC outcome. But here the twist came from the trial. The secondary endpoint, heart failure hospitalization, was significantly reduced. Then multiple other trials, that is CANVAS with canagliflozin 100 and 300 milligram, and Credence trial in patients with diabetic kidney disease, and DECLARE-TRIMI trial, one of the longest and largest trial with cardiovascular disease and risk factors, shows significant reduction of heart failure hospitalization. So the first wonder was anti-diabetic drugs proved to be a heart failure drug. Then for heart failure, other drugs with heart failure with reduced ejection fractions was conducted, and these drugs become pillars of heart failure therapy. Specifically to say, the first trials was DAPA heart failure trials in 2019. ESC cardiology, the trial was published, but this trial receives 2 standing ovations. This was a very rare occasion, a trial receiving 2 standing ovations. First, for the fact it works in heart failure. Second, for the fact it works in non-diabetic heart failure also. So this is second wonder of the drug of SGLT inhibitors. At the same time, other trials was initiated, that is Emperor reduced trials, which also shows significant reduction of CV death as well as heart failure hospitalization. Meta-analysis of both trials, that is Emperor reduced as well as DAPA heart failure, both shows nearly 26 reduction in the primary endpoint as well as 14% reduction in the CV death. And this is quite interesting fact from Emperor reduced as well as DAPA heart failure. If you look at the graph on the left side, the another twist came. That means that even though there was initial declining of EGFR, the EGFR was very well maintained after that. This is the second twist from that Emperor trial. And meta-analysis of both Emperor reduced and DAPA heart failure, which shows significant reduction of the heart kidney outcomes. That means reduction of albuminuria, progression to end-stage renal disease, and progression to dialysis was prevented, so that this is the only drug in heart failure class which has kidney-friendly drug. And other trials, that is solo used worsening heart failure trials, there was a discussion with Dr. Sanmugavelu sir session in the corporate symposium whether to initiate SGLT inhibitors in the hospital. But this trial specifically enrolled patients with recent hospitalization with LV ejection fraction 50%, less than 50%, and more than 50%. This trials also shows that significant reduction of the primary endpoint. So we have consistency of data for dapagliflozin, empagliflozin, as well as sotagliflozin in heart failure. And the other type, that is already the drugs reduced heart failure hospitalization as well as reduced cardiovascular death. The third goal, that is symptoms. From the Kansas City Cardiomyopathy Questionnaire, from Emperor reduced as well as DAPA heart failure, there was more than 5-point improvement in the quality of life of patients, which was even in some of the category of patients, there was more than 15% improvement of the quality of life. This is specific and unique to the drugs. So this is another wonder in heart failure by the SGLT inhibitors. And so evolution of SGLT inhibitors, as I already said, it works in heart failure with reduced ejection fraction. Now I am going to give evidences for mildly reduced ejection fraction as well as the preserved ejection fraction category. The mildly reduced ejection fraction as well as preserved ejection fraction category, there are a lot of trials starting from digoxin, ARB, and candesartan and irbesartan, as well as MRA, as well as RNA. If you specifically look into the endpoint, MRA, RNA are scores, but the Emperor preserved trial, there was significant reduction of the primary endpoint. And RNA, the same trial, which shows only 13% reduction of the primary endpoint. So SGLT inhibitors from Emperor preserved trial scores over well than the RNA. And even in the subgroup analysis, those with ejection fraction less than 50 and 50 to 60 and more than 60, the hazard ratio was significantly reduced with empagliflozin. And so in Emperor preserved trials, the heart failure hospitalization was drastically reduced and CV death also. So it is another wonder in those patients with mildly reduced ejection fraction. And from solo use worsening heart failure, that is heart failure patients, hospitalized patients with acute status also. If you look the category, 79% of patients with LV ejection fraction less than 50 and 21% of patients with LV ejection fraction more than 50. In both groups, less than 50 and more than 50, there was significant reduction of the primary endpoint in the hospitalized patients. So, meta-analysis of Emperor reduced and Emperor preserved was performed. Those patients who have LV ejection fraction less than 60% has benefit from both meta-analysis. But one point is, in those with ejection fraction more than 60, this benefit was attenuated by the Emperor reduced as well as Emperor preserved. So for which specific trials, DELIVER trial was conducted and the results are published recently in the European Society of Cardiology, August 2022. The kidney outcomes to be presented this month in the American Society of Cardiology. So DELIVER trials also shows that significant reduction of the primary outcome as well as heart failure hospitalization. If you look at the age category, those patients with less than 50, 50 to 54, 60, and even more than 70 years, all the primary endpoint was significantly reduced in the delivery trial. The mean age of the patient in delivery trial was 70 years of age. Even with that age, these patients shows benefit with dapagliflozin. Even if you look the sub-analysis of the category, those with LV ejection fraction less than 49 and 50 to 59 and less than more than 60, these patients also has significant reduction. So that if meta-analysis of Emperor preserved trial and DELIVER trial performed, definitely it will be the first line drug for those with preserved ejection category of above 60%. And this is another one of the interesting trial, that is impulse trial. 200 patients up receiving empagliflozin 10 milligram and another 200 patients receiving placebo. That empagliflozin was initiated within the hospital with acute heart failure and the 90 days mortality was assessed. This trial is one of the separate trial. We already analyzed cohort of patients with another cohort of patients, but this technique developed uniquely by the Europe people, where one patient receiving empagliflozin to be compared with another 200 patients of placebo. So 200 plus 200, nearly 4,000 data was received on the heart failure hospitalization and time to death as well as quality of life was assessed at 90 days. This was significantly benefit in those with empagliflozin initiated within the hospitalized patients. So we can safely initiate SGLT inhibitors within the hospital. As I already said, we have solo-used worsening heart failure trial and impulse trials, which was at par with like ARNI. We can safely initiate this class of drugs in the hospital. And another one, this is Rosano et al. Group published a paper with various comorbidities, that is various phenotype of patients. Our heart failure patients have bradycardia, tachycardia, hypotension or hypertension or atrial fibrillation or chronic kidney disease or hyperkalemia. Even with this 11 phenotype of patients, you can safely initiate SGLT inhibitor except a eGFR less than 20 ml per minute. And it works in reduced failure and mildly reduced heart failure and preserved heart failure patients. Whether we can prevent heart failure with this class of drugs, for which a Pontiac study was conducted, one of the pioneer study. Many of the cardiologists know about the study. 300 patients were enrolled based on the NT-proBNP level. The aim is reduction of NT-proBNP up to 50% by uptitrating the beta blocker as well as the ACE inhibitors. When uptitrated and NT-proBNP is reduced, the hospitalization and death to cardiovascular disease drastically reduced. So based on these trials, the TB group formed a risk score, that is prior heart failure, NT-proBNP level, as well as high sensitive TRAPA level. Based on this, those patients have elevated number will have high mortality. That means that we can use NT-proBNP in diabetic patient as a marker to detect the hidden heart failure risk, and we can treat with SGLT inhibitors. This is another trial that is from Canvas, which also shows those with NT-proBNP above 125 have very high risk of heart failure. So this is another wonder. For the prevention purpose, we can use SGLT inhibitors in diabetic patients as well as those patients have elevated NT-proBNP or structural defect, whether in the form of systolic dysfunction or diastolic dysfunction or diabetic with LVH. So based on the trial results, all guidelines was framed from 2021 to 2022. 2021 Canadian mainly concentrate on heart failure with reduced ejection fraction, whereas 2021 also recommend ARNI as the first line of therapy. But look at the 2022 guidelines and the SGLT inhibitors place, which is slightly move on to 2A recommendation in those with LV ejection fraction 41 to 49. Few more minutes. Same, it applies to preserved ejection fraction in those with 50% SGLT inhibitors move on to 2A recommendation. Definitely, based on the deliver trial results, the next year publication will be SGLT inhibitors will be a strong recommendation in all type of heart failure patients. So heart failure patients, the evidence-based drug to be initiated before discharge, and we have to initiate ARNI, beta blocker, MRA, SGLT inhibitors within the hospital. The one drug which do not need titration is SGLT inhibitors. For all other drugs, we have to need titration, we have to check potassium, we have to check BP and everything. So we have evidence-based drug class TAPA as well as EMPA for heart failure, and this class of drugs works across the spectrum of heart failure patients. So other qualities of this class of drug, it is one pill once per day, no dose titration. It improves survival and prevents hospitalization, meaningfully improves the quality of life and functional status of the patient, and benefits appear rapidly within days to few weeks of initiation, even in the hospital, and exceptionally a well-tolerated drug and is very, very safe. Already I said, even in 11 phenotype of patient, you can choose HLT inhibitors. And it does not lower blood pressure like ARNI and other drugs. And no renal effects, adverse effects, and instead preserves the kidney function and preserve dialysis. This is very, very important. The only kidney-friendly heart failure drug available now. And this, of course, for Indian market and our heart failure patient, it is affordable and easily accessible. Thank you, everyone. First of all, I thank the organizing secretary Muthumani to allot a slot for me, and thank my Annan chairperson and every Annan in the Trichy. Thank you, Ananda.
Thank you, sir. Thanks for your relaxed lecture.
Thank you, sir. For the last topic on the session, I request Dr. A.S. Sendilvelu, sir, to come over to the dais. The topic for the session would be prevention of diabetes, myth or reality.
Welcome, sir. Dr. Sendil Velu. Yes, here MBBS, KMCH Chennai, MD Internal Medicine, MMC Chennai, Echocardiography and Ultrasound, Whole Body Color Doppler training at Apollo Hospital, Chennai. Special interest in diabetes and prevention of diabetes. Started Erode Diabetes Foundation in Erode. Regional faculty for PHFI, IDF, along with Dr. Mohan's Academy since 2010. Principal investigator for ongoing trials, Landmark, ATOS, Tamil Nadu State AAP Executive Council member since October 18. Over to you, sir.
Nice introduction. Thank you, Chairperson. So first of all, I extend my thanks to Tapicon Trichy organizers, Chairman Seduraman sir and Shanmugavelu sir, and all organizers, and Vice Chairman Palnivel sir, Palniyappan. And first of all, this prevention topic, I started 20 years back when we started our practice in Erode, where at the time when we started doing CME programs, diabetes we start with very few drugs and insulin. So to attract more persons, this prevention of diabetes came into help for me. So is it really a myth or reality? Because in our place, many Ayurvedic, many natural and மர்மக்கலை எல்லாம் நீங்கள் எதுக்குங்க மாத்திரை சாப்பிட்றீங்க, வாங்க நம்ம மர்மம் வைப்போம், மாத்திரையை நிறுத்தியிருக்கேன்றவாங்க. சுகரே பார்க்காதீங்க. அவங்களோட வெரி ஃபஸ்ட் இன்ஸ்ட்ரக்ஷன், நீங்கள் எதுக்கு சுகர் செக் பண்ணுறீங்க, உங்களுக்கு எதாவது ப்ராப்ளம் இருக்கா? நோ ப்ராப்ளம், காலரிச்சல்லாம் இல்லை. எதுக்கு சுகரை பார்த்து 250 பார்த்துட்டு பயந்துக்கிறீங்க? ஒரு 6 வாரம் வர்மக்கலைக்கு வாங்க, சுகர் கம்ப்ளீட்டாக சரியாயிரும். ஸோ இந்த இன்ஸ்டிகேஷன் தான் இந்த டாப்பிக்கை பற்றி ரிசர்ச் பண்ண வச்சுது. அப்போ தான் 2003 டிபிபி ப்ரோக்ராம் வாஸ் லான்ச். ஸோ தட் ஹெல்ப்டு இன் பிரிங்கிங் திஸ் இன் டு த பிக்சர். ஸோ ப்ரிவென்ஷன் ஆஃப் டயபெட்டிக்ஸில் ஃபஸ்ட்டு டயட்ரி ப்ரோக்ராம். இது இன்னொரு ஸ்லைட்ஸ் இருக்குது பாருங்க. எக்ஸ்கியூஸ் மீ, இன்னொரு ஸ்லைட்ஸ் இருந்தது, இதை போடுங்க. சரி சரி, இதே இருக்கட்டும். ஸோ இதை கோல்ஸ் வந்து என்ன பண்ணோன்னா, டயபெட்டிஸ் ப்ரிவென்ஷன் ஆரம்பிக்கிறப்பவே ஃபஸ்ட்டு டயட் ரெஸ்ட்ரிக்ஷன் பண்ணி, கார்போஹைட்ரேட் ரெஸ்ட்ரிக்ஷன் பண்ணிவிட்டு டு ஷோ தட் டயபெட்டிஸ் கேன் பி ப்ரிவென்டட். ஸோ மெயினாக நியூட்ரிஷனல் ஆஸ்பெக்டில் வி ஸ்டார்டட் கான்சன்ட்ரேட்டிங் இன் generally reducing the general cold, specific cold. So first we started assessing the calories patients are taking. So first IGT, normoglycemia with obesity, and then diabetic patients. So then we determine with anthropometrics, calculation calories, making a meal plan and follow. ஸோ அதுக்கப்புறம் அசஸ்மெண்ட்டை பண்ணி முடிச்சதுக்கப்புறம் வாட் இஸ் த கலரி ரெக்குயர்மெண்ட் ஃபார் ஈச் பேஷண்ட் பார்த்துட்டு ஐடியல் பாடி வெயிட் ஒபிசிட்டி ஓவர் வெயிட் ஹெவி பேர்டன் சொல்லிட்டு வி ஸ்டார்டட் அசஸிங். ஸோ திஸ் இஸ் அபவுட் டைப் 1 we made a plan. So Indian diet, you know very well, that constitutes 60 to 65% of calories. So அதை வந்து from 65, we aim to reduce less than 50 as a low carbohydrate diet. So அதில் வந்து whatever the carb people are taking, we started reducing by 15% from 65 to 70 to 50 and less. So almost you take any part of India, almost all plant contributors carb by 50, more than 65%. ஸோ அதில் கார்போஹைட்ரேட் ரெஸ்ட்ரிக்ஷன் பண்ண சொல்லிட்டு ஈட்டிங் ஹேபிட்ஸ் அனலைஸ் பண்ணிவிட்டு தென் among the components what is free sugar with alcoholic sugar and short chain carbohydrates, அதில் how to reduce the glycemic load. So all these things were taken into consideration. So அதில் பார்த்தீங்கன்னா how to select carbohydrates is very important thing to educate and implement what we intend to implicate. So diabetes prevention is possible provided we always take into consideration of this GI measurements and other things. So after this, the glucose load alla nariya irukku slides, because of the paucity of time I restrict. So if we look at this, if you take bajra roti, kambu, mini millets, idella eduthu pannakulla it is only 55, whereas our Gujarati meal where contain lot of sweets and carb is again high. So same thing with more carbohydrate, more green gram. So this food pyramid we constantly educate and make it workable with base with more whole grain cereals and followed by snacks with a small quantity and fermented foods which are high one. So sparingly, moderately and use liberally we contain, and whatever put it in green is a low GI diet, medium diet is in the orange, and red is a high GI diet more than 70 we would like to discourage. So if we constantly do this and make it a workable plan, it is possible to prevent. So what we should eat, many patients ask every time, நீங்கள் diabetes practice பண்ணக்குள்ள every patient ask about diet. நீங்கள் நல்ல SGLT blockers, DPP inhibitors, லாங் ஆக்டிங் அனலாக்ஸ்னு எழுதுக்குள்ள சார் ஆரஞ்சு பழம் சாப்பிட்லாமாம்மா. ஸோ நம்ம ஃப்ளோவே கெட்டு போயிடும். ஸோ அதனால தான் டயட்டை ரீஎன்ஃபோர்ஸ் பண்ணி எல்லாம் தலையாட்டிட்டு மெடிசன் எழுதிட்டு அகெயின் வி கோ பேக் டு த இது. ஸோ இன் தட் ஹவு த செரியல்ஸ், whole weight greens, so all these things we again repeatedly சொல்கிறதுனால if you start looking at it every time, patients கேட்குற கேள்விக்கு நம்ம இரிட்டேட் ஆக மாட்டோம். So we constantly endeavor and make ourselves tolerant to all the questions our patients are asking, because it is their habit. They keep on asking. நம்மளை பிரேக் பண்ண ட்ரை பண்ணுவாங்க, நம்ம பிரேக் ஆகாமல் பொறுமையாக இருக்கணும். That is what it happens every day in our practice. So glycemic index, glycemic load, we constantly look at it and then decide. So these are all just as a routine. ஸோ இப்போ நிறையா ஜங்க் ஃபுட்டு தான் நிறைய எல்லோரும் சாப்பிட ஆரம்பிச்சிட்டாங்க. ஸோ should we eat அப்படிங்கிறது, now we look at the childhood obesity, children who are all more obese. ஸோ எஸ்பெஷலி இந்த கொரோனா டைமில் ப்ராக்டிஸ் கம்மியாக இருக்கிறப்ப தான் ஆன்லைன் கன்சல்டேஷன்லாம் ஆரம்பிக்கிறப்ப தான் we looked at more at the child obesity, and as a group screening, family screening, we aim to identify potential diabetics and undetected diabetes and IGT persons, and then make them to come forward to screen it and then do a workable plan to replace all these junk foods often. ஏன்னா எல்லாம் ஸ்விக்கி, ஜொமேட்டோ டெய்லி அவங்க ஆர்டர் பண்ணி they started eating more. ஸோ 2 வருஷத்தில் ஸ்கூலுக்கு போகிறப்ப 30-40% வெயிட் கெயின் வாஸ் தேர் இன் ஆல் த ஸ்கூல்ஸ். ஏன்னா எல்லாம் ஐடியலாக வீட்டில் இருந்து they started eating more and did less exercise, less calorie restriction and calorie spending. So serving size is very important. Portion size is different. So if you look at both the diagram with the marker here, 80 grams, 20 grams and 160 grams, 40 grams looks almost simple. So patient guy, சார் நான் இவ்வளோ தான் சார் சாப்பிட்டா 300 ஆயிடுச்சுமா. ஸோ அந்த இவ்வளவுங்கிறது நம்மளால் ஓபியில் உட்காந்து கண்டுபிடிக்கவே முடியாது. ஸோ சம்டைம்ஸ் we keep on increasing the insulin and tablets. Instead, whenever this control is not there, when you do a proper exercise and you write a good drug prescription containing SGLT blockers, DPP inhibitors, metformin and basal insulin, again go back to the diet calorie intake. So we always focus on the drugs we write and we modify the drugs often. Instead, if you are convinced of the drugs you take properly, go back to the diet. Upon in the diet portion control, size control, you again review. For the diet they take, the work they execute is very less. எல்லாமே மெக்கனைஸ் ஆயிடுச்சு. ஸோ வென் தே டூ லெஸ் ஒர்க் அண்ட் ஈட் மோர், naturally calorie spent is less, glycemic level increases in the blood. So again you look at the portion size and size. சார் இத்திரியூண்டு ஆப்பிள் தான் சாப்பிட்டோம்பாங்க, எவ்வளோன்னு கையை காட்ட சொல்லுவாங்க. ரெண்டுக்கு டிஃப்ரென்ஸ் இஸ் குவைட் லார்ஜ். இட் இஸ் 25 grams, it is half that 30 gram. So size does matter. You always ask for the portion size, whatever they take, whether it's parotta or roti or naan or even homemade chapati, the size is definitely more. சார் ரெண்டு தான் சாப்பிட்டோம்னா நீ ப்ரிசியூம் பண்ணிக்கூடாது, அவன் ரெண்டு தோசை அளவுக்கு சப்பாத்தி சாப்பிட்ருப்பான். ஸோ இட் இஸ் நாட் தி ஹேண்ட்ஃபுல் ஆஃப் சப்பாத்தி, இட் இஸ் அ பிக் சப்பாத்தி. ஏன்னா மை சிஸ்டர் டிட் ஃபார் மை பிரதர் இன் லா. அவர் ஒன்றுமே சாப்பிட மாட்டேங்கிறான்னு ஒரு ஃபுல் தோசைக்கல் அளவுக்கு ரெண்டே ரெண்டு சப்பாத்தி போச்சு, அது 6 சப்பாத்தி அளவு. So we have to review the portion size often to implement the diet we would like to implement. ஸோ அதே மாதிரி தான் ஹேண்ட்ஃபுல்லில் பாருங்கள் எத்தனை வகையான ஹேண்ட்ஃபுல். எஸ்பெஷலி ஆயில் எடுத்திங்கன்னா தம் சைஸ் தான். ஸோ இதெல்லாம் உட்காந்து திருப்பி திருப்பி சொல்லி ஃபோட்டோவே போட்டு வச்சுருவோம் நாங்கள். இதை பாருங்கள், இது பண்ணுங்கள், பிபிடி ப்ரெசன்டேஷன், டயபெட்டிக் எஜுகேஷன். ஸோ ஆயில் ஸ்மால் குவான்டிட்டி ஆஃப் தம் சைஸ் எவ்ரிடே விச் கண்டெயின் 10 ml and other broccoli or other item you accordingly you define. ஸோ சேம் பிரெட் எவ்வளோ டிஃப்ரென்ஸ் பாருங்கள், பாவ் பன்னு, சாண்ட்விச் பிரெட், ரெகுலர் பிரெட், ஓட் மீல். ஸோ ஆல் தீஸ் சாய்ஸஸ், more than we talk more, you put pictures, everybody will like. So all media makes us to look at more than listen more. So you always show pictures. That's what we do with our diabetic educator and the nutritional counselors. Before you meet your patient, we spend a lot of time with our diet counselors. So they talk about the pictures and the diet to our patients. So household measures also equally you pay attention. ஒன்று 200 ml இருக்கும், இன்னொன்று ஸ்மால் சைஸ். ஸோ எந்த சைஸுங்கிறது சொல்லிக்கிட்டே இருக்கணும். ஒரே வீட்டில் பையனுக்கு ஒரு சைஸு, அப்பாவுக்கு ஒரு சைஸு, தாத்தாவுக்கு ஒரு சைஸ் இருக்கும். அதில் எந்த சைஸுன்னு ரிவர்ஸ் பண்ணி விட்ருங்க. ஸோ வி ஆஸ்க் ரேண்டம் கொஸ்டின்ஸ். தாத்தாவுக்கு எது கொடுப்பீங்க சார்? சின்னதாக கொடுப்போம் சார்னு சொல்லுவாங்க. சொல்லுவாங்க அப்பாவுக்கு வந்து 200 ml கொடுப்பாங்க, பையனுக்கு 100 ml. ஸோ ரிவர்ஸ் பண்ணிடணும். ஸோ குவான்டிட்டி டஸ் மேட்டர், வித் கலோரி, வித்தவுட் கலோரி, ஆல் தீஸ் திங்ஸ் we take consideration. So I train my dietitian to look at all these things rather than talk about the calorie value, other things. So this will help. So same thing in the portion size. If you see all the 3 containers, it's the same measure, but size of the plate that makes us an illusion. So always tell them proper size, proper plate. Filling the plate is not important. Quantifying the food in the plate is very important. So all these helps to look at it, and the healthy plate feed model will help to reduce diabetes. So prevention of diabetes is very simple. Exercise very important. Look at the diet they take. Low carbohydrate diet, what we measure is around 130 gram per day. So normally 250, reduce it to 50% to 130. Keto diet is less than 50 grams. Low calorie diet is 800 and 850, which is very difficult. So sometimes it is possible, sometimes it's not possible. So we choose a healthy diet along with carbohydrate restriction, more PUFA, more polyunsaturated and monounsaturated fat, and less polyunsaturated fat you add, and saturated fat you reduce to the lowest. Fat, you decide what fat is important, 30% less you add. Same thing with the salt. Excess salt should be discouraged. And micronutrients, look at it, how they incorporate the high fiber, high vitamin diet, especially minerals. So this Indian food, we always focus more on the Mediterranean diet by increasing more nuts, more fiber, eat a lot of veggies and change it. So with all these oil, cooking oil is again very important. Sometimes people more ask about the olive oil. So it is good provided the cost they have to afford. So extra virgin olive oil, you can use it for boiling, and some oil you can use it as a salad. So it is a pomace oil, you can use it for boiling. Extra virgin only for salad dressing. You need not cook. It will not be used for Indian cooking. So whole grain food is very important. Fresh fruits you eat. So Mediterranean diet here more with fruits, nuts than the other agents. So with this foods, what we try to add is again the food choices, food exchanges. Occasionally we allow even controlled diabetes to take a better food, dinner or marriages when they go. But you should collect, if you eat a paneer butter masala and not restrict to half portion, eat a lot of salads and vegetables. So like that, we also give some leniency at times so that they will not be get bored. So this is the diet recommendation by RSSDA, and nutrition in your life is very important. So dietary management is not just a diet prescription. We make an individual diet plan and make a lifestyle which suits to compare, and we not to produce undue hypoglycemia to the patients. So diabetes as well as prevention of diabetes is equally important, so that when we look at the exercise also, it's equally good. Promote exercise, and otherwise this will be the slide in the future generation, the social and evolution book. Apart from Homo sapiens, there will be Homo obesiticus, where with high obesity and lot of junk foods they take. So the problem is, even for the gym, you have an escalator. So this is the situation now. They do less exercise, more indoor play, especially during the last 2.5 years of COVID. Just job is more, field activities has gone very, very few. So benefit of exercise, we all know, and how to do exercise is very important. It makes exercise a good exercise program for individuals with prevention of diabetes aspect. You can prevent and postpone diabetes for longer time. So this is the DPP4, where prevention was possible even with exercise by 58%. And then risk reduction by 31% is only with metformin. So diet and exercise is very useful. You can promote to a greater extent. So exercise is very important type of exercise. You can decide according to the age, young individuals, obese, prevention, all these things you can make it. So at the end, what is important is fit program. You have to decide frequency, intensity, and the time and type of the exercise. What is suitable for which type of patients. So endurance is equally important, breathing exercise, and all these, for some who is not possible, you can do all these other exercises. So snacking also is very useful, delayed onset of hypoglycemia. These are all other slides we incorporated. So yogas are still possible. Along with exercise, you can incorporate yoga for endurance and the stretching and elasticity. So we can incorporate all for those who can't exercise. So this is diabetes, very important. That's misconceptions we take away, and then what you can do, what you cannot do, we identify. Thank you very much.
Thank you so much, sir. Really an excellent talk. Okay, the time constraint. Any questions from the floor? Being a primary care patient, Dr. Pranil Raj, one question. We already labeled him as an hypertensive patient, stage 2. He's on regular drugs. After 2 to 3 months, he is coming regularly. After 2 to 3 months, patient was absconded. At one point in time, he came. ஏன்டா மாத்திரை சாப்பிடல எவ்வளோ கழிச்சு ஒரு எக்கிட்டு மறுபடியும் பிபி பார்த்தா நார்மலாக இருக்குது. How is it possible? மாத்திரையும் போடல. He stopped all the medications. Again and again.
First of all, check the blood BP apparatus, sir. Probably the patient might have. See, that's actually point with every year you have to grade your BP apparatus machine in such a way that you are seeing the blood pressures correctly.
Very common scenarios that we are facing.
Sir, probably the multifactorial risk, other factors should be considered. Probably the patient with another option is a cardiac hypertension made organ damage. Patient I went in for probably a chance of cardiomyopathy is also option is there. So you have to look into screen the patients, and always extensive evaluation only we can find out what went wrong. So yeah, that is the point. If something goes wrong, like a diabetic patient suddenly come with a low sugar, always have to check a renal function. The same way, complete only evaluation we can find out. So that's the point. We have to insist the patient to evaluate and find out the search for the other causes.
Thank you.
Thank you.
Any questions?
Yes, it was pointed out by Palnivel Rajan. most of the time we talk a lot in the conferences, but what I have observed in my 40 years of practice, that we never பிபி எடுக்கிறது வந்து ஏதோ பிபி எடுத்து சொன்னால் ஏதோ டாக்டர் ஏதோ நம்பர் அவர் பிரச்சனையை பேசிகிட்டு இருக்கிறாருங்கிற மாதிரி தான் இன்றைக்கி வரைக்கும் மெஜாரிட்டி ஆஃப் த பேஷண்ட்ஸ் பிலீஃப் இஸ் லைக் தட். அண்ட் ஆல்சோ கட்டி பார்த்தாங்க சார், 100 இருந்தது, 90 இருந்தது, 80 இருந்தது. நோபடி டெல்ஸ் வாட் இஸ் த systolic and diastolic, the higher side of the BP and the lower side of the BP, and they never bother about the value when they are going to the doctor, whether we are normal or அந்த டாக்டர் கட்டி பார்த்தா நார்மல் தான் சொன்னார், நீங்கள் சொல்ல. These are all the common misconception and also miscommunication between the doctor and the patient that is universally prevailing. So we have to take a right step and as a patient education at the time of diagnosing the hypertension and also as well as diabetes. But that is unfortunate, but the situation is prevailing from urban, rural, uniformly in a lot of places. So that we have to take much more initiation on the doctor's side. That is one comment I want to make on that Palnivel Rajan's presentation. This is a universal thing and they are not bothered about it, and they say and they think that இங்கே வந்து தான் பிபி இருக்கு, டாக்டர் தான் பிபி சொல்லியிருக்காரு அப்படின்னு. ஸோ we should not raise the BP of the patient by the way of our counseling also.
Thank you.
Regarding the BP itself, we are not following the standard measurement. That is more important. Patients should for 5 minutes or something, then all the back rest, put apart. So many things are. We are not following it, and we are not forcing the staff or the trained people to do also. The best way to assess means, doctor should take the way.
Thank you, sir. Thank you, sir. With that, we'll come to the end of the session. I thank you once again, dear esteemed speakers, for delivering your talks. And thank you, chairpersons, for having chaired this session. I request Dr. M. Shivakumar, sir, to felicitate Dr. Palnivel Rajan, sir, for his talk. I request Dr. Gregory, sir, to felicitate Dr. A.P. Nandakumar, sir, for his talk. I request Dr. M. Shivakumar, sir, to felicitate Dr. M. Gunashekaran, sir, for his talk. I request Dr. Gregory, sir, to felicitate Dr. A. Sendilvelu, sir, for his talk. I request Dr. A. Sendilvelu, sir, to felicitate the chairpersons for having chaired this session. We'll move on to the next session, what the patient says, a rapid fire round on the symptomatology. So I call upon Dr. S. Surendra Babu, sir, and Dr. K.V. Murli, sir, to chair the session. For the first topic of the session, I call upon Dr. S. Gopalakrishnan, sir, from Tiruvallur, to go ahead with his talk. The topic is cough. "15 minutes, sir. Sorry, 10 minutes, sir. 10 minutes, sir.
all of you will agree with me that with increasing and probably a justifiable dependence on technology for both diagnosis and treatment, the old art of history taking and listening to the patient has receded into the background. The wise words of William Master, listen to the patient. He is telling you the diagnosis, still rings true. To analyze the common symptoms and enlighten us, We have a group of gifted speakers today. Let us listen to them.
In this session, there is no recommendations, no guidelines, no studies, whatever, nothing. No, it is what the patient says. It is because of patience we are able to sit here. Because of patience, the companies survive. Because of patience, all these things happen. But we have never given importance to the patients. This is the first conference, I think, in the history of Tamil Nadu API that patients are also given importance and their words are also given importance. I welcome Dr. Gopalakrishnan to talk on what the patient says about cough.
Good afternoon, our senior faculties and delegates of the Tapicon 2022. First of all, let us salute the organized team of the Tapicon 22 Trichy. We have to our great thanks to all the active members of this organizing team. Cough, the topic is cough. So matter of 10 minutes, it is a very difficult to give some points or a lecture about the cough. Cough is because cough is a that is the most common symptom in our outpatient practice. So most of the time it is troublesome not only to the patient and sometimes to the treating physicians. It's an important defense reflex. By definition, a clearance of the secretion and the particles from the airways and to protect the lungs. While evaluating the coughs as a symptom, the history is the key. That is very important. The history taking is very important. We are not giving proper time while evaluating a respiratory symptom of a cough while in an OPD because of our busy schedule. These are all the undergraduate teaching, the taking the history, onset and duration, character, timing, sputum with or without sputum, aggravating factor, and associated symptoms. Most of them we will miss this associated symptoms. These are the key points you have to keep in mind. The next, basically the classification of the cough, less than 3 weeks, it is an acute, and between 3 to 8, subacute cough, and more than 8, chronic cough. Acute cough is the etiological factors commonly being while evaluating the patient, upper respiratory tract infections, all viral symptoms, including the common cold, coryza, and even H1N1 infection, and the latest the COVID infection. These are all present as an acute cough coming under as a viral syndromes. The sinusitis is again a common symptom presenting as a acute cough. Pertussis, even though rare, sometimes associated with the family history and contracted from the children's in the family. Most of the time, the simple upper respiratory tract infections and bring out the chronic underlying disorders of this, especially the COPD and underlying asthma. Pneumonia, acute onset, as a present is a cough, left ventricular heart failure, foreign body aspiration history, and rarely pulmonary embolism. And most of the interventional, this is a forgotten area, that is a post-intubation during the surgical theaters and the surgical wards, and the extubation from the ventilators in IMCU and ICUs, and the post-hanging trauma. We have seen a lot of cases, cough not at all relieved in post-hanging patients. There is no treatment at all, it automatically subsides. Signs of an red flags in acute cough. Symptoms, the symptoms usually whenever patient presents with hemoptysis, breathlessness, fever and chest pain, weight loss, you have to consider acute management. The signs of tachypnea, cyanosis, especially dull chest with the bronchial breathing and the crackles, you have to refer the patient immediately to the emergency ward for further evaluation. Subacute cough, Post-infectious usually, even a simple coryza and a viral cough can extend up to a period of month, more than 3 weeks. That is naturally, it will subside. The thing is, we have to take a symptomatic care. Post-nasal drip, sinusitis, again a tracheobronchitis, again asthma, TB, these are all under subacute cough. Chronic cough, let us divide into a smoker. History-wise, is a smoker or a non-smoker. If an abnormal X-ray is there, think about the COPD. It present with a chronic bronchitis in one spectrum and emphysema as another in another spectrum. CA lung. Non-smoker usually the upper airway cough syndromes. All the viral syndromes, they extend over a period of weeks and present as a chronic cough. Pulmonary tuberculosis, especially the treated or partially treated, untreated and partially treated tuberculosis can present with the PT sequelae. That PT sequelae usually mimic like an asthma, COPD, and most of the time misdiagnosed and mistreated as an asthma or COPD. That point we have to keep in mind while evaluating the cough in a suspected PT. And the asthma, cough variant asthma, GERD, the prevalence. One more important, it constitutes about 15 to 20% in a patient present with a chronic cough. History is very important, especially present with a nocturnal cough, just like asthma. And after taking full meals, they can present with a cough. Chronic suppurative disorders, bronchitis, and non-asthmatic eosinophilic bronchitis. A separate entity, it needs further detailed investigations, and ILD and the occupational lung disorders. This is the triad of cough in a patient present with a chronic cough, asthma, and post-nasal drips in sinusitis, and GERD. GERD constitutes about 15 to 20% in the case of chronic cough. Chronic cough, chronic aspiration, especially with the patient with those who are suffering from chronic neurological illness, stroke, Parkinsonism, and demyelinating disorders. Those elderly patients with the chronic bedridden, they are present with the chronic aspirations. Psychogenic, fixitious cough, zoonotic diseases, still the hydatid disease is prevalent in underdeveloped countries, psittacosis from birth infections, and very rarely a giant thoracic aortic aneurysm, the symptom will be only the cough. Only the cough. By evaluation, we can find out. We reported 2 cases in our service in Rajiv Gandhi Hospital at Chennai. Only the present symptom was the cough. A simple X-ray revealed a giant aortic aneurysm. So one of the forgotten entity is the passive smoking. This is very common in history. We have to rule out whether the patient is having passive exposure to a passive smoking. That is an important. And while evaluating the cough, every physician or treating doctor, they have to keep in mind about the pathophysiology of the cough. Simply, these are all the hyperresponsiveness, bronchial hyperresponsiveness, not only present with asthma, a simple trigger of a viral or external stimuli can present with the hyperresponsiveness that can present with the cough. And in practice, we have to differentiate by history wave from cardiac asthma. It can present with the acute onset cough, especially in the early stages of bronchial pulmonary edema. Coming to the complications, a violent cough can produce substantial hemorrhage, arterial hypotensions, arrhythmias, coughs in the elderly, CS of rhinorrhea because of the increase in ICT, and inguinal hernias, urinary incontinence, pneumothorax, pneumoperitoneum, pneumomediastinum, and emphysema, especially suffering from patient COPD. A violent cough can produce a rupture of bullae and leading on to the emphysema. So these are all the certain practical points. The coming emerging issues, the environmental pollution, global climatic variation, and industrial causes. These are in future days shifting the scenery of the respiratory disorders from infectious to non-infectious disease. So while evaluating the cough, these are all the things we have to keep in mind. The message here is, whenever evaluating the cough, reasonably subjecting the patient to investigation, you come to your diagnosis. If you are not able to come to the diagnosis, put the patient into a detailed investigations. And another thing is, if you are not able to still, after detailed investigation, after extensive investigation to a pulmonologist or a immunologist or to a gastroenterologist, come to a reasonable professional diagnosis, and we can advise a therapeutic trial based on your professional diagnosis. That is the message. Thank you for your attention. Thank you.
Thank you, sir. You have completed your talk within the prescribed time. Next, I invite Dr. Ram Kumar from Vellore. From Chennai. From Coimbatore. Coimbatore. Ram Kumar from Coimbatore to talk on dyspnea.
Good afternoon, all the delegates. Thank you very much for the organizing committee for giving the opportunity me. And the given topic is dyspnea. 1.5 month back or 1 month back, the organizing chairman called me, sir, you got to speak on dyspnea. Then I said, sir, any delegates will be willing to know something new, something they wanted to update, a new update in the medicine. What is new in dyspnea, sir? No, sir, symptomatology we should give. But because a lot of postgraduates are coming, they should know what is dyspnea. The day before yesterday, I came for the gold medal examination in KAP. I have examined 9 students. All of them are very clear. They know what is dyspnea, what is the grading, what are causes, everything. Then why I have taken up this topic means, the next thing chairman told me, so this time we are giving accommodation only for the speakers. Just now I have signed the checkout bill, it is 23,000. So this dyspnea cost 23,000 rupees I have said. Okay. Thank you. Once again, thank you the organizing committee for giving me topic as well as accommodation. See, the definition, if in my death, I will not aware that I am not breathing. Only my friend Muttumani, he may say that this fellow is not breathing. Just like that, while I alive, in my alive, I am not aware that I am breathing. If I am aware that I am breathing, I am listening. So the definition says undue awareness of uncomfortable, abnormal, or unpleasant breathing is dyspnea. So dyspnea is a term used to characterize a subjective experience of breathing. This is the regular definition that is comprised of qualitatively distinct senses that will vary in intensity. And dyspnea affects quality of life, it affects exercise tolerance and mortality. And dyspnea is also associated with a decreased functional status. It will affect the function of the persons. This is pathophysiology. There are so many triggering factors as well as mediators. In simple, I wanted to put these slides. So hypoxemia, that is an peripheral, that simulates peripheral chemoreceptors. The acidosis, hypercarbia, that stimulates the medullary chemoreceptors with central chemoreceptors. And decreased compliance, that stimulates lung or muscle by mechanoreceptors. And obstruction, airway resistance, airway causes dyspnea. So these are some of the possible mechanisms. But almost all the textbook says the pathophysiology of dyspnea is not clear. So we not worry, we don't want to waste much time on the pathophysiology of dyspnea. In general, acute hypercapnia, it's a stronger stimulus for dyspnea than in acute hypoxia. See, every one of us think hypoxia is the main cause for acute dyspnea. That's not. And chemoreceptors in the medulla respond to changes in pH, acidosis, pH and PaCO2, and peripheral receptors in the aortic arch and carotid body also respond to alteration in PaO2. So acute hypoxia, hypercapnia, and acidosis are the traditional stimuli for ventilation. And this is the spectrum. See, more than 75% of causes for dyspnea is from the respiratory. The lower respiratory tract is 67, upper respiratory 8%, and cardiac 10%. GERD, just now they mentioned about GERD. And deconditioning means obese adolescents. They are not maintaining the body in a correct shape. And psychogenic is 5%. So overall, in a nutshell, asthma, COPD, industrial lung disease, and cardiomyopathy accounted for approximately 2/3 of the cases. And broadly classified into three: acute, subacute, and chronic. So less than 72 hours is acute, 72 hours to 12 weeks is subacute, more than 12 weeks is chronic. This you must know. This must know. At least two grading I have put in my slides. If you are given, for postgraduates, if you are given a respiratory case, you go by this MRC grading. This is a modified MRC. And if you are given cardiovascular system, go by NIHA or New York Heart Association. So in MRC, there are 5 grades. The modification is just they put the numbers. The numbers only modified. The grading is still there. Grade 0, I only get breathless with strenuous exercise. Means I am all right. I am comfortable. Without any exercise, I am comfortable. That's grade 0. Only on strenuous exercise, I feel breathless. Grade 1, I get short of breath when hurrying on the level ground or walking up a small hill. Grade 2, I walk slower than people of the same age at ground level. Because of breathlessness, I have to lag behind, or I have to stop for breathe when walking on my own pace on the level. That is, after half an hour or 30 minutes or after 1 kilometer, if the patient feel breathless or walking at his own pace, that is coming under grade 2. And grade 3 is I stop for walking at my own pace after walking about 100 yards or after a few minutes. Within few minutes, he will start become breathless. That's grade 3. And grade 4, I'm too breathless. This means even breathless at rest. When too breathless to leave the house, or I am breathless when dressing or undressing. Day-to-day activities, it is difficult. That's all. And come to the NIHA, no symptoms. Symptoms only 4: palpitation, fatigue, and dyspnea, chest pain. These are 4 symptoms. So the class 1, class 2, class 3, comfortable rest. Only in class 4, they are breathless at rest. So no symptoms. So normal, ordinary activities will not disturb the symptoms will not occur. But NIHA class 2, mild, less than ordinary activity. See, grade 1, ordinary activity will not produce symptom. Here, less than ordinary activity will produce symptoms. The mild symptoms with a normal physical activity, comfortable at rest, slight limitation of the functional status. And class 3, moderate symptoms with less than normal activity, comfortable at rest again, marked limitation of functional status. And class 4, dyspnea at rest. Severe symptoms with features of heart failure and minimal physical activity even at rest. Types. This you must know, because in any clinical exam they will ask about what is orthopnea. Everyone know. It's the sensation of breathlessness, recommend position relieved by sitting or standing. And the PND is a sensation of shortness of breath that awakens the patient often after 1 to 2 hours of going to sleep. That is during the REM sleep because of the catecholamine surge or decreased response of the respiratory center, and it's usually relieved in the upright position. Platypnea is just opposite to orthopnea. In orthopnea, when you go to recommended position, you will feel breathless. In platypnea, in sitting posture, patient will be breathless. In lying posture, it will be relieved. That's the only difference between platypnea and orthopnea. Tripopnea, when the patient lies on one lateral decubitus, patient will breathless. And the conditions, I will tell you if any question session is there. The another one is I will not included in my slides. This is bentopnea. Bentopnea is when the patient sits over a chair, ask the patient to bend for about 30 minutes. If the patient develops breathlessness within 30 seconds of bending, that is in increased left ventricular pressure, will further increase, will produce dyspnea. That is bentopnea. The causes is depending upon the durations. Sometimes minutes to hours. The sudden onset dyspnea. The investigation is only two. The basic investigation, any patient comes to you, two investigation do. One is ECG, another one is X-ray chest. Only two organs are inside the thoracic cavity which produces dyspnea. If ECG will reveal what is the problem with the heart. X-ray chest will reveal what is the problem with the lungs. So minutes, acute MI with pulmonary edema, minutes. Sudden onset of pneumothorax, already a known case of COPD. Sudden. Any inhalation of the foreign body which goes and obstructs the upper respiratory, sudden. So like that, pulmonary edema, acute exacerbation of asthma, any injury to the chest wall or intrathoracic structure, and sudden onset of hemothorax. That's why I will meet pleural effusion, spontaneous pneumothorax, pulmonary embolism, very, very important for sudden onset of dyspnea, will be revealed in ECG and other investigations. Pneumonia and pulmonary hemorrhage, foreign body aspiration, very, very important, and vocal cord dysfunction, any anaphylaxis which may cause laryngeal edema, there may be obstruction in the vocal cord, and chronic causes, COPD, LV failure, diffuse interstitial fibrosis, pleural effusions, pulmonary thromboembolic disease, and psychogenic, very important. There's another entity. Test, only two tests I said, but in addition, see, chest X-ray, pulmonary function test, spirometry, and blood for arterial blood gas analysis whether the patient is in acidosis or not. I cannot explain this in detail. So each test will reveal what else a basic problem which causes dyspnea. Considering the condition and the timing, thank you very much. Any questions?
Thank you, sir, for your excellent talk on dyspnea.
Next, I invite Dr. Shanmugam from Chennai to talk about leg swelling. Dr. Shanmugam is a senior consult physician in Sir Ivan Stateford Hospital, Chennai. He's chairman Association of Physicians of India, Chennai chapter, past chairman API Tamil Nadu chapter, retired professor of medicine, Meenakshi Ammal Dental College and Hospital, Chennai, speaker and chairperson in various state and national conferences, contributed number of articles in Medicine Update, member of All India Intensive Postgraduate Training Program, Chennai. Dr. Shanmugam, sir, please.
I think we have to thank the organizers first for arranging a beautiful and scientific program for the physicians as well as the postgraduates. Why he has chosen this topic means, still symptomatology, clinical medicine plays an important role in management of the patient, not only for diagnosis and also for the treatment. And also, you feel, the important pretest value or assessment, you do only the necessary tests required further. That is most important. That's why he has put it all the symptomatology. Though you would have read everything in undergraduate, I think this topic is mainly for an undergraduate oriented topic. But fundamentals will never change. For the we were or if you see that leg swelling, it comes in every aspect of medicine. Whether the central nervous system, or you get the thyroid, or the lung, the heart, or the abdomen, or venous system or arterial system. Therefore, is it arterial or venous or lymphatic or in between, or it plays an important role in other system also. It is a common clinical practice in various etiology. It may be acute, chronic, bilateral, unilateral, contributing factors. Increased permeability, protein status, infections, injuries, inflammation, vein, acute, chronic thrombosis, infection, obstruction, compression, lymphatic system, infection, obstruction, congenital mixer, underlying systemic disease. I told you, the cardiovascular, pulmonary, hepatic, renal, and metabolic or endocrine. The local causes also we should be able to assess whether it is infection, obstruction, trauma, or allergy. Maybe with pain, without pain, with pitting or without pitting, sometimes with skin changes and sometimes with hypotension also. So this is, one should not forget, the interstitial fluid increase means, at least 2 to 3 liters of fluid should be there and it should be palpable. And you require this basic anatomy. Therefore, an arterial system and a venous system and communicating one. And in between the interstitial space, you got the cells also and the lymphatic system. All are important. Then the edema is a palpable swelling due to expansion of the interstitial fluid volume, does not occur in normal subject. That is most important. Fluid components, I don't not go into the detail. The fluid balance between the compartment is only mostly hydrostatic pressure and oncotic pressure, which is protein rich. Other factors of vessel permeability, lymphatic system also play an important. Lymphatic system collect the fluid and filtered protein from the interstitial space and returns back into the vasculature. Any disturbance in the vascular space or impaired return of the fluid by the lymphatics leads to accumulation of the fluid in the interstitial space, results in edema. Apparently, 2 to 3 liters. This is very important. So you want to have a volume, which one, whether to reduce or increase, you should know that already the patient is at a volume overload. And history is very, very important. Physical examination, very, very important. Appropriate lab test and imaging when needed. Systemic venous hypertension, often it is bilateral. It may be cardiac failure, pericarditis, pulmonary hypertension, liver failure, cirrhosis. Increased plasma volume. You get it in renal failure, cardiac failure, pregnancy, premenstrual edema, and may also due to drugs also. Many times what I see, number of drugs we use without following it up, and the patient also sometimes never returns, and we find that it is due to the drug causing the edema, especially the pioglitazone, the NSAID, antihypertensive, all antihypertensives, vasodilators, calcium channel blocker, and other things what I have listed here. And these are all some of the pictures. No, you will not forget it. That's why I have put it. Where you can see that dengue rash with hypotension causes edema. Maybe in shock or without shock also. Cirrhosis liver, ascites pedal edema. You got the post-infarction cardiac failure. Then you got the diabetes mellitus, chronic kidney disease, pleural effusion, anemia. All these people are my own patients. And diabetes with Charcot joint also. You got acute kidney injury. Morning, one of the PG presented a paper on acute kidney injury. Very important due to the sepsis. And more than 70% goes into acute kidney injury after the sepsis. So you have to, we think that it is infection, therefore the pedal edema, we have to correct it by giving diuretic. That is not the case. You have to give the hydrate properly, the volume should be assessed. Then you got the drug. Commonly we come across amlodipine. I say repeatedly, most of the calcium channel blocker maybe slightly more in amlodipine and NSAID plus your pioglitazone. I see 10 kgs, 8 kgs with increased weight and pedal edema and causing pulmonary edema also. The fever, painful swelling upper and lower limbs. This patient had CPK of nearly 5,000 and odd, and it turned to be an inflammatory myopathy, which is not common. Therefore, when you don't know the answer, please try to investigate further. Then you got the other patient with hemoglobin 6, creatinine 8.4, CKD. Unfortunately, many people ask for only hemoglobin. Please ask for complete blood count. If you find anemia, ask immediately peripheral smear study. You ask for blood grouping or H type and also ask for the creatinine level. Very number of cases we come across. And decreased plasma oncotic pressure, plasma albumin less than 2. Therefore, is the edema due to hypoalbuminemic condition? If you remember, that is more than enough. For protein loss, nephrotic syndrome, preeclampsia, eclampsia, reduced protein synthesis, liver failure, cirrhosis, vitamin deficiency, kwashiorkor, protein loss, enteropathy, inflammatory bowel disease, ulcerative colitis, Crohn's disease, GI, malignancy. Malignancy, you should not forget it. Non-ulcerative, non-erosive conditions like tropical sprue, celiac disease, amyloidosis, cutaneous burns, connective tissue, Whipple disease, pancreatic insufficiency. It may not be common, but you should remember that. Then the capillary leak syndrome. I think after the dengue, this come in. Everyone wants to know. No platelet. We never bothered about platelet before dengue, but every patient now know what is the platelet today. For this capillary, now COVID also has increased the awareness. Therefore, you should know the basic. Now, all these are all due to the hypercytokines. Therefore, that causes vasodilation. In addition to that, no, the loss of protein in the capillary leak, ultimately causing edema. Sometimes it may cause pulmonary edema also. That is different. A number of conditions will cause capillary leak syndrome due to increased permeability and hypercytokinemia. Loss of protein-rich fluid from the intravascular to the interstitial space. That means, sepsis very common, viral hemorrhagic fever like dengue, etc., snake bite, acute kidney injury, anaphylaxis. So don't think that anaphylaxis will not cause edema, it will also cause edema. Then idiopathic systemic capillary leak syndrome, not very common, Clark's disease. But the problem is, some of the rare disease, they do not respond to your routine method of management. Autoimmune diseases, SLE, rheumatoid arthritis, hemophagocytic lymphohistiocytosis, then ovarian hyperstimulation syndrome. This is very, very rarely reported. My friend Dr. Lakshmanan reported a case of like this. For in an obstetric where you give a hormones and the patient becomes suddenly breathless, ascites, pedal edema, think of these conditions. And invariably, I think the last one, gemcitabine under other chemotherapeutic drug also will cause the capillary leak syndrome. In the recent JP also it has come. Pre-case report also. For most of the rare cases respond to steroid. That we have to keep in mind. Therefore, no improvement, try to introduce a corticosteroid and work it up. Then acute unilateral or symmetrical leg edema, acute deep venous thrombosis. I will not go into the detail because you are aware of the deep venous thrombosis, the risk factor you have to assess clinically, and also you should do a Doppler and the D-dimer, etc., and see the ECG and the echo also, and see the pulmonary CT angio if you want to have and correct the conditions. The very rare condition, May-Turner syndrome. This is also my friend Dr. Lakshman presented. When you got a unilateral leg swelling, the whole leg, especially in the left side, and especially a woman, think of this condition. Where here, the edema of the entire limb, iliofemoral DVT, that is the right common iliac artery, you can see that in the picture also, overlies and compresses the left iliac vein against the lumbar spine. The treatment is not very easy. Then we have to give a thrombolysis, anticoagulant, angioplasty, stent, etc. For very rarely we come across arterial thrombosis with the edema also. This is also one of my patients who had cardiac failure, left atrial clot, plus chronic alcoholic. Then he presented with the swelling and the whole limb was very cold. I did the venous Doppler normal, then we did the arterial Doppler. And with thrombosis, we have anticoagulant and refer the patient to the vascular surgeon. For the compartment syndrome also, any injury, you have to think of the edema. For some time, the injury may not be external, it may be internal also. Therefore, history is very important, and the swollen leg means you should contact the surgeon also, so that any debridement you can do it immediately. The cellulitis, I will not go into the detail. Therefore, infective etiology you should have that. Then chronic venous disease also, abnormal venous dilatation, varicose vein, telangiectasia, reticular pigmentation, etc. Then this thing also will come as a chronic as a post-thrombotic syndrome. But simply we can say that no, you elevate the limb and follow it whether the patient again goes for a deep venous thrombosis or not. If there is an infection, you correct it. Then the lymphedema. The lymphedema is the last one now. Everyone is aware of lymphedema due to filariasis. But we have to look into the malignancy, underlying malignancy, whether it is present or not. For primary, secondary, underlying disease, infection, malignancy, etc., swelling, which is usually non-pitting, and you may have skin changes also. Risk factor, I have already told you, lymphadenopathy, radiation therapy, obesity itself can cause lymphedema. Then stomach sign, they cannot lift the skin. Then persistent accumulation of the lymphatic fluid promotes the proliferation of the adipocytes and deposition of the collagen fibers in the extracellular matrix around the capillary collecting the lymphatics. Very rarely we do all these tests because most of the things will be clinical, but when needed, we have to do lymphangio, ultrasonography, lymphangiography, and lymphoscintigraphy, and CT or MRI. The miscellaneous one, no, the last, I think, made 2 slides. Mixed edema, everyone is aware, non-pitting edema. But you should know the history, how to elicit mixed edema, and do a simple test of thyroid function. You will get the diagnosis. Obesity, hypertrophy of the calf muscles in the hypothyroid also. Limb hypertrophy, hypertrophy of the soft tissue and bone also. Very rarely, edema due to the lipid deposition, the lipedema. For we may not be able to do much about this one, but you should have in the mind. For conclusion, one of my patient's version, thank you for looking at my leg swelling, examining me thoroughly, doing all the needed lab tests, modifying the imaging, modifying the medication. Now I am symptom free. I will follow the medication, instruction, lifestyle modification as suggested. This patient had a lot of problems. You can see that diabetes, CKD, severe pulmonary hypertension, and the patient was a diabetic also, and he was taking pioglitazone. Really, the patient thanked me to correct some amount of edema and his the disease. Thank you.
Thank you for such an informative.
Next, I welcome Dr. Vignesh from Vellore. He is the son of my classmate, Dr. Sukumar, who is practicing at Gudiyatham. Welcome, Vignesh. He is going to talk on the symptom palpitation.
Good afternoon. Yes. So at the outset, I would like to thank Tapicon 2022 committee and Dr. Said Raman sir for giving me this wonderful opportunity to present in front of this audience. So the topic allotted to me was palpitations. So my previous speaker has made my job easy. They said normal times you don't feel your breath. At the same time, normal times you don't feel your own heartbeat. So any increased and unusual awareness of one's own heartbeat is called palpitations. So what the patient says, the patients describe palpitations as flutters, skips, pounding sensation, and sometimes as a pulsations in precordium. Palpitations could be intermittent, sustained, and regular or irregular. So we all know that the most common cause of palpitation is going to be a cardiac cause, and most of the time the degree of palpitation does not indicate the severity of the disease. So the threshold at which the symptom develops varies between individuals. So I would just quote a real life experience. So one fine day, my medical officer called me from the emergency and said, "Sir, we have two young females. Both have the same symptoms. That's just palpitations." So one of the patient was just crying and creating a ruckus in the in the casualty, and the other patient was just lying down calmly with cold extremities. So this is the first patient. Probably she was in the middle of a probable panic attack. So all the staff nurse was just surrounding this patient and trying to pacify her. The second patient had a ventricular tachycardia. So this patient actually had a viral myocarditis with severe LV dysfunction. So we had a great difficult time with this patient. So even though her LV function improved in the later, ultimately she succumbed to the illness because of multi-organ dysfunction. So the reason why I'm saying is that the degree of palpitation never matters because it does not correlate with the severity of the disease. So, pathophysiology, we know that arrhythmia causes palpitations, and any augmentation of cardiac contractility, be it physiological or pathological, is going to cause palpitations. And cardiac neurosis is another condition. We'll discuss it shortly. So, augmentation of cardiac contractility may be because of ventricular hypertension or any change in the preload or afterload, and amplified metabolic states like thyrotoxicosis and fever. Hypoxemia and catecholamine excess is also going to cause symptoms of palpitation. Now, cardiac neurosis. So, Da Costa was the first person to describe the cardiac neurosis. So, he found that it's also called as soldier's heart. The syndrome is also called soldier's heart. So, the Da Costa identified symptoms of palpitations, tiredness, headache, dizziness, and insomnia in the soldiers who were in the American Civil War. So, once you take out the soldiers from the Civil War, all the symptoms got resolved. So, he found that these individuals, the symptoms were induced by stress and anxiety because of excess activation of the sympathetic nervous system, and he labeled it as cardiac neurosis. Coming to the etiological classification, we all know that palpitations may be caused because of extracardiac causes and cardiac causes, psychiatric causes, and drugs. So the extracardiac causes may be because of anemia, fever, hypothyroidism, hypoglycemia, hypovolemia, pheochromocytoma, and vasovagal syndrome. The cardiac arrhythmic causes could be a simple atrial and ventricular premature contractions can bring about palpitations because of the altered filling during the diastole, and tachyarrhythmias like sinus tachycardia and supraventricular tachyarrhythmias like atrial flutter, fibrillation, AV nodal reentrant tachycardia, AVRTs like WPW syndrome, multifocal atrial tachycardias, and ventricular tachycardias all cause palpitations. Bradyarrhythmias like sinus bradycardia, AV block, and sixth sinus syndrome also do cause palpitations. So, in a patient who's already went pacemaker implantation, if that patient develops a symptom of palpitation, we do need to consider pacemaker mediated tachycardia. So, the non arrhythmic cardiac causes. Whenever the left ventricle is overloaded, volume overloaded, patients tend to develop the symptom of palpitations. Typically, in a patient with valvular regurgitant lesions at the mitral and aortic level, and congenital heart disease like VSD and PDA may cause symptoms of palpitations in young. Cardiomyopathies, mitral valve prolapse, are other non arrhythmic causes which can cause palpitations. As we all know, psychiatric causes, anxiety disorders, and panic attacks can cause palpitations. Among diets and drugs, we know that beta agonists, theophylline, phenothiazines, digoxin can all cause palpitations. Narcotic agents, cocaine, amphetamine, alcohol, tobacco, caffeine, all these can cause palpitations. So whenever a patient presents with palpitations to us in our OPD, so what do? So we get the history. So the first question that we're going to ask is whether the palpitation is continuous or intermittent, whether it is going to be regular or irregular, whether the palpitation occurs at rest or specifically only at exertion, what are the precipitating factors, whether the onset was abrupt, how does the attack terminate, whether there was any associated symptoms of chest pain, dyspnea, pre-syncope and syncope. And also, we also need to look at whether the patient also had a past history of ischemic heart disease or a valvular heart disease. Associated symptoms. We all know that when a patient with the symptoms of palpitations, when they say it as a skipped beat sensation, so VPCs and APCs are the most common cause. And also, when the palpitation is associated with chest pain, we need to consider ischemic etiology and pericarditis. Of all the associated symptoms, I think we should give more weightage to the symptom of pre-syncope and syncope, because when the palpitations are associated with these two symptoms, it means that the cerebral perfusion is slightly decreased, which means the cardiac output is decreased, which means there is a hemodynamically compromising arrhythmia, be it tachyarrhythmia or a bradyarrhythmia. So some hemodynamic disturbance is going to happen. So pre-syncope and syncope gets the maximum weightage among all these symptoms. So especially when a patient develops palpitations and the attack gets terminated by a vagal maneuvers, or when the patient has palpitations where there are symptoms of neck pulsation, so AVNRT is one possible cause we need to consider. So palpitations associated with exertion. So CPVT, catecholaminergic polymorphic VT, is one specific arrhythmia which comes only when the patient exerts. So when the palpitations are associated with exertions, you definitely need to consider CPVT as a possible etiology. Rapid irregular palpitations may be seen in patients with atrial fibrillation and any tachyarrhythmia with a variable atrioventricular block. So when the palpitations is also associated with heat intolerance and tremors, hyperthyroidism is a notable cause, and general anxiety, you always consider panic attack. So once the history is over, the clinical examination always finds its way and is very important in assessing a patient with palpitation. The pulse will tell you whether it is irregular and the patient has atrial fibrillation. The blood pressure is going to tell you whether there is a wide pulse pressure and there is a regurgitant lesion in the valve. The JVP is going to tell you whether there is a absent A wave because of AF or something like a Canon A wave because of a complete heart block. The murmur is going to tell you which valve is going to be involved, and the signs of heart failure, signs of hyperthyroidism, all these needs to be considered when examining a patient with palpitation. So once you get to some etiological assessment, next is the evaluation. So we have non-invasive evaluation and the invasive evaluation. So non-invasive evaluation, the ECG during the attack of palpitation gets the diagnosis of arrhythmia. So that is more important. Echocardiogram can be used to rule out the structural heart disease. External monitors like event recorders and Holters can identify the arrhythmias, paroxysmal arrhythmias. So mobile cardiac outpatient telemetry is the newer advance, where you stick a web cardio to the patient's chest and send him home, and we get the report in the email saying what the arrhythmia is and what is there. Everything gets reported and picked up easily. Now stress test. Now stress test is one test which brings out the arrhythmias, especially when the condition like CPVT. So you can see the diagnostic yield of a clinically significant arrhythmia. The maximum yield is with an implantable loop recorder. So this is, you use an implantable loop recorder only when your conventional workup fails. When you do all the other investigations with Holter and event recorders and you don't pick up an arrhythmia, but still you consider that arrhythmia as a possible cause for the patient's palpitations, you use an implantable loop recorder. So this is a typical example of how the stress test brings out the arrhythmia. So in the rest, it looks normal, and as the exercise progresses, patient develops a ventricular tachycardia. So this is an important condition, CPVT. I thought I would discuss this. So the patients will have no structural heart anomalies, a normal echo, a normal ECG, normal QT intervals, but stress is the only test which brings about the VT. So definitely patient is going to have a family history of sudden cardiac death in there. And exercise brings about the VT. Treatment of choice is beta blockers, ICD, and sympathectomy. So this is the typical bidirectional VT which develops with CPVT. You can see each QRS is in 180 degree out of proportion. One positive, one negative, one positive, and negative. So it's a bidirectional VT because of CPVT. So the other invasive modalities for evaluation of palpitation is going to be ILRs, and electrophysiological study. The management, most of the patients with palpitation, you reassure, evaluate and treat the cause, and rate controlling agents like beta blockers and calcium channel blockers are going to help you. So what the last example, so 65 years old male presents with palpitations and mild chest pain and pre-syncope. So we all can all see that there is elevation in the inferior leads, but most important is the patient had atrial fibrillation. So we might have all seen atrial fibrillation in ECG. I thought I'll show you in real time how it looks. So this is the coronary angiogram of the left coronary system. You can see this is the left anterior descending artery, and this is the left circumflex. The left circumflex artery exactly sits in the left atrioventricular groove. So the vibrations, what you see of the left circumflex artery is actually the atrial fibrillator, the fibrillating atria, the chamber above the vessel. So this is another view where you can see significant atrial fibrillation. And this is the left atrial location where it's actually fibrillating. So what is the etiology? The right coronary was completely occluded. Immediately after revascularization, patient came back to sinus rhythm. So you find out the cause, treat it, and patient gets better. Thank you.
Thank you, Dr. Vignesh, for your excellent talk.
Next, Dr. Muttumani, who needs no introduction, is going to talk about hiccups.
He is conducting the conference without hiccups. So he is the eligible person to talk on hiccups.
Good morning, one and all. Good afternoon, one and all. Respected chairpersons and delegates. I thank the scientific committee for giving me this opportunity. In spite of the resolution, the organizers should not talk. So why we have taken this symptomatology? Because sir previously told we have to get all the updates why we are going into the symptomatology. Because we are in a period where the postgraduates ask for a CT chest without auscultating the patient and going for echo without seeing the elevated JVP. So we should not forget the symptoms. So we have taken this symptomatology. And the topic given to me is hiccups. So though it is not a very common symptom, most often it becomes a nightmare. So when we get a patient with hiccups, it is very difficult. So it is very highly irritating to the patient and at the same time highly irritating to us also. And most of the time it is intractable. So what happens, the hiccups? So it is an involuntary, intermittent and spasmodic contraction of the diaphragm and the intercostal muscles. So there is a contraction of the diaphragm. So the sudden inspiration that ends with abrupt closure of the glottis generating the hic sound. So the forced inspiration after followed by closure of the glottis. That is the thing in hiccups. So the left hemidiaphragm is commonly involved. So if it is less than 48 hours, it is usually self-limiting. If it is more than 48 hours, it is called persistent. If it lasts more than 2 months, it is called intractable. So these are the causes for hiccups. So there are Humpty number of causes. So the most common causes are the vascular causes like the stroke, the encephalitis, and the structural causes. Another cause is the vagus and phrenic nerve irritation. So these are the causes like laryngitis and other things. The most common causes were the gastric distension, gastritis, peptic ulcer, pancreatitis, and all those things. And these are some uncommon causes like aneurysm, the mediastinal tumors, and other things. So this is myocardial infarction, pericarditis, the toxic and metabolic like alcohol, the electrolyte abnormalities is also some of the important causes. And after general anesthesia, like the stimulation of the glottis, this can also cause. And most often the drugs, there are few drugs, and the dexamethasone is one of the common drug in practice. After this COVID era, we have seen lot of patients using dexamethasone and they develop hiccups. Another one is the psychogenic, and another thing is the infections. Few infections are more commonly they can cause hiccups. So from our experience and our colleagues' experience, the common thing to focus when a patient comes with cough is,
So starting from the dangerous thing like lateral medullary syndrome. So hiccup is one of the presenting syndrome in many patients with Wallenberg syndrome or the lateral medullary syndrome. The next common cause will be a gastric distension or GRD. And the third thing is drugs most often is dexamethasone. And another things are uremia and hyponatremia. So whenever a patient comes to our clinic with hiccup, we have to focus on the 6 things. So starting from simple thing to the dangerous thing. And this hyponatremia, one of the common presenting symptom of hyponatremia is hiccup. So this is the reflex arc. The phrenic nerve and vagus nerve is both involved in the afferent and the efferent system. So this is the center. So the management should be focused on finding out the cause from the history, physical examination and further evaluation. So management, these are the common physical maneuvers like breath holding. Most of the time what happens, patient வந்தோடனே கொஞ்சம் breath hold பண்ண சொல்லுவோம், but already நிறைய தடவை breath hold பண்ணிட்டேன் அப்படின்னு patient சொல்லிடும். So we have to try other maneuvers like Valsalva, sipping on or gargling with very cold water, biting into a lemon, pulling on the tongue, swallowing a teaspoon of dry sugar, pressing gently but firmly on the eyeballs. These are vagal maneuvers. So because the both afferent and efferent involves vagal and the phrenic nerves. So while sitting, pulling the knees up to the chest, like compressing the chest, drinking water through a rigid tube with a valve that requires significant suction effort. That is the forceful sucking against a closed valve. So this stimulates both the phrenic and vagus nerve simultaneously. So this is one of the mechanism to stop hiccup. The pharmacotherapy, the common drug is because the commonest cause is gastric distension, the proton pump inhibitors will be useful and metoclopramide can also be used. It has two effects. One is the prokinetic effect and another one is the central effect of a dopamine antagonist. This both things can be useful to stop hiccups. Baclofen is the commonly used drug for hiccup. So any patient coming with hiccup, the first thing, even without finding the cause, we'll try to put the patient on baclofen. So this is mainly useful in case of central causes. We can go up to a maximum dose of 45 milligrams per day in a divided doses. And gabapentinoids. So these are useful in patients having hiccup in recovering from stroke. The chlorpromazine is one important drug which is used if the patient is refractory to baclofen and gabapentinoids. Most often the hiccup ends only with chlorpromazine. So starting from 25 milligram BD or twice, but it is a highly toxic drug. So a lot of extrapyramidal symptoms and other things, drowsiness, all those things can occur. So this is the only FDA approved drug for hiccup. So the maximum dose is 150 milligram per day. And few practitioners also use oral lidocaine viscous, just ask the patient to swallow the lignocaine jelly. So that is also useful in some patients. The other drugs which can be used are phenytoin, valproate and amitriptyline. And the one more drug is standosterone, this 5-HT agonist used for stroke-related hiccups. So the commonest drugs are proton pump inhibitors, metoclopramide, baclofen and finally chlorpromazine. The other things are Ryle's tube insertion. This is also one of the common practice of putting a Ryle's tube when a patient comes with hiccup. This helps by decreasing the gastric distension and avoiding the irritation on the diaphragm. So the other things are very rare thing, vagus nerve stimulator, electric stimulation of the phrenic nerve, positive pressure ventilation and USG guided phrenic nerve block. So the common thing is Ryle's tube insertion. So the hiccup, usually a self-limiting thing, identify the cause in persistent or intractable hiccups. Conventional remedies can be tried until the cause is identified. So the first thing is the physical maneuvers. The second thing is you can try a pharmacotherapy and third thing is you can use a Ryle's tube insertion. So the chlorpromazine is the only FDA approved drug for use to prevent hiccups. Thank you. Thank you for your patient listen.
Brief but excellent talk, Dr. Muthumani. Next, Dr. Kadar. Next to talk about chest pain is Dr. Kadar Sahab. He also needs no introduction. He's a popular fellow in Trichy. Kadar Sahib, please.
Six, 7 minutes. Muthumani, I was just telling the talk was only for 10 minutes. First person to finish in 5-6 minutes. So you know how busy he was. In spite of that, he accepted and he gave his talk. So this is like asking me to talk on diabetes for 10 minutes is very difficult. So what I can do in the next 10 odd minutes is I will tell you how to pick up the nature of chest pain and the etiology for chest pain. This was a small study done in Britain, found that 75% of the information to a correct diagnosis can be obtained from detailed history alone. We rarely listen to history in our OP, nor in our in emergency settings, we hardly look at history. Immediately we look for investigations. At least in OP, we have 1 or 2 minutes to ask for the history. So this study showed 75% of the history pertaining to chest pain can be leading to a good diagnosis, the right diagnosis. Only 10% from physical examination, 5% from simple routine tests, 5% from costly invasive tests, and 5% you will not have an answer for if you do all these tests as well. So this was done in Europe as well as US. It shows the etiology for chest pain. Someone coming to OP, what we do not want to miss in cardiovascular, in chest pain is you do not want to miss etiology due to a cardiovascular disease. So it is around 16 to 19%. But someone coming to emergency in the middle of the night, even if the chest pain is not convincing you that the patient needs admission, always advise admission. In the era of legal problems, you always advise admission because every second patient will have a serious cardiovascular disease. When I say cardiovascular disease, it's not only coronary disease, can be non-coronary as well. So let us see the causes of chest pain. What are the cardiac causes and the non-cardiac causes? So the cardiac cause which should not be missed is obviously angina first. So what are the description with the patient comes with pain? He'll say something is heavy sitting on my, like an elephant sitting on my chest, something which is stabbing me, something which is tightening me, irki pidikira mari irukkude, something they can radiate. They'll have a choking sensation in the throat. They can have jaw pains. So please remember, it is not pertaining only to the chest. You can have associated pain over the jaw or only in the jaw or only in the throat. Commonly, this is the area where the pain radiates, the chest and the inner part of the forearm. So the medial part of the forearm. But it can also be in the right side. Don't ignore. Someone comes with chest and right side pain. Do not think it is non-cardiac. Pain can also in the right part of the right upper limb, can radiate to the jaws, it can radiate to the back and in the epigastrium. Most of the times we miss when the patient says it is burning sensation. We presume it is gastritis and we tend to overlook it. If you're not convinced about the nature of the pain, see whether you can get any clue as to whether it is angina. Angina can be precipitated this for ease, exertion, physical. In elderly, it is most commonly straining at stools. That is why we always had a stool softener at the time of discharge. We always tell them not to strain. Eating, after eating, postprandial, most of the gut blood goes to the flanking circulation, coronary flow is reduced. After emotional disturbance, either it is good or bad, or after an extreme temperature, high or cold or hot climates. So with the nature of pain, angina nature will be the same. But with the nature of pain, you have to see whether you can differentiate whether it is chronic stable angina, whether it is unstable angina, or whether it is ST elevation myocardial infarction. That will depend upon the duration of chest pain and the relieving factors. If the pain is less than 2 to 10 minutes only, usually it relieves when the patient takes rest with a nitrate sublingually. It is being relieved. Most likely it is chronic stable angina. It's a chronic plaque. Sometimes the pain takes more than 10 minutes, but it is relieved within 10, 20 minutes or half an hour. You're usually dealing with a non-ST elevation or unstable angina. When the patient pain doesn't get relieved, even with nitrates, and the patient's intensity is more, and it is around 8 or 10 out of 10, the patient knows it is something different, usually dealing with ST elevation myocardial infarction. For all the postgraduates, don't believe the first ECG. 25% of the patients who come with ST elevation myocardial infarction, the first ECG is normal. This was done in our hospital at 8 a.m. See, the ECG is absolutely normal. That is why I told you in the middle of the night or any time when the pain is very convincing, history looks like angina, but the ECG is normal, don't get fooled. You always advise observation or admission for the patient. This is done at 9 a.m. When you have a patient with chest pain, but ECG changes are not there, the best thing you can do is you'll have some small suspicion in inferior leads or anterior leads. Ask the staff to collect the monitor in that lead. If you have suspicion lead 2, the monitor should be showing lead 2. When you have suspicion in anterior leads, the monitor should be showing anterior leads. So any point of time when the patient complains of chest pain while you are observing or the monitor lead shows some abnormality, T-wave inversion or something, immediately do a 12-lead ECG. You will be not missing the diagnosis. For that, you cannot be making the patient wait forever. After 3 hours, you can do a high-sensitive troponin. After 6 hours, you can do troponin to rule out. But if you are convinced it is angina, you always advise admission. Right, that is for coronary, that is angina. Non-coronary, again, there are a lot of things. One you should not miss is aortic dissection. Unlike angina, where the pain slowly increases over a period of few minutes, in dissection, the pain is maximal at onset. It is 10 by 10 at the onset. Then it can persist like that or it can come down. That is aortic dissection. Maximal pain at the onset, 10 out of 10 pain. Pain more at the back and radiate to neck, abdomen, limbs. Here, the differential diagnosis or the clue will be based upon whether you have any of the limbs is affected or the aortic valve is affected. You can have aortic regurgitation or you can have differential blood pressure if one of the limbs is affected. The other thing which is not uncommon, but patient can still come with chest pain in is a patient with pulmonary embolism, especially a peripheral pulmonary embolism with a small infarct can have pleuritic type of chest pain. Here, when you see this ECG, we can always think it is a coronary event when you have this T-wave inversion. But again, the second commonest after sinus tachycardia, the second commonest ECG finding in a patient with pulmonary embolism is this T-wave inversion because the right ventricle is pushed. So normally this V2, V3, V4 records events from the left ventricle. When the right ventricle is enlarged and it is under strain, this is reflecting ECG pattern from the right ventricle. So this is right ventricular strain, not left ventricle. So please do not think when the patient doesn't have S1Q3 T3, you are ruling out pulmonary embolism. It is present only in 10% of patients. Commonest symptom sinus tachycardia, then this T-wave inversion. But obviously, apart from chest pain, patient will have dyspnea. So the predominant complaint in patients with pulmonary embolism will be dyspnea. But patient who has a peripheral emboli with a pleuritic type of chest pain, you are still dealing with pulmonary embolism. So whenever you have doubts like this type of ECG, sinus tachycardia, you have pleuritic type of chest pain, always do a D-dimer to rule out pulmonary embolism. The D-dimer is negative, you are ruling out pulmonary embolism. It is positive, you do a CT pulmonary angiogram to confirm diagnosis of pulmonary embolism and start subsequent treatment. The other diagnosis in non-coronary chest pain is acute pericarditis. It is a sharp pleuritic type pain. Most common, it is seen in acute myocardial infarctions on the third or fourth day when again patient complains of chest pain. But what you need to know is you ask the patient for the nature of the chest pain. The nature of chest pain will be very different from the chest pain or the day of onset of MI. So here the pain is worse on lying down and during inspiration. Sitting up and leaning forward, the patient will have relief of chest pain. Here you should not feel afraid by seeing ST elevation. Here it will not follow any coronary pattern. It will show diffuse ST elevation. Look at AVR will show ST depression. The one lead which shows ST depression in pericarditis is AVR. So this is how you diagnose acute pericarditis. Rarely young females can come with mitral valve prolapse. Obviously you can pick up, there will be low blood pressure, thin built individuals with non-ejection click and lane systolic murmur. So that is about cardiac chest pain. These are the common causes of non-cardiac chest pain which can be equally dangerous. Esophageal spasm is the one which closely mimics angina. It will also be relieved with nitrates, but please remember it will take longer time to be relieved with nitrates. And esophageal spasm is more common in nights because the acid is supposed to stay only in the stomach. It's not supposed to go to the esophagus. We have different epithelial lining. So it goes for spasm. It will closely mimic angina, delayed relief with nitrates and relieved with antacids. Acute cholestasis, obviously, it will be presenting in a typical manner. But you can always look at these symptoms like exacerbation after a meal, having these symptoms for a few days, subacute, associated fever, chills, vomiting. It can mimic. It can tell you you're dealing with a gallbladder disease. Pancreatitis pain is in the upper left side or the middle of the abdomen, radiates to back commonly, and it is worse within minutes after eating or drinking, like cholestasis. More commonly, foods that have high fat content, becomes constant and more severe and lasting for more days. This is easily picked up in the OP. Women or men, young age, coming with costochondral pain. Usually it's the second rib which is involved. You palpate, you'll have tenderness. Sometimes you can even have swelling and warmth there. Cough and sneezing can provocate the chest pain. Herpes zoster, not to miss. That's why in our teaching, you always strip the patient. If you have any suspicion, don't feel ashamed, even if it's a lady. Ask, have a female attendant, strip and see whether you are missing herpes zoster. Here it will be a typical burning, deep pain. Patient will have rashes and blisters and will follow a dermatomal pattern. Rarely we can come with, I told you 5% of the time you do not have any cause. You do not know what is the reason for chest pain. It can be somatic, sleep complaints. Patient usually have panic attacks and tachycardia. Right. If this history is not adequate enough to give you the clue for the chest pain, ask for relieving symptoms. Sublingual nitrate and rest relieve in 1 to 5 minutes. If not, it's an ACS or non-anginal chest pain. Esophageal spasm, sublingual nitrate relieves chest pain but takes longer time. When you're standing or sitting quietly, the pain is relieved. It is angina. Breath holding in deep expiration is relieved. It's usually pleuritic chest pain. Bending forward, the pain is relieved. It is pericarditis. Food and antacids, the pain is relieved. It is acid peptic disease. And belching, if the pain is relieved, is usually acid peptic disease or anxiety. So to summarize, I'll just tell you, whenever you see a patient with chest pain, remember the 6 causes. ACS, pulmonary embolism, dissection, rupture, pneumothorax, and pneumonia. Thank you for your patient hearing.
Thank you, brother. You did very well.
Oh, thank you, sir. I was looking at the clock. So I think before all of you leave, I just wanted to, there are a lot of people being honored. The gentleman who's sitting next to me, sir, can you please identify yourself and stand up? You know how old he is? Yeah, he has come for all Tapicons. He's practicing in Tuticorin. I know himself. He's 88 years old. He has not missed a single Tapicon, and all the medicine update programs which we have organized from Trichy for the past 23 years, he has come for everything. And wherever I go, I have seen his presence. I thought I should sit in front of him and start a conversation. So he was taking all the videos and photos. He was telling me his grandson, granddaughter are doing post-graduation. So he wants to share the knowledge with them. So this learning, this learning never stops and never dies. Thank you for being an inspiration for all these. He told me that. Yeah.
Shall go for the floor.
It's open for
Yes.
questions, doubts.
No problem, sir. Yeah, you can please be seated because general comments. And I thought this is first MBBS clinical teaching. What is the need for a physician or senior physician to attend? But I felt that it is a need for everybody, either a MBBS student or DM candidate or the senior person of 100 years. It is necessary because it consists of everything. Cough in a GRD. There is no problem with the respiratory system. There is no problem with the brain. There is no problem with the chest. What medicine to give? How, even if you give antacids, how it relieves cough? Antacids for a GRD, but how it relieves cough? Again, GRD can produce breathlessness. GRD produces chest pain. There are people who come with chest pain in the middle of the night. We go treat as a typical epigastric pain, fullness, abdominal fullness. You take an alcohol. We give antacid, send home, become completely all right, goes home. After 2 hours comes with the MI. But the question is why he became all right? 2 hours he was all right. Only it's 4th hour he develops a problem. Then what's the mechanism acting? So later we realized that the reflux of acid, the first 2 centimeter of the esophageal junction, it stimulates the receptor in the lung that causing bronchospasm. That's for a cough. The reflux of the acid in the first 2 centimeter of the esophagus causes coronary spasm, causing chest pain. If you release that, the chest pain improves. When a patient is taking cough, talking in a podium, continuously taking water, is it the water decrease the cough? Is the water is not a cough suppressant, but immediately cough is suppressed because it's washing out the acid from the lower esophagus. Thereby, the receptor stimulation is not there. So much is there for a simple cough, but the treatment is such a complex one. So it's really all the experts. That's why the Dr. Ramkumar, Dr. Shanmugam sir, and all of the experts been put because they are rich in clinical medicine, rich in the updated knowledge, and rich in the experienced medicine. So probably that is the reason they have put the last session. I really enjoyed. I'll congratulate all the speakers, including the chest pain, all the topics. But I want all the topics were excellent. And if at all any queries from the floors, also we try to interact.
Call upon the chairperson to hand over the mementos to the speakers.
I request Dr. Surendra Babu sir to felicitate Dr. S. Gopalakrishnan sir for his talk. So kindly come on to the dais. Let's give a big round of applause. I request Dr. K.V. Murli sir to felicitate Dr. S. Ramkumar sir for his talk. I request Dr. Surendra Babu sir to felicitate Dr. K. Shanmugam sir for his talk. I request K.V. Murli sir to felicitate Dr. V. Vignesh Sukumar sir for his talk. I request Dr. Surendra Babu sir to felicitate Dr. L. Muttumani sir for his talk. I request Dr. K.V. Murli sir to felicitate Dr. A. Kader Sahib sir for his talk. I request Dr. A. Kader Sahib sir to felicitate. I request Dr. Kader Sahib sir to felicitate Dr. Surendra Babu sir and Dr. K.V. Murli sir for having chaired the session. Thank you, sir. Thank you, sir. Next, we are moving on to the next topic, which is oncology. I request the chairperson, Dr. N.K. Sendilnathan, sir, SRM, to kindly come on to the dais for chairing the session. I request the chairperson, Dr. N.K. Sendilnathan, sir, to kindly come on to the dais for chairing the session. Now I invite our first speaker, Dr. Arun Seshachalam, sir, from Tiruchi, on the topic oncology post-chemo care.
Good afternoon to one and all. First of all, I thank the organizer for giving me opportunity to chair the session. The speaker is Arun Sheshasalam, ESMO Award for Excellence in the Field of Medical Oncology, ESMO Award for Excellence in the Field of Medical Oncology 2013 Netherlands, Outstanding Youngster Achiever Award 2013 JCI Union Indian Zone, Dr. K. Sanjeevi Award 2011 Serving the Underprivileged and Ethical Practice of Medicine, Executive Management Program in Healthcare Management Essential, and University of the Virginia. Over to speaker.
Thank you, sir. So I think two sessions generally we should avoid. One is pre-lunch, another is the post-lunch. Okay, so we all know that. But despite that, many of you are here. So I think we are discussing one of the most important topics, that is post-chemotherapy care. So why this is important is because of two reasons. One is the incidence of cancer is increasing day in and day out. Okay, if you see the global incidence, 1 in 3 men in their lifetime will get cancer. 1 in 3 men in their lifetime may get cancer. That is first. 1 in 2 women will get cancer in their lifetime. Okay, and third thing is more and more cancer patients are cured and more cancer patients are coming back to the community. And last, even if it's a stage 4 metastatic disease, now we are able to have a lot of targeted molecules through which we are able to prolong their life and give you a good quality of life. And again, these patients are coming back to the community to get treated by their family physicians. So it becomes very important for one reason, because patient will go to Chennai, Bombay, even Delhi, take their chemotherapy, but they always will come back for the post-chemotherapy care to their physicians. Okay, because chemotherapy is just 3 hours. So they fly to Delhi, they will take their chemotherapy, and next day they will land up to us for further cancer care. So it is very important for us to understand what are the complications that can happen once the chemotherapy is received by the patient. So in nutshell, to give you an overview, cancer drugs can be classified into 3. One is chemotherapy, another is immunotherapy, third is targeted therapy. Chemotherapy is any drug that acts on the cancer cells. Immunotherapy is when you use monoclonal antibody to target the cancer cells. Targeted therapy is called magic bullets. Okay, these drugs will act only on cancer cells. So these are a general division of anti-cancer drugs, and each chemotherapy drugs and acts on different phases of cell cycle. Okay, certain chemotherapy drugs will act on mitotic phase, some will act on synthetic phase, some will act on G1 phase. So each drug is very cell cycle specific and it acts on different phases. So it is very important if you see, okay, what is the basis, rational behind combining chemotherapy drugs and why we give 6 to 8 cycles, what is dose intensity. Okay, this model if you see, for any cancer to be identified, if I want to palpate a cancer in any patients, that patient should achieve at least 1 billion cancer cells in their body. Unless 10 power 12 cells accumulate in the body, we cannot diagnose a cancer patient either by radiology or by inspection or palpation. So you can see, this is the curve. This is the clinical detection. Only when the cancer cells achieve 10 power 9, when the numbers achieve 10 power 9, that is the time we can make a decision that the patient is having cancer. So this is called comparison model of tumor growth. Okay, just remember why it is important is when we give chemotherapy, it follows a logarithmic cell reduction. Okay, every cycle we give, there is 3 log cell reduction happens. Okay, every time, for example, if there is 10 power 12 cancer cells are there in the body, if you give chemotherapy, there will be 3 log cell reduction will be there. So from 10 power 12, 3 log 10 power 9 it will become. Okay, so for a cancer to decrease to 0, okay, if you to become undetected, you need minimum 6 cycles. Okay, because every time you give chemotherapy, there will be 3 log cell reduction. Okay, so chemotherapy cycle is given once in 3 weeks. Okay, first 2 weeks, there will be 3 log cell reduction will be there. So from 10 power 9, it will reduce to 10 power 6. So what happens is you give 3 weeks. So first 2 weeks will be reduction, and next 1 week we give for the recovery of the patient's body, stem cells and mucosa, all these things for recovery, you give 1 week duration. So in that week, 1 log reduction will increase. Okay, so 3 log reduction will decrease. 1 week gap you give. In that 1 week, cancer cells also will increase. So ultimately, if you give chemotherapy once in 3 weeks, every time you decrease 2 log reduction. Okay, so ultimately, if you want to achieve 0, that is all the cancer to be destroyed, you need to give minimum 6 to 8 cycles. So this is the concept by which most of the regimens are designed. Why chemotherapy is given once in 3 weeks, 6 to 8 cycles? Because we need to achieve that 0 cell in the body. Okay, so that is the concept. And we give combination. Every time chemotherapy is given, we give 2 or 3 agents together because each agent acts in different phases of cell cycle in a different way. If the cancer is resistant to one drug, probably the other mechanism may act and the cells may get destroyed. So this is the rationale for using combination regimen. This is the rationale for using 6 to 8 cycles. And this is the rationale for maintaining dose density. Because if you give more than 3 weeks, if I give chemotherapy instead of 3 weeks, I give 4 weeks, what will happen? In the 2 weeks, the cells will again increase. So it is very important you combine the drugs, you maintain the dose intensity, you make sure that the post-chemotherapy care is taken care appropriately. Okay, so this is the rationale. And why post-chemotherapy care important? Because these cancer cells is not going to affect only the cancer cells. The chemotherapy will affect the cancer cells, but also normal dividing cells, particularly the cells that is dividing in a faster rates. Okay, the mucosa, the stem cells, and the hair. Okay, if you see, most of the patients will have alopecia because the hair follicles has the highest proliferative rate. Most of the cancer patients will have mucositis, oral ulcers, because the mucosa is highly regenerative. Last, most of the patients will have neutropenia because the stem cells are proliferating. So the chemotherapy is going to act on the cancer cells, and it is also going to act on other normal proliferating cells in the body. Okay, so this is important. Anytime when you go back to your practice, you always remember you give chemotherapy day 0, day 7 the toxicity will start, and day 14 it will reach. This is called the nadir. Day 14 is always the peak. That is where all the toxicity will go to the maximum, and from day 14 to day 21 the recovery pattern starts. This 14 to 21, this is the time all our body cells try to recover, and this is the same time where cancer cells also will start proliferating. As normal cells are proliferating, cancer cells also proliferating. So what we are going to do now is we are introducing dose dense regimen. Before, we didn't have effective antimicrobial agents. We didn't have growth factors, that is called colony stimulating factor. We didn't have that. That time we made sure that we gave 2 weeks and we gave 1 week break so that we allow the cells to, normal cells to regenerate. Now what we are doing is, this nadir, we start adding growth factors so that we rapidly increase the regeneration of normal cells. So now we are decreasing the cell cycle, chemotherapy cycles to once in 2 weeks regimen. That is called dose dense regimens. So more and more these days, because of effective supportive care, we are decreased from 3 weeks to 2 weeks. Whenever chemotherapy is given once in 2 weeks, that is called dose dense regimen. Many of the fit patients, when the patients are fit, when the tumor is aggressive, particularly like Burkitt's lymphoma or DLBCL, where the tumor is aggressive by itself, we try to give once in 2 weeks so that we decrease the tumor population. So this is the slide where post-chemotherapy care, what all the possibility. One is immediately after chemo start. Once you give the chemo, the reaction happens. Okay. So what all that? One is anaphylaxis. Most of the anaphylaxis is for monoclonal antibodies. Okay. Any MABs, okay, rituximab, bevacizumab, last MAB, when the cancer drugs ends with MAB, it is called monoclonal antibody. Okay. These drugs will have lot of reactions. So anaphylaxis is common whenever you use MABs. Extravasation. Extravasation is when the chemo is given outside the veins. Okay. That is called extravasation. So it is very, very important. Chemotherapy is given by the trained nurse, because getting the appropriate cannula, making sure that there is no double puncture, making sure the drug enters into the veins. Okay, it is very important, because only treatment of extravasation is prevention. There is no treatment. Extravasation, there is no treatment at all. Okay, it is very important. When you write the drug, the best nurse should give, most experienced nurse to give, and most important, that nurse should have the capacity to tell, I cannot get a proper cannula. Okay, if the nurse tells, sir, it's a difficult cannula, then we need to get alerted. Okay, we need to call the patient. You need to tell that I'm going to put a center line. You should not pressurize the nurse to put a cannula and give chemo, or call better nurse to put a chemo. So the most important is extravasation prevention. Okay, so some patients, particularly when they get anthracycline, they can have urine distillation, red color urine, while getting chemotherapy. Then last is nausea. 20 minutes, right? Yeah. So the next, this is immediately while getting the infusion. The next is nausea, vomiting, myelosuppression. This is again important, because myelosuppression is neutropenia. Any patients having neutrophil less than 1500 and having fever, it's a medical emergency. How it is chest pain for Dr. Kader, for me, a chemo patient with fever is a medical emergency. So myelosuppression is one thing we should always keep in mind. That happens on day 7. Again, remember, for any chemotherapy, it is between day 7 to day 14. They will go in perfect health to the oncologist. Okay, day 7 they will come to the physician. It happens to me as an oncologist also, because they will take chemotherapy in Chennai, but when something happens, supportive care, they will come to me. Okay, that happens. Day 7 exactly, that is the time where they needs the maximum care. So any patient coming to us with fever and exactly in the nadir, okay, 7 to 14 days, there can be a medical emergency. Okay, diarrhea, particularly certain drugs, particularly 5-fluorouracil. Okay, when 5-fluorouracil capecitabine, when they receive and they are having diarrhea, it means that they are having 5-fluorouracil mediated or complicated diarrhea. It can be very severe. If not treated properly, patient can die within 24 hours. And most important is hydration. When 5-FU-induced diarrhea comes, first is hydration, second is loperamide. Okay, you can go 2 tablets 4 times daily for 2 to 3 days. And third most important thing is octreotide. These are 3 agents which can be used for 5-FU-induced diarrhea. And mucositis. Many of the patients, because already I said GI is one of the most proliferating cells. So mucositis is another complication for most of the drugs. When patient comes with mucositis, make sure that patient is hydrated well. They are able to eat properly. If they are not able to do, give IV fluids, support the patients. Patients will recover in next 3-4 days once that nadir is crossed. Okay. Then delayed complications, some of the complications, hair loss. Not all chemotherapy has hair loss. There are certain chemotherapy drugs which are not prone for hair loss. Neuropathy, particularly taxols, paclitaxel, docetaxel, vincristine, they are prone for neuropathy. So in these patients, when the patient is diabetes on diabetic drugs, we should make sure that other causes of neuropathy is well under control, because these chemotherapy-induced neuropathy will come 6 months to 1 year, and it will take up to 2 to 4 years for complete recovery. And hand-foot syndrome, the patient will have proliferation of skin and palms, and there will be erythema of palms will be there. This is common with 5-FU like drugs, particularly 5-fluorouracil, capecitabine. And last is late side effects. Okay, that is cognitive dysfunction. There will be drop in IQ can be there, particularly when the patient is on high dose methotrexate, cranial irradiation, cardiomyopathy, anthracycline mediated. Okay, any patient on adriamycin, cardiotoxicity is common. Second malignancy, ototoxicity, and pulmonary fibrosis. These are the late complications. These are some of the photographs of post-chemo patients. This is the typical mucositis. This patient received a 5-FU infusion, came back with us on 8th day with mucositis, grade 3 mucositis. And this is the hand-foot syndrome, what I said. This patient is on sorafenib. Okay, tablet sorafenib is a VEGF inhibitor. This is targeted therapy. Okay, it goes on, it's a small molecule, so it goes and attached to the tyrosine kinase. It is used for hepatocellular carcinoma. So this patient on sorafenib, exactly on third month of sorafenib, patient presented with this. They can be so severe that they can have skin peeling. They can't even step on the floor. Okay, so most important is urease-based cream. Give a treatment break and restart the drug with a lesser dose. This is the extravasation. This is the most dreaded complication, because when a chemotherapy is given and extravasation happens, it's a medico-legal issue also, and there is no treatment. Okay, most important is prevention, as I said, and identifying is also very important. Okay, so where you place the cannula. Okay, always make sure that cannula is placed below the wrist on the, because this is the area not much of tendons and nerves are there. Even if extravasation happens, not much of loss of movements will happen. So which side the cannula is put, and most important is prevention. And if extravasation happens, identify it early, notify to the oncologist immediately, refer them back, because it's very difficult to manage, because it is implicating directly the hospital service. Okay, and worst scenario, the patient will go for ulcer and tendinitis and may require plastic surgery and tendon transfer also. This, any thoughts? What is this? What is this? This is port. Okay, so most of the patients, chemo patients, as I said, this chemotherapy is given for years nowadays. Okay, for example, if you take a breast cancer patient, they are taking chemotherapy for 1 year, 2 years. There are patients who are taking Herceptin for 4 years. Okay, getting a cannula for these patients is very difficult. So we implant a port, implantable chemo port. That is, it's a central line. We put in the subcutaneous area, which can be accessed even 1,000 times. You can prick 1,000 times this port to give IV fluids or drugs, anything. So this is chemo port. This patient typically said to us immediately after port, patient said that I have pain in the chest. When we saw, this is a port site abscess. Okay, so it's very important whenever the patient is having port, hand hygiene and all aseptic precaution is taken care. And next important is any patients on chemotherapy. Okay, patients on chemotherapy, when they come back for any surgical emergency, we should see two things. One is, when was chemotherapy given? Because we have seen patients where chemotherapy was given and patient was operated for hernia on 8th day. Okay, that time exactly WBC dropped to 400. Okay, so it's very important that operation should have been planned after 3 weeks after the last chemotherapy drug. So any surgical procedure, we need to see when was last chemotherapy given. Give adequate time, at least 3 weeks for the counts and WBC counts to recover, and then, and certain chemotherapy drugs, particularly bevacizumab, a monoclonal antibody against VEGF, certain agents, when you give at least 4 to 6 weeks, we need to wait. Okay, so any patient drops back to our OP for any surgery, just check what was the drug given, and we can speak to the oncologist how long we should wait if it's an elective procedure. And next is LV dysphagia. Many of the patients, chemo patients, would have received anthracyclines. Okay, anthracyclines is adriamycin, epirubicin. These are the anthracycline drugs. These are cardiotoxic drugs. Okay, so they are prone for cardiotoxicity. They will present with dyspnea, cough. This is the only symptoms. They may tell that 4 years back I took cancer treatment. This is the only history they will give, and they will present with cough. And when we see, the BNP will be elevated, there will be features of congestive cardiac failure. The diagnosis is anthracycline-induced cardiotoxicity. Okay. The definition for anthracycline-induced cardiotoxicity is any ejection fraction drop 20% from the baseline. The patient had 70% ejection fraction upfront, and now when you are doing, after getting the anthracycline, if the drop in EF is more than 20%, then it's probably adriamycin-induced cardiotoxicity. And what is important is, what is the cumulative dose of adriamycin that is given? That is important, because more the dose of adriamycin or anthracycline is given, patient is prone for cardiotoxicity. So this is again one of the paper which we published actually. This paper is, we took acute leukemia patients. Okay, we took acute leukemia patient, adolescent patients. After 2 years of high dose methotrexate and cranial RT, we did the neurocognitive assessment. We did the IQ assessment for that patient. We published. What we found, a significant drop was there. You can see there is a significant drop for all these patients in performance IQ, visuospatial, processing speed, planning, verbal attention, verbal fluency. All these things dropped from the initial baseline value to 2 years post high dose methotrexate and cranial RT assessment. And this patient is on regular follow-up, and we are assessing the patient at 5 years also to see whether this drop in IQ, all these things are recovery. So these patients, even after taking all the chemotherapy, getting cured, when they go back to the community, they may have other neurocognitive problems also, which we should always remember, and it should be addressed. So what are the factors that can predict? Which are the patients we need to be very careful when we refer to the oncologist and coming back to us? Okay, as a physician, any patient, an elderly patient, when they already have a lot of comorbidities, general condition is not good, a smoker, multiple uncontrolled comorbidities, the uncontrolled diabetes, uncontrolled hypertension, genetic polymorphism, because certain patients have a particular gene deficiency will be there. But for example, DPD enzyme deficiency, this is called dehydrogenase enzyme deficiency. Okay, this enzyme deficiency, if it's there, they are prone for 5FU-induced drug toxicity. Okay, so there are particular individuals who are prone for drug toxicity. So this is a recent, like yesterday, day before yesterday, patient, a Hodgkin's lymphoma patient on ABVD, landed up into emergency actually with a dyspnea. First symptom was cough. Okay, and patient was admitted, started an IV antibiotic, and in the night patient was desaturated. CT test was done. Okay, so any diagnosis, any suggestions? Patients on ABVD, Hodgkin's lymphoma, cough of 1 week duration, fever of 2 days. CT test was done. You can see it's predominantly pleural based, bilateral, mainly affecting the lower lobe. Yeah, so first is COVID. SCORAD-4 was the diagnosis. Okay, SCORAD-4, COVID was the first thought. So we sent for COVID, all the COVID testing, everything was negative. So we should always never forget bleomycin-induced toxicity. Of Hodgkin's lymphoma, ABVD was given, bleomycin was given. So this patient is going to come for cough to the physician. They are not going to, because this patient landed up in the emergency, and I got the call the next day from the emergency department about this patient. Okay, so the patient is on bleomycin. In the bleomycin patient, this kind of picture, the first diagnosis for us is bleomycin-induced lung damage. So the typical features is the bleomycin lung damage, mainly lower lobe. It will be morely pleural based. There will be hilar sparring will be there. More of organizing pneumonitis kind of pattern. It is very difficult to differentiate between interstitial lung disease, viral pneumonitis, and BLM-induced lung damage. Well, what is most important is BLM-induced lung damage, unless we give steroids, okay, the improvement we cannot see. Okay, so it is very important we do the lavage, rule out infective causes, then only we can go for steroids. So last, this is the port catheter. This is the port. So we insert this port into all the patients who are receiving chemotherapy for more than 3 or 4 months. Okay, so this has a drum, and it is connected through a central catheter. It is inserted into the superior vena cava. It goes to the right atrium. So last, I think last is febrile neutropenia. As I said, it's a medical emergency. Up to 70% death can happen if we miss a febrile neutropenia. How important is timeline is within 15 minutes we should do the assessment. Within 1 hour, all evaluation should get over. The antibiotic should go. First antibiotic IV should go inside within 1 hour after completing all the investigation. So it is the timeline is there. 15 minutes assessment. Within 1 year, all investigation it should go inside. So class, what is febrile neutropenia? Neutrophil counts less than 1,500. What is severe febrile neutropenia? When the neutropenia is less than 500 or expected to fall less than 500. Okay, so you calculate febrile neutropenia, you know neutrophil percentage. Okay, what is the percentage into total WBC counts? You classify all the patients into two risks: low risk, high risk. Low risk is any patient, adult patient, less than 60 years, solid tumors, not intense treatment, neutropenia expected to fall, increase within 7 days. Okay, this is called low risk. High risk is elderly patient, uncontrolled comorbidities, you expect neutropenia to prolong more than 7 days, hematological malignancy. This is high risk. Any high risk patient, post chemotherapy in nadir, landing to you, admit the patient, send the culture, start the IV antibiotic within 1 hour. So these are the antibiotics most commonly used. My personal practice, first line I use cefoperazone sulbactam along with levofloxacin or amikacin, because we use double pseudomonal coverage whenever we treat febrile neutropenia. Second line is piperacillin tazobactam along with levo or amikacin. Third line is meropenem, and we assess the patient every 48 hours. Okay, if the patient is deteriorating, escalate the antibiotic, look for the cultures. If the patient is having central line, always try to add vancomycin to it. Okay, if the patient having a catheter and the fever is not improving, remove the catheter. So last summary slide, whenever the patient lands to us, see the diagnosis, see the stage, see the intent. Okay, intent is end of life support care. No point in giving aggressive ICU admission or ventilatory care. So always see what is the intent, what was the last discussion with the oncologist, see what is the regimen that has been received, look for the central line or central port. Okay, what was the previous blood culture positivity? Based on that, you can plan the antibiotics. When was the last treatment given? If the treatment was given 7 days before, there can be a medical emergency. Admit the patient, speak to the oncologist. Okay, are you dealing with the nadir period? And am I dealing with the febrile neutropenia? When this question should always happen whenever we are dealing with cancer patient. Last slide. This is my recent article. What makes a cancer team successful? I think one of the most important, apart from all the team dynamics, one of the most important is having the communication channel open to the treating physician or family physician. This is very, very important because the patient get oncology care for 1 day, but the rest of the 21 days, they are going to be with the family physician. So keeping the communication channel open to the family physician is always very important attributes of a successful cancer team. Thank you. Thank you very much.
Thank you, sir. Next, we invite our next speaker, Dr. Krishna Kumar Ratnam, sir, from Madurai, on the topic cancer screening.
Good evening to the esteemed faculty, and thanks to Tapicon for having given me an opportunity to share some of my points, which I think is not just for the physicians but for the doctors in general, because I know this has come as probably the last topic of this conference, but this is a very, very important topic, because amongst the non-communicable disease, we all know that cancer is really, the numbers are becoming like an epidemic. So just like how Arun said that certain complications instead of treating has to be prevented, cancer only has to be prevented if you want to really save yourself. So save yourself meaning you and your patients. So I'll just be giving a very quick gist on what are the various cancers that are amenable to screen in the community, and what are the current guidelines, and in India, what are the cancers which we really can intervene with the screening technique. So, as already introduced, I am Dr. Krishna Kumar Ratnam. I am Arun's classmate. We have been together from our MD right up to DM and post DM. So I head the department in Department of Medical Oncology at Meenakshi Mission, which is a teaching postgraduate institute, and This is one topic which I also insist on my postgraduates, which generally gets neglected. So I was very happy that this topic was given to me by the Tapicon faculty. And last but not the least, I am a physician myself, MD General Medicine physician, and oncology is a subspecialty. So I never feel an outsider in Apicon. So looking at the cancer burden in India, it is quite huge, especially if you see the Globocan data. The numbers are cascading over the last 1 decade, and at least 1/3 of the cancers, nearly about 34% of cancers, can be prevented by screening. So this is what we teach, and we were taught. We teach during the cancer awareness programs the warning signs of cancer, which we as physicians have to see in our patient. Any change in bowel or bladder habits, especially in the elderly patients. Even today, I remember the page in our surgical book which used to say an undiagnosed iron deficiency anemia in an elderly person, you will have to rule out colon cancer. Similarly, nowadays, undiagnosed anemia, there is so much more. We think it's iron deficiency anemia, we think it's nutritional anemia. He may turn out to the physician as a myeloma. He may turn out to the physician as a myelodysplastic syndrome. So there is plentiful for diagnosis from a simple anemia. Similarly, any change in bladder or bowel habits, a wound that does not heal in the normal situation to the physician is a diabetes. But from the onco point of view, we'll have to see whether he has any other immune reconstitution problems, especially neutropenia. These patients may take a longer time for their infections to clear. Any unusual bleeding or discharge. Now, this is important from GI point of view. Patients can come with history of dysphagia. We have been taught time and again about dysphagia for liquids and solids. And as physicians, we are brilliant in diagnosing dysphagia for liquids because we will start looking for neurological problems. But very simple history of dysphagia for solids. தண்ணி குடிச்சாதான் சாப்பாடு இறங்குது is directly a diagnosis. Most of the time, you'll be right, you'll be diagnosing an upper GI malignancy. In the women, if there is going to be a lump anywhere in the breast, and this is not cancer always, but this awareness has to be there right from 20 years of age. I will be coming to that during the screening of breast cancer. And in a smoker, if there is going to be a nagging cough, which we as physicians keep calling it the smoker's cough or the COPD cough, but if it lasts unduly long, we need to at least screen him whether there could be cancer. So, in a resource limited setting like developing countries, I should not say it's resource limited. India is never resource limited, it is resource plentiful that we may even overuse certain resources. A screening test, technically, it is a secondary prevention method where we employ early diagnosis and prevention of cancer. It is for the asymptomatic population. So, whenever we talk to the patient and we ask them, why did you not come to us with this problem? You say you had this lump in the breast for the last 3 years now. They say, அதில் ஒன்றுமே இல்லை, வலியே இல்லை, அதனால நாங்கள் வரல. So, the same thing. See, I'm not saying that we physicians are intelligent enough that we won't do this to our patient, but we can sometimes do this to our family members. So, I would rather say that this, like how they say charity begins at home. I think what we learn in Epicon first, I think if we start applying to our own family members, I think that's where we first have to change practice. And then we can start thinking of whether we can apply this in our community practice. So the goal basically is to reduce mortality due to a particular cancer. And what is this ideal screening test that can be employed by physicians or community practicing doctors? It has to be a cheap test. Cannot be very expensive, and it has to be sensitive enough and specific, because patients, you cannot keep calling them back and forth. Getting a patient to get screened once itself is in a lifetime is very difficult. And let us say I introduce a very complicated machinery which is available only in one point at Tamil Nadu and say that that is the best screening method. Obviously it cannot be there, so it has to be quite accessible and safe for the patient. But we all know that there are pitfalls for screening. With the awareness that we try to implicate on for our population to our patients, a lot of overdiagnosis can also take place because there could be a lot of false positive. There can be, sometimes asymptomatic and non-cancerous conditions which induces certain types of fear in the population. So cancer screening cannot always be a part of a routine general health checkup. It has to be tailored. So now I will come to this point because many of the hospitals and many of the labs offer various tumor markers as a part of their health check package. Now, I can put my hands down and tell you 9 out of 10 tests which have been referred to us and recommended to us, probably not by guidelines, but by the laboratory or the person who comes for cancer screening, they are useless. So please make sure that when we prescribe a health checkup, suddenly there will be somebody coming with a CA 15-3 marker, which is borderline high, or somebody who suddenly comes with a CEA, which is borderline high. Okay, that we can be happy we picked up something, but that always need not be cancer. It is not a sensitive biomarker. So that is why this is the importance of a screening test. So I have started my first slide. What is a screening test? Where it has to be applied? And there are a lot of fallacies with screening tests. So as physicians, we should be aware of this. So this is one point that I wanted to drive back to the postgraduates here. So these are the common cancers, at least, which has tried screening to prevent mortality. But now the top three which I have put up in the list, the breast cancer, cervical cancer, and oral cancer, are the only three cancers which have been recommended in India, because you know that we cannot go with individual practices, but we'll have to go with the mass. So the National Cancer Control Program, the NCCP, and along with the Prevention of Health from the Union Ministry, has designated certain guidelines as to which cancers can be taken up for community screening nationwide. So it's breast cancer, cervical cancer, and oral cancer. So I'm just going to concentrate only on these three, and that would help both of us go home, not just quickly, but with some salient points. Breast cancer. Has mammogram really reduced breast cancer death? Or are we just diagnosing more and more cancers and just putting in more fear into our women? This data is from the West, but you can see that there is a 42% decrease in the mortality when we screen and detect breast cancer rather than a breast cancer which has come to the physician directly from the patient. So 42% decrease in mortality is a very, very huge number. So you have, for every 100 patients, you're going to save 40 patients. So that's a huge number. And at what age does generally globally guidelines are there to recommend cancer screening of women? It is usually beyond 40 years of age, not earlier than 40 years of age. And when they do it appropriately, you can achieve this figure of 40% decrease in the mortality due to breast cancer in our women. So this is a guideline which has been issued by the National Cancer Grid. So what is this NCG? NCG is a consortium of cancer centers. My department at Meenakshi Mission, I am also a part of the investigator with the NCG. So we work closely with Tata Memorial Hospital and at least another 25 centers across India. So they have given clear guidelines. We should not restrict to Apollo or restrict to Meenakshi Mission or restrict to government hospital in Madurai or government hospital in Trichy. So they have given clear guidelines for all the settings. So in the resource limited setting, clinical breast examination is the easiest thing to do by the physician or the gynecologist, whoever the women goes to, and normally it starts from 30 years of age and to be done at least twice a year. And from when do we start? Usually the clinical breast examination, ideally from 30, but at least from 40 years of age. Okay, this is because before that, what has been advised for the women in breast cancer awareness is self-breast examination. We have trained few nurses in our department who normally teach breast self-examination, and that can help detect cancer at a very, very early stage. And definitely it's a simple easy tool and it's available everywhere in the internet. So if you are a physician and especially a lady physician who is practicing and you can, if you want to do something for the community, the simplest thing will be from 20 years of age, bring in the breast cancer awareness and then ask the women to do self breast examination monthly once during a fixed day of the menstrual cycle, preferably after 10 days. So that starts from 20 years of age. Clinical breast examination, ideally from 30, but at least after 40 years of age. And mammogram, every year is a recommendation in the West, but the National Cancer Grid has found that it's going to be a bit difficult to convince. So, asymptomatic women, at least once in 2 years, we will have to do mammogram. So, this is a simple recommendation that has come, and this we are trying to implicate. So I used to give the rule as 20, 30, 40 rule. So from 20 years, self breast examination, from 30 years, clinical breast examination twice a year, and 40 years, mammogram every 1 to 2 years. But there are women who have higher risk for breast cancer. They are not the average woman in the community. So these are people who have previously, one side they've already been diagnosed with breast cancer, so the other breast has an increased risk, or they had radiotherapy, or they have certain genetic syndromes which make them more susceptible for breast cancer. For these, we have definitely better guidelines. We may have to start breast cancer screening much earlier, even before 40 years, probably from 35 or even 30 years. Normally, they say 1 decade lesser than the closest sibling who also got the breast cancer. So here, there is not just mammogram, but they also use MRI in addition to mammogram, because in very young women, sometimes it is difficult to pick up lesions with mammogram because of dense breast. So MRI is a more sensitive tool to pick up breast cancer. So first cancer that we spoke of in cancer prevention is breast cancer. Please just remember the 20, 30 and 40 rule. And young women with history, you may have to start much earlier. Next is cervical cancer. I think we've gone all the way from, all of us from MBBS period have been taught about pap smear and cervical cancer, but there is lot of confusion and dilemmas in today's screening for cervical cancer after the discovery of human papillomavirus kits, which are available for the gynecologist. So should we just do a routine pap smear or should we do a HPV kit? Well, what I would rather say is I would just go back, but this one which I have just marked here, this is a very, very simple guideline. And I'm sure, I mean, most of us are physicians here. We may not be having a hand to all these things. But once again, if there is something in our family, I think we may need to just have, if somebody has, atypical squamous cells of undetermined significance, they are the people who really have to be definitely screened with DNA test on the pap smear, and that would help us to triage these patients and push them for more evaluation like colposcopy. So I'll quickly run, and in fact, the National Cancer Grid has also said that HPV screening can be done in patients with ASCUS, and these patients, otherwise, all the other patients go for the routine pap smear, which is either conventional or liquid based. The third and the final cancer, which our Indian government endorses, is oral cavity cancer, because this is one of the cancers which are in the top 5. And there are patients who are deemed to be higher risk. The ones who have are 40 years or more and who have chronic tobacco and alcohol use, and patients who have already been proven to have oral HPV infection, because once again, the HPV kits are so much available with dental surgeons also. And these patients, especially as the age increases, the risk of oral cavity cancer increases. There are different, just oral examination. Some people go for exfoliative cytology and then they try to see if there are atypical cells. Some people try to go for brush biopsy. So basically, oral cavity cancer screening has to be done at community level after intense history taking. And if there is any high risk factor, it is better to subject them to one of these 3 tests. If there is any suspicious area, you can go for a brush cytology, which is now one of the recommended tests. And then there are additional vital stains which can help in differentiating the normal area from the abnormal areas in the oral cavity. The NCG, the National Cancer Grid of India, has also endorsed that oral cavity cancer definitely needs to be screened, and at least it has to be done about once in 5 years time if identified as high risk individual. But I probably would say that if there is an optimal resource, every 2 years they need to be screened. So this can be done by referring them to regular oral surgeons who would be able to look at all parts of the oral cavity. We normally tend to not look at these minor things, but once you become a cancer physician, or at least you are a patient who has a lot of patients who come to you, if they have these criteria, you better refer them to. Now these are the tests which we are actually doing in community, but I brought them as other tests in clinical practice. Pardon me for doing that. The first three we don't routinely do, but that has been endorsed by the government. Colonoscopy. So colon cancer, the risk is increasing. All these data are from the West. We don't have data much from India, but we can either do colonoscopy, or we can do a guac based fecal occult blood test, or you can do the immuno test using DNA, which obviously, if you're just going to do an outpatient, DNA test is supposed to be best, but the availability and the cost is a problem. So if given a choice, if your family member wants to get screened for colon cancer, one colonoscopy in 10 years is supposed to have the best reduction in mortality, and it has to be started anywhere beyond 45 to 50 years. But in India, guac based, fecal occult blood test is quite enough, but there are a lot of restrictions. If there are some food can cause false positive tests, if the PR examination has been done and then within the 48 hours there can be false positive, so we need to be aware of it. So just look for colon cancer symptoms like unexplained IDA, iron deficiency anemia, or weight loss. That could be a patient for whom you can apply these screening tests. PSA from my time in MBBS and probably MD General Medicine, we used to write it like any other outpatient test. There is a lot of controversy going on whether PSA at all should be used, because a lot of false positive, and you find a lot of patients with non-specific prostate lesions and you don't know what to do with them. But there are recommendations. If at all you want to employ a PSA, go beyond 50 years of age, keep a cutoff of about 7 nanograms, and these patients need a urology referral for TRUS. 4 to 7 is an indeterminate, less than 4 we all know is normal. You have to repeat after 3 to 6 months, but there is a caveat. If somebody has already been on finasteride, or patient has been on anti-BPH drugs, we will have to be careful before taking a decision whether this patient needs urology referral, because a slow increasing PSA for a patient who has been, let us say, on dutasteride with silodosin, which has been prescribed by all of us, and every 6 months there is a borderline rise in PSA, they need early referral. You need not wait till 7 nanograms. The colon cancer syndromes I missed in the previous slide, they probably will not go with the 50 years. There are a lot of other syndromes which the GI specialists will know. They need screening for colon cancer even from the age of 10 in FAP syndromes. So they are not the patients who we would probably routinely see as a physician, but it is better to be aware. Last will be the lung cancer, which is one of the most common cancer which we see in clinical practice. Please see if any of your patients are having these high risk factors: more than 20 pack years, current smoker, or a reform smoker but within 15 years. If the center has the facility to tune down and bring down the exposure and make it a LDCT, low dose helical CT, patients can be screened annually. But it has not come as a guideline for obvious reasons, because for the cost involved with the low dose CT per patient, it may take some time for the government to roll out programs to say LDCT as a standard of care for screening for lung cancer. But if screened, lung cancer can be made curable, because we will be finding a lot of stage 1 patients. So I would conclude here. Screening definitely prevents cancer death in India. In your practice, if somebody asks you what cancer you want to screen, it is only breast cancer and cervical cancer in women. High risk men and women with risk factors for oral cavity cancer. These are just the 3 cancers that are for screening. But if you are in a very resourceful setting and your patient has come forward to get himself screened for other forms of cancer, I would rather say colon cancer is worthwhile because there is availability for colonoscopy. Prostate cancer, do not fall prey to borderline prostate values and then start evaluating the patient. But yes, it is better to know about prostate cancer screening, and lung cancer screening sooner or later would become a standard of care in India. It can help diagnose patients with stage 1 lung cancer. I think thank you for your patient hearing. If there are any doubts, we can go for it.
Thank you, sir. We invite our next speaker, Dr. Tirupati sir from Karaikudi.
The topic for the last session is underdiagnosed and neglected scrub typhus, my 100 cases experience to evidence.
Good evening, all. It's been great pleasure to be here in the Tapicon forum. I thank the Tapicon organizers, Trichy, for giving me the opportunity. And let's go to the topic proper. I am myself Dr. Tirupati, senior consultant Apollo Reach Hospital in Karaikudi. It's an outskirt, lying in the outskirt of Karaikudi. So we have, in my experience, we have seen for the past 6 months nearly 100, more than 100 plus cases of scrub typhus, but never been referred as a case classical of scrub typhus. Usually referred either as a some form of PUO or dengue or any other name. So that's what I want to highlight in this talk. So my topic is underdiagnosed and neglected scrub typhus, my 100 cases experience to evidence. So this is one case scenario, a 65-year male having an intermittent fever for the past 14 days, been admitted in a private hospital, extensively worked up. There was no localizing sign except for severe tiredness. Fever, initially it was in high grade, intermittent, headache, myalgia, it's all non-specific. But after a while, first 5 days, the fever was usually occurs every 10th hourly. But later, every fifth, exactly by 5th hour, patient will have fever. Once taking paracetamol, it will relieve. Still no other localizing sign. So this were the things that were done outside. Investigations of both for bacteria, virus, everything been worked up, but nothing came out. Culture negative, and they even suspected tuberculosis and other chronic causes like vasculitis or autoimmune, and hence they referred to higher center. The patient reached our center. Here too, we did some blood investigation. Total count was absolutely normal. Platelet was just on the lower side. So we initially, as usual, started with IV broad spectrum antibiotic. Fever was not responding for the first 3 days. We have extensively asked about the details of exposures of any bite or anything. Nothing came out. Any exposure to garden or related to non-specific history of tuberculosis in the family, everything was worked up. But one history that patient told was he received a TV box from his son from Singapore. Once he opened, there was small insects came up. That's the only history. There is no history of bite or anything. But initially, we usually for every fever used to search, but ultimately found a scar in the genitalia, exactly the tip. So this was the only history. So such the importance. Next, another scenario: the 50-year female referred as a dengue with platelet of 50,000. But fever was persistent more than 5 days. That is, up to 7th day, the fever was there. And outside, they had done a dengue CAR test negative, and for us, serology was negative. Any fever more than 5 days in a viral, especially for a dengue, we should always think, because usually counts will fall up to 7 to 8 days. By 8 to 9, it will usually recover. But anything fever beyond 5, should always think of other DDs. So patient had rashes similar to dengue. Microscopic examination for the usual platelets, they usually go for automated analysis. Usually they will have a clumps even on microscope. You can see there is a clumps of platelets. This is one of the characteristic feature of scrub. So this itself give a clue that there may be scrub typhus. In such patient, there is no need for blood transfusion. Even if the platelet is about 20,000 or 15,000, no need to rush for blood. We send sample for scrub typhus and started on doxy. This is another scenario. So this is another case, patient being evaluated extensively in a tertiary care in a multi-specialty hospital in Madurai. Patient was diagnosed as severe sepsis, went in for ventilator on NARAD support, and the patient wants to take home. So hence they referred, not referred, they against medical advice patient went just as a terminal care. Patient landed up in our hospital with this history, 15 days of fever, was rapidly deteriorating coma. His urine culture was initially positive, so they thought it's a urosepsis and they treated with very high antibiotic. This is the previous history. On receiving, we too have patient was very toxic, vasopressor support and on ventilator. But one point that clinches or differentiate is we saw the scar in the scalp, edge of the scalp, probably maybe injury, but still we suspect why can't it be a scrub. They did every investigation, but they left a scrub. That's a point. So, liver enzymes were very, very high as the patient was in sepsis DIC. But still we proceeded initially with the double dose, then followed by BD dosage. We just left the patient and treated otherwise with symptomatically. Patient survived and is an auditor, still living well. So why I need to mention these are some of the different scenarios we usually come up, especially the dengue with low platelet is one of the common diagnosis. DD we should always think is scrub typhus. So why this scrub? It's an underdiagnosed. The problem, this is related to scrub. The scrub is otherwise called as bush typhus. The disease caused by the bacteria presently called Orentia tsutsugashi. And scrub typhus is spreads to people by bite. There is no person-to-person transmission. And in the might bite only in the larval form, usually bites, not the it never transmits through eggs or adult form. The most common symptoms of scrub typhus include fever, headache is similar to other viral illnesses. So this is the endemicity of this disease. We call it as triangle of scrub typhus, extending in the west up to Pakistan and Afghanistan and up to the northern Japan to northern Australia. This is called Sutsukamushi triangle. And as far as India, predominantly these cases usually been reported in many parts of Chennai, especially the border Andhra Pradesh, and usually the patient will land up with PUO. Even fever may last up to 2 months. Patient may kept in ventilator, but still must not have diagnosed. So especially we should always think any patient coming from the triangle which I mentioned, any travelers, any history of farming, camping, hunting, archaeological digs, and Orentia mites are being found in grasslands, so forest exposure, bush areas, wood piles, gardens, and beaches. So any patient with this contacts, and we have reports of unscreened blood transfusion, but very rare as far as India is concerned, and unhygienic needles. But there is no reported person-to-person transmission. So what is this scrub typhus? It has been caused by Orentia tsutsugamushi. It's a mite-borne bacterium. It's a gram-negative bacterium belonging to the family of Rickettsia and is responsible for this disease. It's a natural and obligate intracellular. It lies in the cytoplasmic, not in the nucleus, like Rickettsia, and belonging to the family. The mite family belongs to the Trombiculidae with a genome, very small genome, but very high number of DNA replicates. This unlike other bacterioms, bacteria. And the disease scrub typhus occurs when infected with mite larvae. This is usually by accidental. And this is regarding the history of this Orentia. Previously, the Sutsukami is a Japanese word. Sutsuka means illness and mushi means insect. Etiology, this history dates back to 3rd century, but we don't know the exact etiology. Only by 20th, the etiology of the disease, after 20th century, we came to know about there is some transmission by mite. So mite theory came up by 1908, and 1915, geologists suggested the larva of mite, Microtropinium, may be one of the etiology which is seen in the mice, ear of the mice. And the causative pathogen, that is the bacteria, has been identified by Ayahashi in 2020. And since there is a similarity between the Rickettsia Provosaceae family, this Orantia has been added in 1930. But other colleagues like Akira Tamura, only in 1991, they found that there is a structural difference between Rickettsia and this one, and they proposed a separate genus called Orantia Sutsukamushi. So what's the difference? There is a major difference with other bacteria. Though we call it as a gram-negative bacteria, it is not taken up by gram staining because of its cell wall devoid of liposomoglycan, lipophosphohomoglycan and peptidoglycan. And due to the absence of this peptidoglycan, this drug is totally resistant to beta-lactam antibiotic, which we use routinely. But unlike Rickettsia, which is very sensitive to beta-lactam. And the bacterium is enclosed in a cell wall on the outside and cell membrane in the inside. So it's between cell wall and cell membrane. So the cell covering takes up the stain like Gimsa and Jimenez stains. Although its cell wall is a classical of bacteria, but outer is much thicker than the inner wall, which is seen, which is unlike Rickettsia. Rickettsia, it's totally opposite, but this one outer is thicker than the inner one. And the capsule layer that forms the spherical halo in other bacteria is also missing in our scrub typhus. So there is a much major difference, and other difference are the classical bacterial lipophospholipoglycans like muramic acid, glucosamine, hydroxy fatty acids, heptose, and 2-deoxyoctanic acid is all absent in the cell wall of scrub typhus. And other difference, unlike other bacteria which are easily grown in routine different medias, this Rickettsia grown only in living cells, and especially this Orantia grows specifically in yolk sac of developing chicken embryos, and it cultured cell line such as HeLa, PHK, Vero, and L929. In contrast to Rickettsia, which resides in the nucleus, this Orantia resides in the cytoplasma, and the bacterium is very, very highly virulent, so it cannot be grown in our routine lab. We need at least biosafety level 3 labs for it to grow. So regarding the vector borne, it's a carrier, it's a mite. The mite population that it belongs is Leptotropidium, and there are different and usual, it's been transmitted from female to X through transovarial transmission, and from X to larva and adult is through transstadial transmission. Thus the bacterial life cycle is entirely in the mites. So we are just an accidental host. So infection to rodents and humans are accidental, and especially this Leptotropidium dehiscens is the most common vector. And in different countries there are different other vectors. Especially in India, there is a different mite species called Schwangastilia ligula. This is a different vector as far as India. As far as life cycle of mite, things that we need to know is there is an egg form, then larva, and larva there is pre-larva, larva, and nymph, and then adult. And this larva is the most culprit thing for transmission. Is commonly referred to as chiggers, and are the only ectoparasitic stage. Now it's just comes out. It may either stick to humans or mammals or mites for it to feed. Only once or twice it feeds. So that's the only stage of life of mites that transmit the infection is chiggers. And wild rat like ratas are the principal natural host for this chiggers. So regarding chiggers, It feeds only once in the mammalian host. It may feed up to 2 to 4 days. And in contrast to most parasites, they do not feed on the blood, but instead it sucks with a separate feeding apparatus called a stylostome. With this, it sucks the body fluid through the hair follicles and skin pores. Why this is important? This is where our eschar starts to form, and it releases the saliva, which liquefies that lesion. So this saliva can dissolve the host tissue on the feeding site, so that it's been liquefied. So this is where our Orantia bacteria, which was staying in the saliva, enters our host tissue. So human bites, as mentioned, it's an accidental. We are an accidental host. Generally, it travels through the whole, even legs or hands. Only in the fold, it gets trapped, especially when tight-fitting clothes are there. So usual bite marks we should look for is armpits, waist, ankles, and behind the knees. Occasionally, in our case, even in scalp. So eschar is formed on the skin where the infected might bite. In rare cases, it may be in the cheek, earlobe, and dorsum of the feet. So symptoms, it is usually non-specific symptoms. Hence, the main symptoms of Orantia may mimic malaria, leptospirosis, typhoid, murine typhoid, chikungunya, dengue, and everything. It's a different mixture of symptoms. So usually it will be a misleading. So here the problem arises. Even apart from fever, the rash will be also developed. It's also divert our diagnosis. Eschar is one clue, but that doesn't mean all scrub typhus do have eschar. Only 55% of the disease have eschar. May patient go for pneumonitis, meningitis, DIC, and severe multi-organ failure like our patient. So severe infection can happen, leading on to circulatory collapse, heart failure, and death. So mortality in epidemic typhus is around 10 to 40, but in our scrub, that is due to Prowazaki, but in scrub typhus it is more than 60 if it is untreated. So diagnosis is always, we should have a open mind for diagnosis. So the major factor is the most useful diagnostic clue is the eschar that we should always see in all fever patient. But only in 55% of the patient do have that eschar, and eschar it's not specific for scrub typhus. It may also happen in other rickettsial illness like Rocky Mountain spotted fever, which is uncommon in India, Brazilian spotted fever. And using DNA analysis, we can even classify the subclassification of the rickettsial infection from the eschar. So as far as investigation, the simplest and rapid test is wheel Felix, but we are not using it. The other investigations that have a very good results are immunofluorescence assay, ELISA, DNA analysis using PCR. And ELISA is a technique that we use in our hospital and in most of the hospitals. And IFE is the gold standard test as it gives a reliable result. However, it is expensive and not specific for a different rickettsial. There is a specificity is a big problem. As far as ELISA and PCR, we can specifically detect Orantia Tsutsukumoshi specific proteins like TSA F56 and GROEL, so that they have a very high specific and sensitivity. On the other hand, it is very, very expensive. So only problem is with the diagnosis. Treatment is very, very simple. A single drug doxycycline can do wonders. Even in severe sepsis on multi-organ failure, giving doxycycline can reverse. Only problem is with the pregnant woman and babies where it is contraindicated. We can try azithromycin, but still doxy will be the best. And Southeast Asia, where doxy and chloramphenicol resistance has been there, that especially in some strains of scrub typhus, azithromycin has been recommended, and randomized controlled trials and systemic review showed that azithromycin is also another safest medication. As far as our district, we usually thought it will be around the forest areas, especially Dindakal hills, Nilgiris, and outer parts of Chennai. But even in our district, we have, myself, I have seen more than 100 cases in our hospital in the past 18 months, during the even started in the COVID time itself, and the numbers is steadily increasing probably due to increase in rainfall and increase in bushes. And awareness among doctors are very poor regarding scrub typhus. And usually we have a big uh, doctors who usually large doctors in the rural who usually prescribe steroids, which have worsened the course of scrub typhus. Even the classical features has been masked by using of steroids. And the government notification should be emphasized in all fever cases, especially for scrub typhus. And regarding immunity of this disease, there is no lasting immunity for the scrub typhus. This is a bigger problem with this one. They even tried with vaccination, but it never lasts. In 1950 itself, immunization technique has been tried, but by a year, the infection again develops. So that it is not now known that longevity of the immunity depends on the strain of the bacteria. When reinfection occurs with the same strain as a previous infection, if there is a same strain means it may last up to 5 years, but generally the strain varies, so it never goes beyond 1 year. So immunity is a bigger problem, so we should be very, very careful in handling this disease. So in humans, the immunity declines after 1 year and disappears within 2 years. So the point I need to stress is this one. We need a detailed history regarding exposure, especially bushes or cluster of fever or anything like that. And always search for eschar. Though we cannot see in 100% of the patient, it still give a better clue in treating the patient at the earliest. And the commonest differential diagnosis for dengue is always scrub typhus. It's also presented with reduced platelet count. On seeing clumps of platelets in a microscope is another clue. We should always think of scrub typhus. And if the total count is normal, even having patient continuously have fever, should always still think of scrub, but doesn't means all scrub patient will have normal total count. It may even increase up to 30,000. Atypical fever presentation is also another DD for scrub typhus may present with atypical fever presentation. And considering the atypical presentation of this disease, local physicians and public health officials should be alerted regarding this disease, and because of it's more prevalent than what we previously expected. And once again, thank the organizers for giving me the opportunity and for audience for the patient listening. Thank you.
Thank you, sir. Is there any questions?
Usually up to some studies say even up to 1 month you need to take oxygen. So but generally, as far as my experience, 10 days is more than enough. That's been very well. Still, every week. Yes.
Well, Jasmine, we have quite common disease. We also come across. Actually, when Dean Madam was, previous our college Dean Madam was present, we published a paper about varying presentation of the scrub typhus. 10 cases. One is as myocarditis, another one is encephalitis pump, another one is ARDS. As you said, most of the time there was no scrub, eschar at all. Without eschar also can present as various forms. So what important thing is whenever there is no localizing findings, mild leukocytosis, no leukopenia, low platelet count, we always suspect the scrub typhus. The another one is therapeutic challenge. Suppose if you give doxycycline, the fever disappears immediately, it mostly is scrub typhus. That is also possible.
Eschar.
The problem is it won't respond to cephalosporins. It
Of
won't
course.
respond to
Even
meropenem.
meropenem,
Most
everything
of
has been tried.
the patients are transferable in the corporate hospital.
And I want to ask you all the three, how do you prescribe Doxy? Give orally or IV? If IV, how long you give and when
If
you
it is
switch over?
encephalitis and all life-threatening condition, we can give IV. We tried IV azithromycin rather than the doxycycline.
I think IV doxycycline
Yes,
is
it's
better.
available.
It's also available.
It's available.
I think you can try use the doxycycline IV. No, sometimes there may be a need for IV. Patient, one of my patient came last week, comatose, hiccup, acute kidney injury. We can't give oral. We gave him only IV BD.
Yes, sir.
And he,
IV
within
is
2 days he recovered.
Yes.
Yes.
That is the thing.
Yes.
Whenever you give oxy, immediate response.
And unfortunately, doctors are not looking for scrub
Yes, sir. That's the problem.
under the breast, axilla,
Moisture area.
and genitalia.
Moisture.
Thighs. They look it, definitely they can get an early diagnosis. Thank you.
So thank you, sir. Our both oncologist speakers also speak very nicely, quite informative. When to screen and what are the important care we have to give in post chemo period. Thank you very much.
Thank you, sir. With this, we are coming to the end of Tapicon 2020. I thank the speakers and the chairperson for having chaired this session. I now request the chairperson, Dr. N.K. Sendilnathan, sir, to felicitate Dr. Arun Seshachalam. Dr. Krishna Kumar Ratnam, and Dr. Tirupati. And I request Dr. Tirupati, sir, to felicitate the speaker, Dr. N.K. Sendilnathan, sir. Thank you, delegates, for being so patient till the end. Thank you so much.
With this, we come to the end of all sessions in our Hall B. Kindly assemble at Hall A for the valedictory function. Thank you, sir. Thank you, all distinguished guests. I'm so sorry all these people left.